right? So pay attention, guys, because you really have to be able to differentiate between one thing and the other. Because when they ask you a question in category, like I was telling you the other day, say, shock, all the answers are going to be different kinds of
shock.
They want to know that you know how to tell the what?
Difference.
Right? And you really got to listen today, guys. You really got to listen and try to go ahead and put and understand that pathophysiology together. Because now it's really going to come into play. That correlation between what's going on inside the body and what you
see.
Straight up, guys. That's the way it works. Right? So, guys, pretty exciting lecture today. Right? It all begins. Right? And we're hoping that you guys got a little time to at least start working on your patient assessments. Right? Now, I noticed some people got here early, which was nice, except you should have been working on your patient assessments with each other. Because you guys have to be able to communicate. You got to be able to talk, right? Because that's really what this business is all about. So, my question to you, as it is every day, is...
Are you ready?
It's my question. What did I tell you about premature readiness? Are you ready? Are you ready?
Yeah.
Wow. Again, was that too quick? Was that too quick? Come on, guys. Shock and trauma, real patients, real injury. Are you ready?
Yes.
All right. So what are these all doing on the... Okay. So, here's the dealio, guys. You want to put your phone on your desk? Hey, yeah, I saw that. Okay, the only way you should have your phone on your desk is if you're using this to record the lectures. In which case, it's fine. If you're not, it needs to be off and away. That's what I used to do. Yeah, I saw it. Turn it off. I don't want to hear your pants vibrating, sir. No vibrating pants. All right, guys. As always, the one, the only. Mr. Ritz-Cut. Woo! And... Perfect! All right. Very exciting,
We're missing one.
We're missing one. Did you scare him away again?
No.
Everybody's like, patient assessment. Right? Funny, right?
All right.
Maybe they're just running late.
Yeah, I think it's around.
Maybe they hit something like out of traffic. Hey guys, hey, first skills day tomorrow. Hey, I know we told you this, but I'm going to reiterate. Everybody's got to have a what?
Watch.
That's a watch, not a phone. An actual watch, right? Because you got to take vitals, guys. You're going to need it for your ride along anyways, right? And guys, practice your patient assessments. Oh, yeah. And you have everything that we're doing tomorrow. You should have gone through all that online skills content that we gave you. You know, that online skills content? You know, the one with all the skills on it that you're doing tomorrow? Those things? All right. Enjoy.
Cool. All right, guys. So we're going to go ahead and start off talking about shock. All right, and then we're going to do a bit of trauma overview. So we're going to talk about the most of our traumatic emergencies. We're going to talk about for tonight and Monday night as well. All right, and then Tuesday, okay, we're going to start getting into medical. All right, like I was saying the other day, I can't remember if it was last night or the night before. All right, we like to say that trauma is very what? Straightforward. It's very what?
Straightforward.
It's very what?
Straightforward.
Damn, you guys like goldfish. Okay, trauma is very straightforward, right? So the stuff that we're going to talk about when it comes to traumatic injuries, it's really easy. If I see somebody's guts hanging out, that's only one type of traumatic injury that has one specific type of treatment. If I see a patient's chest is moving opposite directions, that's one specific type of trauma with no treatments. Okay, if I see a hole in somebody's chest and it's sucking, that's one specific type of injury with one specific type of treatment. Okay, that's what we mean by trauma being very straightforward. But when it comes to a medical patient, okay, is there like 2 or 3 things that cause someone to go, oh, my chest hurts and I can't breathe?
Yes.
No, there's a lot more.
Oh.
Okay, there's about 20 things that will cause somebody to have chest pain and shortness of breath. And you have to be able to identify what are the things that cause someone to go, my chest hurts and I can't breathe. Okay, Now, as far as shock, we are going to be blending a little bit of both medical and trauma because shock can be caused both by medical issues as well as traumatic issues. Okay. Now, as far as the overall definition of shock, okay, the overall definition of shock is anything that causes widespread inadequate tissue perfusion. Okay, so the definition of shock is anything that causes widespread inadequate tissue perfusion. Okay, so that's anything that's going to cause inadequate blood flow throughout the entire body.
That was widespread inadequate tissue perfusion.
That's what it was.
Was it? 22 for Saturday.
Okay.
We need another.
I bet you like 12 are going to show up.
We gotta get another.
Yeah.
I'll call them. If
Yeah.
I need to, you let me know.
Alrighty. So, as far as shock, okay, it's anything that causes widespread inadequate tissue perfusion, right? And it's pretty much anything related to the circulatory system. Kind of talked about in the human body, right? We break it down to the pump, the pipe, the fluids. Okay, and if we have any type of problem with the pump, the pipes, or the fluid, okay, that's going to lead to our different types of shock. Now, if I've got a patient who is spilling out a lot of blood in the abdomen due to a organ rupture in the abdomen, sir, what kind of organ would rupture causing blood inside the abdomen?
Spleen?
Which is an example of what type of organ?
Solid?
Solid, because they're full of blood. So that patient would have rigidity, dissension, pain and alpha quadrants, but what skin signs?
The diaphragm? Or maybe also skin signs, maybe discolored? Maybe
How would they be discolored, sir?
Cyanosis, maybe?
Eventually, very, very late, they will be.
Flushness?
No. Sir?
Cool, pale, diaphoretic,
Why would they be pale, cool, diaphoretic?
because all their blood is not anywhere else.
So they're going into what kind of shock?
Hypovolemic.
Hypovolemic shock, right? Because they're losing a lot of blood. Obviously, that is a fluid problem, right? If the blood's not in the circulatory system where it should be, that's a problem, okay? And it's so much blood filling up the abdomen that it's filling up like a water balloon, all right? Now, as far as that type of hypovolemic shock, we call that hemorrhagic hypovolemic shock, and we'll see it later on, okay? But that's specifically due to blood loss. But we can also have, right, fluid loss, not caused by actual bleeding, but by somebody losing all of the water content of their blood. Right, and sir, what is the water content of the blood called? That makes up most of the volume. Yes? Plasma. Okay, so if we got a patient losing a bunch of plasma or the water content of their blood, that too is going to lead to hypovolemic shock. But it's called non-hemorrhagic hypovolemic shock because it's not blood loss, it's just water loss, right? Plasma loss. Okay. We also call that metabolic hypovolemic shock. Okay, so two names for that one particular thing. Non-hemorrhagic, because it's not blood loss, right? But we also call it metabolic hypovolemic shock because they can lose it from metabolic issues, such as excessive vomiting and diarrhea, right? Excessive salivation, excessive urination, excessive sweating. Okay, they can lose all that plasma due to different things, not necessarily caused by trauma. Right? That is an example of one of our types of shock being all of our fluid problems. Okay, as far as our pipe problems, okay, that is called distributive shock. What kind of shock?
Distributive shock.
Right, and there we have widespread vasodilation, right? And there's multiple things that will cause that widespread vasodilation. All right, so we'll cover that. And then we have our pump problems. We have two different types of shock, one being cardiogenic shock, where it directly affects the myocardium. We have another one, okay, that interrupts the job of the heart itself without really causing damage to the heart itself. All right, so those are going to be our four different types of shock, and they're going to be different subcategories within those different types of shock. Right, so for example, hypovolemic, we have two kinds, hemorrhagic, non-hemorrhagic. Right, for distributive, we have four kinds. Cardiogenic is just one. Obstructive, we have three different things. Okay, so there's different factors that will cause different kinds of shock. So as far as the definition, again, anything that causes widespread inadequate tissue perfusion. Okay, so anything that's going to interrupt blood flow throughout the entire body is going to lead to a state of shock. So, for example, if all that blood is spilling in the abdomen, okay, that's not going to allow perfusion throughout the entire body, hence why patients go into shock. Okay, patients who have really bad heart attacks, okay, if the heart is not pumping blood around the body, blood can't get around the body, now the patient's going to go into shock. All right, and when that happens, the body starts to become acidotic. Starts to become what?
Acidotic.
Okay, because we have all these nasty byproducts start building up, things like CO2, lactic acid, and other bad acids. okay, that our body can't very easily get rid of. Acidosis then leads to tissue death, which leads to organ death, and then eventually
Patient death.
patient death. All right, now when it comes to recognition of our quote-unquote classic signs of shock, Miss, what are the quote-unquote classic signs of shock? Miss, what are the quote-unquote classic signs of shock? Yes?
Your sympathetic nervous system.
What about it?
Your blood pressure increases.
Okay.
Heart rate increases.
Okay.
Pupils dilate.
Okay. But that also happens to just stress itself, right? So for them, for example, they would have a little bit of that stuff too. They'd have a little bit of hypertension, their pupils would dilate a little bit, their heart rate's going to go up a little bit, but that's just sympathetic stimulation. But as far as the fact that I can tell they're going into shock, what are the classic signs that we're going to see?
It's a dual pale skin.
Okay, cool, pale, and
Diabetic.
okay,
Not breathing enough.
sure. So you have pale, cool, diaphoretic skin. What else would let me know this patient's in shock based on the quote-unquote classic signs?
I'm not sure.
Sir? Sir?
Altered level of consciousness.
Well, eventually, much, much later. But what else?
At the moment, I can't tell you.
Sir? No? Sir?
Trouble breathing.
I'm sorry?
Trouble breathing.
Okay, but again, that just goes with tachypnea.
Like,
How would I know in the context of a patient assessment? Let me rephrase it. How would I know in the context of a patient assessment a patient might be in shock? So they're going to have pale, cool, diaphoretic skins. What else?
altered level of consciousness.
Sir?
Low levels of oxygen.
Nope. Sir?
I was gonna say the same thing.
Miss?
When you do the pictures.
Okay, so what's the cap refill going to be like? Immediate or delayed?
Delayed.
Right. They'll have delayed cap refill. What else?
Weak
I'm sorry?
Ready heart rate.
What does thready mean?
Weak and a bit fast.
A bit fast.
Or very fast.
Okay, so rapid and weak. Okay, so the patient will have a thready pulse. So they're going to have pale, cool, diaphoretic skin. They're going to have delayed capillary refill as well as a thready pulse. What kind of pulse?
Thready.
What kind of pulse?
Thready pulse.
Right. And Miss, under which letter in my assessment would I actually determine that they're in shock? Okay, so if you spell those letters out. Circulation, right, as you go through a cough's mnemonic. Okay, and again, this is all patient assessment stuff, so now, again, things are going to start snowballing, guys. Okay, you have to use your patient assessment to identify what's going on with your patient. Okay, so if I got a patient who I checked their delayed cap refill, okay, by itself, because it's the only thing I've checked in circulation, doesn't tell me much, but when I see it with a rapid and weak pulse and they're pale, cool, and diaphoretic, crap, my patient's showing signs of?
Shock.
Signs of?
Shock.
Signs of?
Shock.
And what does that do to your patient? Kills them. So if we see it, we
Treat
we
it.
see it, we
Treat
we
it.
see it, we
Treat it.
So, Miss, how would I treat a patient who's in shock? So I can't hear you.
A blanket over.
Okay, so we cover them with a blanket. What else? I can't hear you.
Make sure they get oxygen.
Okay. And?
And make sure that they have a pulse.
Well, no, because if they don't have a pulse, then they're dead and we're not worried about shock. Miss?
Proper positioning.
All right, proper positioning. Okay, so O2, blanket, and proper positioning. So if our patient's complaining of respiratory distress, what position would I want them in?
Fowlers.
What if they have a spinal injury?
Supine.
Which is?
On their back.
Okay, and what if they don't have either of those issues? What position could I possibly use?
Whatever their comfort.
Nope, don't care about their comfort. Sir, what position would I use? If they're in shock with no spinal injury and no shortness of breath.
Shock position?
Shock position. And what is shock position, sir?
With their feet 6 to 12 inches high.
Okay, but
And their head. I forgot that one.
Maybe the Fowler's position, where 12 inches.
so I'm going to bend my patient into a V. No, so then what position?
Supine.
Right. Okay, so we'll keep them supine, right? Lay them flat on their back, but I elevate their feet. How high?
6 to 12
How high?
inches. 6 to 12 inches.
Why do I want to use that position, sir?
So, we can get blood that are in the lower extremities to the heart.
Right, so we can get that blood in the legs back into the core of the body where we need to maintain that core perfusion. Okay, again, it's not some rote, mindless memorization that we have to follow. Well, my instructor said if they're in shock, I use shock position. Because if you do that, then you're not applying your critical thinking, and then you're going to compromise your patient by either lifting up their legs with a spinal injury or laying them down if they got respiratory issues. Or if somebody were to ask you, hey, why are you doing that? Well, I don't know, right? Which is not going to be a viable excuse. Okay, we're saying, hey, we got to bring that blood from their legs back to the core of the body to maintain core perfusion. Because they're in shock, which means they're suffering from
Widespread inadequate tissue perfusion.
right. Okay, we're going to try to fix that whenever possible. Now, as far as patients who are in shock, again, they will become acidotic. Okay, so we want to try to maintain as much perfusion as possible to hopefully get rid of a little bit of that acidosis, or at least prevent it from happening in the first place. Okay, and when it comes to the treatment of shock, there's really nothing we can do in the field in most cases of shock where we actually stop it and reverse it. Okay, what we usually do is stop it and keep it from getting any worse. We basically put pause on shock, right, while they go to the hospital and they can get everything else fixed to actually reverse and cure the actual shock itself. Okay, so we need to identify it and take care of it right then and there, because as it goes on and on and on, they're going to progress through different stages of shock that we'll talk about after we talk about our types of shock, right? Because that'll let us know that, okay, this patient's compensating, so we got a little bit of time, or oh shit, they're decompensating, right, and they might die, right, without me knowing if they're actually going to the last stage of shock, which would be irreversible. Okay, so once we cover all of our different types of shock, then we go into stages. Hey, they're either compensating, decompensated, or it's too late and they're in irreversible shock. And you have to identify not only what kind of shock they're in, so we know how to treat it, but identify what stage of shock they're in so we know how urgently we have to treat it. But usually, once we see it, we treat it. We take care of it right then and there. Now, as far as Fick principle, okay, the Fick principle states that air goes in and out, blood goes round and round, and tissue gets perfused. Okay, which is common sense when you think about it. Oh yeah, I need to breathe in and breathe out so my tissues get oxygen and get rid of CO2. My blood's got to pump around my body so I can move that stuff. Yeah, that makes sense. Right? But if I have anything that interrupts air going in and out or blood going round and round, is that going to cause a problem?
Yes.
Yeah. Okay, and that too leads to our pump, pipe, or fluid problems. Okay, if the heart is jacked up, okay, is the heart able to pump blood around the body? No. Okay, as far as blood vessels being fully dilated, if the vessels are fully dilated, do we have enough blood in our body to keep a decent pressure?
No.
No, and that's where we get all of our distributive shock problems, because we have poor peripheral vascular resistance to our blood pressure tanks, and we, as adults, are reliant upon blood pressure to maintain perfusion. So shitty blood pressure equals shitty perfusion, which then equals shock. Okay, air going in and out. Okay, we'll talk about one of our obstructive shocks, okay, where that can interrupt airflow, right, as well as the interaction of air and blood mixing together. Okay, so it all boils back down to the Fick principle. Now again, a lot of things in medicine are named after the people who discovered it. So this guy Fick, way back in the 1800s, where they didn't know anything, so that's why a lot of people name shit after themselves, because they can discover it. Right? He came up with diffusion as well, in addition to the principle, right, named after himself. Big ego on this guy, right? But again, he stated that, things going from high concentrations to low concentrations, passing through a semi-permeable membrane, that's diffusion. And I'm going to name it after myself. Right? He also figured out cardiac output. Now, as far as the formula that we use for cardiac output, right? Sir, what is the formula we use for cardiac output?
Is it SR?
Which, it's not SR. That's something.
Something times heart rate
Okay.
equals output.
Uh-huh.
No.
Sir?
It's stroke volume times heart rate is equal to cardiac output.
Exactly. Okay, the stroke volume, which is the amount of blood the left ventricle pushes out per contraction, okay, we multiply it by the heart rate, and that's where I get the cardiac output. There's no way of us knowing what the actual cardiac output of our patients are in the field because I don't have a way of measuring stroke volume. Okay, we can't say that, oh, every time the heart contracts, there's 65 mLs of blood that's getting pumped out. Oh, that last one was 68 mLs. Oh, this one was 60. We don't have a way of knowing that. Okay, but you at least have to understand the theory and the concept behind cardiac output, right? The heart has to push out enough blood per contraction. The heart has to pump a certain times per minute to make sure that we're able to get blood going around the body, right? And cardiac output also has to go in blood pressure. Don't ask me how they calculate it. I don't know, right? But basically that goes in with it to determine if we actually have decent blood pressure to therefore maintain perfusion for us adults. For kids, because kids are freaks, okay, right? Because kids are freaks, they simply rely on cardiac output. They just have to move that blood as quickly as they can around their body, and that's why they have faster heart rates and faster respiratory rates when compared to us adults, right? Because they don't care about blood pressure as much as we do. They just have to pump that blood around the body and keep it full of oxygen. Now, as far as our perfusion triangle, okay, it goes down to the three parts of our circulatory system. The pump being the heart, the pipes being the blood vessels, and the fluid being the blood. Right? Now, within these different types of circulatory parts, okay, if they start failing, that's going to lead to its own specific type of shock. So, for example, if we have a fluid problem, that's what kind of shock?
Blood.
Yeah,
Blood.
hypovolemic. Okay, and again, we have two subcategories of hypovolemic shock. We have hemorrhagic, which is them just straight up bleeding out, and we have non-hemorrhagic, aka metabolic hypovolemic shock, which is loss of plasma, which again is the water content of their blood. Okay, generally caused by non-traumatic issues: vomiting, diarrhea, excessive urination, salivation, sweating. Okay, so we have to try to figure out, okay, what's causing my patient to go into shock? Do I suspect they have any internal bleeding since I can't obviously see it? Or, yeah, they lost their arm, so they're spilling out a bunch of blood on the floor, right? Either way, they're still losing a lot of blood, being hemorrhagic hypovolemic shock. Or, hey, is this patient suffering from heat stroke, which would be considered a form of metabolic hypovolemic shock, right? In the case of kids, okay, because kids have a lot of episodes of vomiting, diarrhea, right? Has this kid been sick for the last few days? Have mom and dad said they've been throwing up 4 or 5 times a day for the last 2 days? Okay, what is causing this person to go into shock? Right, versus our distributive shocks, our pipe problems. Okay, we can tell it's a distributive problem in most cases because they would have vasodilation going on. We'll see flush skin. Okay, so as blood vessels dilate, okay, that blood is going to start going to the skin, giving them more of that red or flushed appearance. Right, now of course, do I focus on similarities or do I focus on differences? Differences. Okay, now the differences will obviously tell me what it is, right? But I can group it down. Okay, so these things are different from the others, but they're all similar in the sense that they're going to be in the same category. So for example, all of my distributive shocks, most of my distributive shocks, will have flush skin. Okay, now it doesn't tell me necessarily what type of distributive shock it is, but it tells me it's a form of distributive shock. I know it's not a cardiogenic problem. I know it's not a hypovolemic problem in most cases. Right? I know that it's distributive. Okay, and we'll talk about how to actually identify the differences between those different distributive shocks. As far as the heart, okay, we have 2 different types of shock that relate to the heart. We have cardiogenic shock and obstructive shock. With cardiogenic shock, okay, that is when we have massive damage to the myocardium, which is just a fancy word for the heart muscle. Okay, and that's going to happen when the patient suffer pretty significant AMI. AMI standing for acute myocardial infarction. Okay, so those that are having an AMI, right, or acute myocardial infarction, Right? If it's bad enough, they will go into cardiogenic shock. Because the heart is having so much damage that it can't pump blood around the rest of the body, therefore causing a state of widespread inadequate tissue perfusion. All right, the other form of pump problem will be obstructive shock, where the heart itself is usually not damaged, but the heart can't do its job. All right, we've already talked about one form of obstructive shock. We just didn't really classify it as obstructive shock, but we've already talked about it. All right, that, of course, being a tension pneumothorax. All right, now as far as a patient who has a tension pneumothorax, all right, miss, what is a tension pneumothorax?
That's when there's like alcohol, sugar,
In the what?
there's air in potential space.
I'm sorry, in the what?
There's air in the potential space.
I'm hearing it, but I'm not seeing it. In the what?
There's air in the potential space.
Yeah, I don't see it. In the what?
What?
I don't see what you're saying.
Oh my goodness.
Yes.
That's vague.
Yes. Is it a little bit of air or a lot of air in that
No,
potential space?
it's a lot.
It's a lot of air. So how much air?
A lot of air.
In there?
Potential space.
In there what?
Potential space.
Right. So much air that things are starting to shift. Can I see the shift happening inside of my patient? No. But can I see signs of the shift happening inside of my patient?
Yes.
Yes. What are those signs that we're going to see to indicate a tension pneumothorax?
Your tracheal
Tracheal what?
shift.
Okay. So tracheal deviation. What else?
JVD.
Which stands for?
Jugular vasodilation.
Nope. Sir, what does JVD stand for? What does JVD stand for, sir? What does JVD stand for, sir?
JVD, jugular vascular. JVD. I know that much.
Sir, what does JVD stand for?
Regular vein distension.
Right, jugular vein distension. Okay, and what else do we see to indicate a tension pneumo?
Subcutaneous, is it, I don't know how to say it, emphysema?
It's emphysema.
Emphysema.
And what is subcutaneous emphysema?
Air pockets buildup,
Where?
near the jugular.
Not necessarily.
Can I say throat?
Not necessarily.
Okay. Potential space?
No, it's not in the potential space because that's a pneumothorax. Sir, where's that air building up with subcutaneous emphysema?
Above the fatty layer?
Not above the fatty layer.
Underneath the fatty layer?
Not underneath the fatty layer.
On the layer of fatty skin.
In the fatty layer. Where is it?
In
the fatty layer.
Right, it's building up in the fatty layer of skin. Subcutaneous is the name for that fatty layer of skin. Emphysema means trapped air. What does it mean?
Trapped air.
Right, so it's literally trapped air in the fatty layer of skin. So when I go to palpate, what kind of sensation do we get?
Snap, crackle, pop.
Right, we get that snap, crackle, pop, okay, as we're pushing down, popping all those little tiny air bubbles. All right, so we're going to see those signs in the patient's neck to indicate that, crap, this dude's got a tension pneumothorax.
I'm sorry, can you repeat the three?
Mhm.
You said JVD,
Subcutaneous emphysema,
emphysema.
yep, and tracheal deviation. Okay, now with tension pneumothorax, the reason why we get JVD is that poor little heart is getting smashed in between the lungs as everything begins to shift. And as that poor little heart is getting smashed, can it refill with blood?
No.
No. So therefore, blood starts backing up to the jugular veins, giving them a JVD. But because blood can't go in, a lot of blood can't go out. Okay, which is going to lead to a state of widespread inadequate tissue perfusion because the heart's stroke volume, the amount that comes out per contraction, is starting to tank. Again, the bigger the stretch, the bigger the squeeze. The heart can't stretch out very much, therefore it can't squeeze out very much either per contraction. Okay, and that's going to be one of our three major causes of obstructive shocks that we'll, of course, be going over later. All right, but that's what, number 4 or 5 now that we've talked about tension pneumothorax? Okay, so that's just an overview of all of our different types of shock. Of course, we'll be going through talking about them a bit more specifically, how to identify them, and of course, once we see it, how do we
Treat it.
So as far as the circulatory system, okay, as far as the blood vessels are concerned, okay, they're lined with a very special kind of muscle, right, sir? What kind of muscle?
Can you repeat the question?
What kind of muscle is the blood vessels lined with?
Smooth muscle.
Where do we control that smooth muscle?
In the brainstem vasodilation, or is it vaso?
Vasal is part of it, yeah, but what center?
I don't know.
Sir? What center in the brainstem controls smooth muscle?
Cardiac center?
Nope. Miss?
What was the question?
What part of the brainstem controls smooth muscle? I'm sorry?
The medulla?
Nope. Again, we're keeping it simple. No fancy Latin. Don't summon demons in my class, please. Miss? No. Miss? Sir? Sir? I told you guys, you got to get this brainstem shit down, because when we talk about head injuries, you're not going to have a fucking clue as to why we're going to see what we see for a specific type of head injury and a complication of it. Sir?
The vasomuscular control center.
Close, but not quite.
Vaso. Circulating. No.
Sir?
Vasomotor.
Vasomotor. Okay? It's the vasomotor center in the brainstem. Okay? Motor just means movement. Okay? So the vasomotor center is going to control movement, constriction or dilation, right, of muscle around the body. Okay? So in the case of the blood vessels, right, in order to maintain perfusion, are they going to constrict or are they going to dilate? Are they going to constrict or are they going to dilate to maintain perfusion?
Constrict.
They're going to constrict. There we go, finally. Okay, they're going to constrict, right, to try to move that blood from the extremities and in the skin to the core of the body to maintain perfusion of all the important stuff we have here. Okay, so that's going to happen. Now, as far as our distributive shocks, again, that's a widespread vasodilation problem. Okay, which means now we're taking that blood away from the core, therefore causing inadequate perfusion. Okay, and we have to understand why are these patients going to have vasodilation as opposed to vasoconstriction if we're trying to maintain perfusion. Okay, and we're going to recognize that by the fact that we'll have flush skin. All right, now as far as the hormone that's going to cause all this stuff to occur, right, what hormone is going to cause all this to occur? Adrenaline. Okay, so the adrenal glands, our little kidney hats, okay, are going to start dumping adrenaline into the bloodstream, right, causing us to kick that sympathetic response, get into that fight or flight. Okay, so it's going to cause vasoconstriction. It's going to cause the airway to dilate, so we can suck in more oxygen per breath. All right, it's going to cause us to start getting a little sweaty to cool down, since we run better when we are colder. All right, it's going to cause pupillary dilation, all that stuff. All right, all the stuff that we see as we kick the sympathetic response. Now, between sympathetic and parasympathetic responses, which one do we prefer to be in?
Parasympathetic.
Parasympathetic. Okay, because again, in the parasympathetic state, we're intaking energy, right? Whereas in the sympathetic, we are expending that energy. Okay, but they're total opposites of one another. If one does one thing, the other's going to do the opposite. Okay, so in the case of sympathetic response, again, we dilate our pupils, try to let in as much light and information as we can. Okay, we're not going to be salivating as much because I'm not worried about digesting food. I need to get the hell out of there, right? We're going to go and increase our heart rate. We're going to open up our bronchi so we can suck in more air. Okay, the gastrointestinal tract is on pause because I'm not worried about digesting food, right? The liver is going to start putting out stored forms of glucose, giving us more energy for that fight or for the flight. Adrenal glands are dumping out adrenaline, causing all this to occur, and we lose control of our bladder. Okay, but everything is going to be the opposite in the case of parasympathetic. Now, when it comes to patients who suffer spinal cord injuries, if they sever their spinal cord, okay, they can no longer kick their sympathetic response below the point of injury. Because in order to kick your sympathetic, you've got to communicate with your what?
Brain.
With your brain. Okay, and if you cut that cord, there's no more communication between the brain and the body. So we end up getting a very specific presentation that we call two-tone. What do we call it?
Two-tone.
Two-tone, because above the injury, where they can still activate their sympathetic, they'll have one type of appearance, we'll talk about later, right? Whereas below the injury, because they can't communicate with their brain, they have another type of presentation. Okay, and we can see that exact spot where the spine is broken, okay, based on where the skin signs will change. Okay, but it all comes back to understanding your anatomy and your physiology. Okay, why do I see those different things? It's simple. They sever their cord, the brain ain't talking anything below the the point of injury, and they're going to default to this parasympathetic state. Okay, now the reason why they default to a parasympathetic is because of this third nerve we didn't really talk about in the human body, but that being the vagus nerve. Okay, the vagus nerve is the 10th cranial nerve, which means it originates from the brain. Okay, and that cranial nerve, right, is going to start coming out of the brain and it goes through the body, and it controls the parasympathetic response. So when our patient suffers a spinal cord injury to the point where the cord's been severed, that vagus nerve essentially acts as a detour to go around that broken part. But the vagus nerve can't carry sympathetic stimulation. It only carries parasympathetic responses. Right? That's why patients who have high spinal cord injuries, right, to their neck, as long as it's below C3, 4, and 5, because if it happens at or above C3, 4, and 5, right, miss, what nerve gets knocked out? Back.
3, 4, 5 is the thoracic.
Nope. Miss. If they have a fracture or an injury at or above cervical vertebrae 3, 4, and 5, what nerve did it get taken out?
That's the big one that goes through the brain, right?
No, it's not the big one. That's the spinal cord.
The
Miss.
phrenic nerve?
The phrenic nerve. And what does the phrenic nerve control?
It controls the fight or flight,
Nope. What does it control?
The movement of your diaphragm.
Right. It controls the diaphragm. Okay. Does it control rate or tidal volume for breathing?
The tidal volume.
Controls the tidal volume, right? How much air we can suck in and out per breath. So if they got a high spinal cord injury at or above C3, 4, and 5, they take out that phrenic nerve, they're not going to what?
Breathe.
They're not going to breathe. And if we don't provide immediate ventilations for them, what's going to happen to them?
They're gonna die.
They're going to die because they simply cannot breathe. Okay, as far as the rate of our breathing, sir, what controls the rate of our breathing?
The respiratory.
The respiratory thing?
I forgot the name.
You're right, it's the respiratory, but respiratory what and where?
I forgot the
Okay, well, you don't know where it's located?
in the brain.
What part of the brain? It's very vital that you know this, sir, because it controls your vitals.
I forgot.
Sir?
I'm not sure.
Sir?
The respiratory control center,
Which is located in the
brainstem.
in the brainstem, right? Again, all of our vitals, okay, are going to be controlled and regulated by the brainstem. Respirations are obviously no exception. They have their own control center, right, being the respiratory control center. Now, in healthy patients, sir, how is it going to set the rate of breathing in a healthy, quote-unquote, patient?
Through its primary chemoreceptors,
Which are measuring levels of
carbon dioxide
or other,
stuff.
like,
Acidic.
right, other acids.
Acid.
Okay, and if we have an increase of acids, what happens to our respiratory rate?
You start breathing faster. It
You try to
rises.
get rid of more.
acid.
That's it. Okay, 1-to-1 correlation, right? The brainstem saying, hey, we're way too acidic, we got to blow this shit out. So now the patient's going to start breathing more quickly. Okay, whereas primary or the secondary chemoreceptors that measures levels of oxygen, again, there's only one patient, we'll talk about that next week. Okay, they're now looking at levels of O2. All right, so as far as the different parts of the brainstem, again, controlling different parts of the vitals, we got to know that stuff because when we talk about head injuries, again, later on tonight, okay, there's going to be a direct 1-to-1 correlation of what happens with brainstem injury and how it's going to change the vitals. Okay, and again, this is why I told you guys starting Tuesday, you've got to get this crap down. All right, now as far as smooth muscle in the blood vessels, again, that's regulated by our vasomotor center. So it's going to tell the blood vessels to constrict or dilate as needed. Okay, now the smooth muscle in the blood vessels, right, they're lazy. Okay, what I mean by that is they want to open up and relax whenever they have the opportunity to do so. Okay, in order for them to actually constrict, the brain has to tell them to constrict. Okay, so your vasomotor center has to constantly send signals to your blood vessels to say, hey, you got to tighten up. Okay, and as soon as that thing goes away, the blood vessel's like, cool, open up, right? And we have widespread vasodilation problems, which will then lead to forms of shock. That's why patients who have a spinal cord injury are going to have this specific presentation below the injury versus another one above the injury, because below the injury, they can't communicate with the what?
Brain.
With the brain. Okay, and again, the brain has to tell us to vasoconstrict. All right. So, as far as our quote-unquote, or actually what's going on with shock first, it's a neuroendocrine response. So again, both the endocrine and the nervous system are working together to try to fight off shock. Okay, but I can't really have one without the other. The endocrine system has to release what hormone? Adrenaline, where the nervous system goes, oh shit, there's adrenaline in here. Okay, now we got to start kicking the sympathetic response. right? And if we don't have, right, the nervous system being able to function, like in the case of a spinal injury, okay, the nervous system doesn't detect the adrenaline and doesn't do anything about it. All right, so we need to see that going on, okay, where both the endocrine system and the nervous system are working together, therefore causing the classic signs of shock. Yeah.
So the shock only happen when the nervous system can't recognize what the endocrine system's telling it?
No, that's
or
not.
It's just when there's inadequate.
That's it. Yeah, because the nervous system will still try to combat it. That's why we see those classic signs, right? But in the case of that one type of shock that I've been mentioning, right, it can't detect it because it's not getting any signals from the brain.
Oh, okay.
So basically, that part of the nervous system is out of action. Right? Now, as far as breaking down shocks, okay, kind of what I was getting at earlier is you want to break it down to smaller subcategories. Okay, and that's what you guys should do for a lot of the stuff in class. Okay, is break it down to more smaller, digestible, bite-sized pieces, and then you can start building it back up from there. Okay, understanding and paying attention to the differences for each of these different things. Okay, so for example, shock, right? One big thing is widespread inadequate tissue perfusion. Okay, well we can break it down to different categories, right? Different problems. Pump problems, pipe problems, or fluid problems. And then from there, I can break them down. My pump problems, I have 2 different types of shock, right? So break it off. And then obstructive shock, I can further subdivide into 3 different things. And then from here, I'd write out, for example, a flashcard for all my signs of attention pneumo. Tracheal deviation, JVD, subcutaneous emphysema. Why does it happen? Any possible treatments? I'd make another flashcard for cardiac tamponade. What is it? What are my signs? How do I treat it? All right, same thing for pulmonary embolism. What is it? How do I treat it? How do I identify it? Okay, so you almost want to branch it down. That way you can make an individual flashcard or whatever you want to use to study for each individual thing, and then we can start building it back up again. Okay, I know these 3 things are all part of obstructive shock, which is a pump problem, which is a type of shock. And then we can go and understand the differences between them as well, right? Because, of course, these are all forms of obstructive shocks, right? But how do I tell the difference between them? Okay, or other things, for example, right? Especially when it comes to our distributive shocks. Okay, the distributive shocks are the ones you guys always confuse, either between each other, or you don't understand why we see those specific signs or symptoms and why we have to treat them the way we have to treat them.
Is there any correlation between septic shock and sepsis or no?
Yes. We'll get to that in a bit. All right. Now, as far as our distributive shocks, got me saying septic. All right. As far as our distributive shocks, okay, we break it down to the 4 categories, and I use the mnemonic of SNAP: septic, neurogenic, anaphylactic, psychogenic, right, to break it down. Right. So, as far as commonalities, the one thing they will all have in common is widespread vasodilation. Okay, they're all going to be pretty much widespread vasodilation problems, which means they're all going to have flush skins for the most part. Okay, now the flush skin doesn't tell me what type of shock it is necessarily, but at the very least, I know it's a distributive problem. I know it's not a cardiogenic issue. I know it's not a hypovolemic issue in most cases. Right? I know that it's going to be a distributive problem. Now, of course, there's always exceptions to the rules. Okay, so it's never going to be clear-cut 100%. It's always going to be this. But for the most part, flushed will equal distributive problems. All right, now as far as our hypovolemic problems, we have hemorrhagic and non-hemorrhagic, aka metabolic hypovolemic. So hemorrhagic shock is caused by straight-up blood loss, right, where they're losing everything in their blood. Whereas non-hemorrhagic is not blood loss, but they're losing what component of their blood?
Water.
Plasma or water, right, which again makes up most of the blood volume. So if you lose a lot of the volume, it's still technically hypovolemic, it's still low volume, but they still have their red blood cells, their white blood cells, their platelets. They don't have the stuff that it's all floating in.
Would that be metabolic shock?
Yeah. Non-hemorrhagic and metabolic hypovolemic shock are the same, just different names for them. Right. So, as we go through the course of the lecture, right, for this particular chapter, we'll be breaking it down, the different types of shocks, different causes, different treatments, and of course recognition. And then once you talk about the different types, then we go into different stages. Okay, is it an early, moderate, or late stage of shock? So when it comes to our quote-unquote classic signs, okay, the reason why I've been saying quote-unquote classic is because not all kinds of shock are going to show pale, cool, diaphoretic skin, thready pulse, delayed cap refill. Okay, they will vary depending on the kind of shock that the patient's actually going through. Now, the one common thread amongst all of your types of shock, regardless of what it is that thready pulse. Okay, the one common thread amongst all of your types of shock is that thready pulse, that rapid and weak pulse. Okay, well, at the very least, tell me they're in shock, and then I just have to determine what kind of shock are they in and what do I got to do about it. Okay, they're not all going to be pale, cool, diaphoretic. For example, my distributive shocks, okay, are they pale?
Yes.
No.
Oh, no.
No. It's a vasodilation problem, so they'd be what color?
Flush.
They'd be flushed. Okay, so again, for my distributive patients, they're not going to be pale. They're going to be flushed. Right? As far as the moisture, sometimes they're dry, sometimes they're wet. For the color, sometimes they're hot, sometimes they're warm, sometimes they're cool. Okay, so it really depends on what's happening to our patient causing those different skin signs. All right, so not every single patient who's in shock will be pale, cool, and diaphoretic. As far as cap refill, again, cap refill by itself doesn't mean anything to us, but when I see with other signs and symptoms, is it then relevant? Yes. All right, then it will tell us hey, something's definitely going up with this patient. Right? But again, cap refill can be affected if you're cold or if you're old. All right, so geriatrics, they're going to have delayed cap refill just because they're old. Right? Hypothermic patients are going to have delayed cap refill because they're cold. Right? So by itself, it doesn't mean much. But again, when I see it with the rapid and weak pulse, or I see it with the pale, cool, diaphoretic skins, or anything else like that, then that's a problem. All right, now as far as our most basic kind of stereotypical form of shock, that is going to be hypovolemic shock, more specifically hemorrhagic hypovolemic shock. Okay, so that is going to be caused by straight up blood loss, either internal or external, right, but losing everything in their circulatory system. Okay, so we have to try to determine, was there a mechanism of injury, which tells me is what type of patient, trauma, or was it a nature of illness, which tells me is what kind of patient?
Medical.
There we go, finally. Right, where it's a medical patient, okay, based on why they're losing blood. Right? Yes, medical patients can lose blood. It's not just trauma that causes blood loss. Okay, especially if our patient has some type of gastrointestinal bleed. It happens a lot in geriatric patients, okay, where they will actually start bleeding inside of their gastrointestinal tract. All right. Now, as far as our metabolic hypovolemic shock, aka non-hemorrhagic hypovolemic shock, okay, that's a straight up loss of plasma. So we can have it from patients who have excessive vomiting or diarrhea, which is very common in pediatric patients, okay, because kids get sick a lot. Right? Patients who have excessive salivation, usually we'll see that with like nerve agent exposure and things like that, where they're drooling that much. All right, patients who have suffered thermal burns. Okay, we'll talk about burns on Monday. Okay, but if you guys have ever seen or had a burn that started to blister up, right, that blister is all full of plasma from our blood. So it's shifting out of our blood into that area and not where it's supposed to be, and that'll eventually cause a loss of volume in our circulatory system. Okay, full thickness burns, they basically have all that fluid cooked, right, where it's no longer usable fluid. Right, heat stroke patients. Okay, they too are going to go into metabolic hypovolemic shock. Now that's one of the exceptions where I see flushed skin in a non-distributive problem. Okay, so with heat stroke patients, they will be flushed, they will be red, but it's not a distributive problem. Right, that's just basically from overheating. And if you think about it, what color do you associate with hot?
Red.
Red. Right? That's why you can also think about it for peritonitis. Hey, they're burning up, they're trying to cook out the infection, that's why they're flushed, because they're vasodilating to cool off a little bit. All right, now when it comes to treatment of shock, especially our hypovolemic shocks, it's your basic standard shock treatment. O2, blanket, proper positioning. Okay, we definitely want to give them high flow O2. Depending on the kind of shock and what's going on with the patient, we may or may not want to use a blanket. So for example, with a heat stroke patient, okay, they're going to be hot to the touch. So do you want to cover them with a blanket? No, because you're going to cook them even more. Okay? But if they're losing a lot of blood and they're pale, cool, and diaphoretic, would you want to cover them with a blanket?
Yes.
Yeah, because I want to try to preserve that body heat. Because they're cool to the touch, right, I want to try to prevent hypothermia as much as I possibly can. right? And then we have to use the proper position. Okay, what is the most appropriate position for my patient to not make their problem even worse? Now, the patients may have sustained a spinal injury, depending on what the issue is, right? So we may have to consider supine, right? They may have some type of issue causing respiratory distress, where we may have to put them Fowlers. And if they don't have any one of those, then I can use what position?
Shock position.
Shock position, right? Where we elevate their feet how high?
6 to 12 inches.
While they're in what position?
Supine.
While they're in a supine position. Okay? If there's any type of external bleeding that we see, of course we see it, we treat it. So I want to apply direct pressure first. Second step, we elevate and wrap. And if that doesn't work, then we apply a what?
Tourniquet.
Then we go for a tourniquet. Okay, so I do want to stop any bleeding. Calling for ALS is not a treatment. Okay, you guys always do that, like, oh, I'm going to call for ALS. That's not a treatment. Okay, so something we do. Right, but ALS is going to go in and they can replenish fluids with an IV. All right, so at least I want to get them coming over here where they can do more for the patient, but that itself is not a treatment. All right, and then we're going to reassess their vitals every 5 minutes because is this patient critical or stable?
Critical.
They're critical. Right, they're freaking dying, so we want to reassess their vitals every 5 minutes to see if they're getting worse or if they're staying about the same, or in the off chance they just so happen to actually be getting better. All right, if we are worried about spinal injuries, well, again, we'll go ahead and maintain that as needed, and we'll talk about that more later on tonight. All right, now as far as some old school kind of treatments for shock that we still have to talk about per the national training standard, because some places apparently still use this thing, okay, it's pneumatic anti-shock garments, sometimes referred to as military anti-shock trousers. Okay, again, a lot of EMS comes from the military. So what these are, they're essentially inflatable pants that we put on the patient. Very stylish. Okay, but what they're going to do is they're going to fill it up with air, and they're using that air pressure to help the body do what the body normally does, which is shunt blood from their legs and bring it back where? To the core of the body. Okay, so they go and inflate these pants. It starts squeezing that blood from the legs back to the core to maintain core perfusion. And because of that pressure, we're not going to have a lot of blood flow going down to the legs. It's all going to stay here. Right? Now, they did this stuff back in like the 90s and stuff like that. So again, way back when. All right? And they found out that patients were actually doing pretty well when they had these things inflated and they were used properly. Okay? It did do what it was supposed to do, bring blood back to the core to maintain core perfusion. But as soon as they took these things off, and if they didn't do it correctly, we have all this dirty, nasty, acidotic blood from their legs, whatever wasn't squeezed out, that now gets pumped back into circulation. Okay, and now we have all this acidosis affecting the vital organs here. And the organs got used to having all that pressure, like, oh, cool, everything's back to normal, and everything's gone. All right, so these patients, if they weren't taken care of or taken off these things properly, would crash, right, and die super duper quick. So what they have to do, or what they had to do, is very, very slowly release the pressure from these pants and introduce a pH buffer to reduce the acidosis coming back into their body, right? And sometimes doctors didn't have the patience for it or just didn't know how to do it properly, right? And they killed more people than they probably saved with these pants. So like, ah, shit, that's not good. All right, let's just not do it anymore. And like, oh, hey, it's an air splint. We can use it for pelvic fractures too. But then you run to the same problem. So we don't use these in California, right? Like I said, apparently some places around the country still probably do use this, hence why we still have to talk about it, right? But you're not going to be seeing this much here, especially in LA, right? In fact, I don't even bother pulling it out in lecture anymore because that's the only time I've seen this thing in person, whereas when I've been teaching. And again, don't have to worry about that because we're never going to see it. Now, as far as our distributive shocks, okay, these are all going to be widespread vasodilation problems using our mnemonic of SNAP. Slides aren't in SNAP order, but it would be septic, neurogenic, anaphylactic, and psychogenic. Okay, so septic, neurogenic, anaphylactic, and psychogenic. So we'll talk about the different kinds of shock, right? How to identify them. Most of them are going to be flushed due to vasodilation. Right, so that'll tell me that it's a distributive problem, but it doesn't tell me what type of distributive problem it is until we get to the actual differences between them. Okay, so again, you want to go back and categorize these different things, right, based on their different types, signs, symptoms, et cetera, et cetera. So starting off in neurogenic shock. Okay, this is the kind of shock I've been teasing for the last few slides. Okay, where a patient has severe spinal cord injury to the point where that cord has been severed. All right, now the higher up that injury occurs, the worse off the patient's going to be. All right, especially if it's up at C3, 4, 5, what nerve does that take out? Phrenic nerve, which means they can't
Breathe.
which means they will eventually will
Die.
unless we're there and start providing ventilations for them. All right. Now, as far as what we see with this patient, okay, we see what we call a two-tone appearance. What kind of appearance?
Two-tone.
Two-tone. All right. Now, I especially like giving nicknames to my patients because it kind of helps me memorize, right? Or at least remember what's going on with them. Okay. So I like to call this patient Tony Two-Tones. All right, because they're going to have a two-tone appearance. All right, they're going to have one set of skin signs above the injury, another set of skin signs below the injury. Okay, and of course, you have to ask yourself the question of why? Why do they have that two-tone appearance? Okay, everything above the injury can still communicate with their, which means they can still kick what response? Sympathetic response. Okay, so they will have pale, cool, and diaphoretic skins above the injury because they're still kicking their sympathetic response. But below the point of where that cord has been severed, can they communicate with their brain? No. So it's going to default into what type of response? Parasympathetic, due to that vagus nerve traveling around and still sending those signals to the body. Okay, and when our patient is in that parasympathetic response, again, smooth muscle, it's lazy, so it's going to start to dilate the blood vessels. So when you have that vasodilation, what color skin will they have?
Flush.
Flushed. Okay, so above the injury they're pale, below the injury they're flushed. Now as far as moisture, okay, we have to have signals from our brain to tell us to sweat. Okay, so our sweat glands need to rely upon signals from the brain to actually secrete sweat. So therefore above the injury they'll be diaphoretic, but below the injury they're going to be dry. They already know they're going to be flushed. They're going to be dry. Okay? So again, above the injury, they're sweaty. Below the injury, they're dry. Now, as far as temperature, okay, they're going to be cool above the injury because of vasoconstriction, shunting blood towards the core. Below the injury, okay, they're going to start warm and eventually going to start to cool off as time goes on. Okay, so below the injury, they start warm. They start at a normal temperature. But as time goes on, since they can't control their temperature very well, okay, they start cooling off. Whereas above the injury, they're cool right from the get-go. Okay, so totally different presentations above and below the injury, simply based on what's happening to the body and the pathophysiology that goes with it. You cut that spinal cord, your brain ain't talking to the rest of your body. So it's just going to default to that parasympathetic stimulation since that vagus nerve is going down. Okay, since our blood vessels need input from the brain to constrict, they're not getting that, so they simply relax and dilate. Okay, my sweat glands aren't getting the same signals, so therefore they don't secrete sweat. And because we can't control our temperature without the brain, we start off warm at normal and then eventually cool off as time goes on. Okay, so again, they won't have the classic signs that we see with regular shock. Pale, cool, diaphoretic skin. Right? We only see it on one part of their body. Now, in addition to that, for male patients, they may have a priapism, which is an unwanted erection, usually caused by spinal injury. Okay, so is he happy to see you? No, especially if you see two different skin signs, don't flatter yourself, it's not for you. Okay, that patient's got significant spinal cord injury, right, going into neurogenic shock. Now, as far as treatment, we see it, we
Treat it.
We see it, we
Treat it.
So we still want to give them high flow,
Oxygen.
cover them with a,
Blanket.
and what's the proper position for them?
Supine.
Supine, because they have what kind of injury?
Spinal.
Yeah, it's so bad their cord has been cut in half. Okay, so therefore we just want to keep them in the supine position. Right, now if they have any inadequate breathing, so they just so happen to have that phrenic nerve taken out, okay, we have to start breathing for our patient. All right, now the likelihood of us showing up on scene early enough to the point where the patient's not dead yet, when they knock that out, is super duper small. Okay, the only times we really will see that happen is if we are there on scene as it happens. Okay, so if you're doing standby events at football games and stuff like that, high contact sports, okay, you might see patients that could potentially go to neurogenic shock. Okay, and as that standby medic, it's usually a very chill job. Super fun jobs if you guys can land those, right? But when shit goes down, it's you and nobody else, right? So you've got to be able to do that stuff right then and there. All right, so we'll go ahead and again prevent spinal motion restriction. We'll talk about that tonight, how to do the process. Okay, but a week from tomorrow, on skill day 2, we're going to show you guys how to actually put people on backboards. Okay, so we'll talk about it tonight, but we'll show you how to do it next week. Obviously, if you've got a spinal injury where the cord's been cut, we're going to want to put them on a board. All right, after that, prepare for transport. And we're most definitely going to want to consider taking them to a trauma center because of the actual injury they sustained with a high MOI. All right, so with this, it's mostly quote-unquote supportive treatments. All right, but there are specific things we have to do for our patients. So, when it comes to septic shock, okay, so septic shock is caused by a widespread infection. Widespread what?
Infection.
Right, because again, if you think about it, it's got to be widespread because the definition of shock is widespread inadequate tissue perfusion. Okay, so localized infections like peritonitis or appendicitis or anything like that, they can cause septic shock, but they are not septic shock. All right. Once that infection leaves that particular body part and travels all around the body, aka gets into the bloodstream, then we can consider it septic shock. Okay. Now, as far as telling the difference between a patient who is in septic shock versus somebody who's got a regular infection, okay, we've got to look at their vital signs. Okay. If they have an infection or they're in septic shock, which one's going to have worse vitals?
Septic shock.
Septic shock. All right, because it's now widespread inadequate tissue perfusion. So think about when you're sick, you're going to breathe a little bit faster than normal. You're going to have a little bit faster heart rate than normal. Okay, but is your mental status going to change?
No.
No. Is your blood pressure going to change that dramatically too?
No.
No. But when they're in septic shock, they will have a change in mental status and their blood pressure will start to drop more than usual. Okay, but they still have tachycardia. They still have tachypnea. Right? They're going to be flushed. They tend to be hot. Right? They're going to be a little bit more on the moist side, usually more diaphoretic than clammy. Okay, so we got to look at the skin sign, or the vitals rather, to tell us the difference. More of an ALOC, a little bit more hypotensive than usual, yet now it's looking like it's sepsis. All right, now these patients are not going to have the classic signs. Right? They're not going to be pale, cool, and diaphoretic because they have a what?
Infection.
They have a what?
Infection.
They have a what?
Infection.
Right, and is the body going to try to fight off the infection?
Yes.
Yeah, so the body's going to do that the best way it knows how to try to cook that infection out. So therefore, they're going to be wet to the touch.
Hot.
Hot. Does the body like being hot?
No.
So what does it do to compensate?
Sweat.
Sweats and vasodilates, giving them what color appearance? Red or flushed. All right, so they're going to be hot, flush, and diaphoretic. All right, so again, it looks like our regular infections, but they're going to have shittier vital signs. All right, they're going to be a little bit more tachypnic, a little bit more tachycardic, a little bit more hypotensive, a bit more altered. All right, and it really depends on the infection as well as to how quickly and how suddenly, okay, this infection is going to take place and how quickly they'll go into sepsis. All right, so for example, if they were to have appendicitis, okay, appendicitis then goes to peritonitis, and the peritonitis can eventually go septic. Okay, that could take maybe about a day and a half, depending on the patient. Okay, things like pneumonia, right, can go septic fairly quick. UTIs can go septic very quickly. Okay, it also has to do with the immune system of the patient. If they've got a weakened immune system, they're going to go into sepsis a lot quicker compared to somebody with a stronger immune system. Okay, so geriatric patients, for example, do they have weak or strong immune systems?
Weak.
Weak immune systems. So it's very easy for them to go septic compared to a healthier adult patient, right, who's going to have a bit stronger immune system. Right, kids, right, same thing with kids. Their immune system's a little bit weaker, so it's easier for them to go into sepsis.
So is this one like toxic shock syndrome?
Yeah.
So how do you know like when that's what's going on with the patient?
Versus, what do you mean?
Like when you go to the site, how do you know that that's the problem?
That they're in septic shock.
Toxic shock.
We're going to pretty much make them the same thing. Yeah. So again, it's all based on their vital signs. All right, so as far as treatment, okay, it's going to be our traditional treatment. O2, proper positioning, but we have to be careful of the blanket. Okay? This patient's going to be hot to the touch. Do you want to put a blanket on them? No, because then you're just going to cook them even more. All right. However, okay, if we are going to cover the patients, we can use thin sheets to cover them up. Okay, we only want to do that if our patient is what? Cold, but they're going to be doing what? Shivering. Right. Think about the times you have a fever. Right. When you have a fever, if you're not under a blanket, you're going to kind of get the chills, kind of get the shivers. Okay, that's why you go over the blankets, and then you tend to cook yourself even more. Right? For us, we want to cover them up just to the point where they stop shivering. Okay, and we can more accurately control that by using thinner sheets and layering up the patient instead of one big fat heavy wool blanket goes on top of them. Okay, if our patient's not shivering, we don't have to worry about covering them up. Okay, we only apply blankets if they are shivering. Okay, now as far as proper positioning, most of the time we can use shock position. That'd be totally fine. But if they have, for example, pneumonia that's gone septic, okay, are they going to have a hard time breathing?
Yes.
So what position would I want them in? Fowlers. And if they do have that lower airway infection, what skin signs would we hear in that patient? Or, sorry, lung sounds would we hear?
Do I have a noisy, like, gurgling or?
Not really gurgling.
Is it the whale noises?
Sorry?
Like
The whales? You mean rails?
rails?
No, it's not rails.
Ronchi?
Ronchi. What is it?
Ronchi.
What is it?
Ronchi.
Right, ronchi. Okay, ronchi is going to be an indication of a lower airway infection. And how would you describe what ronchi sounds like?
Of course, bubbling.
Right, like a coarse bubbling sound. Okay, so like, again, think about when you're sick, you have that chest congestion, that in the morning, that nasty sound. That's what ronchi would sound like. Rails, right, is more of a wet, bubbly sound. Okay, that's an indication of fluid in the lungs being pulmonary edema. Okay, so in the case of pneumonia, right, we would hear ronchi, sometimes rails, but for right now, ronchi. Okay, and that tells us, hey, they got a respiratory infection, let's keep them sitting upright. Okay, but if they got, for example, peritonitis to go septic, okay, we can lay them down shock position, that's fine. Okay, so we also got to think about what caused the infection to occur. Now, as far as alerting the sepsis team, okay, we want to do that when we are transporting a septic patient to the hospital, right? When I was, in the field still, right, sepsis would just barely becoming like this big thing, right? We always thought that, they're just sick. Okay, it's just an infection. It's not a big deal, right? But then they would crash super quick, right? So nowadays, right, they're saying, hey, these septic patients, if we even suspect sepsis, we're going to treat them as seriously as we would MI patients or stroke patients, right? Where we got to get this thing fixed ASAP, right? Because these patients will crash super quick, right? Especially if they're immunocompromised or anything like that, right? So if we see it or suspect it, we treat it as septic shock, and we let the hospital know if we have an online system. Because as soon as they get that patient in, they're going to start pumping a bunch of antibiotics to try to fight off whatever infection they got. Right, so we really got to be looking out for, again, the vital signs, because that's what's going to tell us the difference between a regular old infection versus sepsis. Now, when it comes to anaphylactic shock, okay, this is an overreaction to the body's immune system to the point where it cranks it up to 11. Okay, so anaphylaxis is an overreaction to the body's immune system to where it's cranked up all the way to 11. So the body's going to do what the body normally does, but way more dramatically than it normally would. Okay, we'll be talking about anaphylaxis and allergic reactions quite a bit over the next week and a half or so. Okay, so again, it's things that we'll be saying over and over and over again. All right, now as far as the way that stuff can get into the body, it can get in through injections, like bee stings. Okay, patients can ingest stuff they're allergic to, like peanuts or shellfish. They can breathe stuff in, such as pollen or dander, or just simply comes into contact with their skin. Okay, the severity of allergic reactions will vary from minor irritation to full-blown anaphylaxis. Okay, when the patient becomes anaphylactic, okay, most of their body systems are being involved. the respiratory system, the cardiovascular system, the neurological system, right? The endocrine system. All that stuff starts getting involved, right, as an overreaction of the immune system. Okay, they're not going to have the classic signs because it's a distributive problem. What color are they going to be? Flushed. What color?
Flush.
Because they're going to have vasodilation. Right? Now, as far as what we can do to fix a patient who is in anaphylactic shock, okay, we can administer EpiPens or epinephrine. Right? And that's going to reverse the effects of anaphylaxis, not to the point where it completely fixes the problem, but it keeps the patient from dying. Now, as far as what's happening to our patients when they're undergoing anaphylactic shock, again, we already know it's widespread vasodilation. Okay, now we got to ask the question of why do they have vasodilation with anaphylaxis? Okay, has to do with what the body's trying to do in response to that antigen or whatever it doesn't like. Okay, that body wants to get rid of whatever nasty crap is in there. Not necessarily infection, but again, as far as what it's allergic to. Okay, so the blood vessels are going to dilate, okay, to try to move that stuff out to the skin. Right? Now, if you've ever seen anybody, either in real life or on TV, having an allergic reaction, they tend to do a lot of what? Itchy. Right? They get really scratchy, okay, because the body's trying to literally scratch that stuff out of itself. Right? In addition to that, they start developing a what all over their body?
Rash.
A rash. Okay? We call it hives. Right? Also, fancy medical term, urticaria. Okay? So the fancy medical term for hives is urticaria. URTICARIA, something like that. Again, do the best you can for spelling. Okay, but they start developing the urticaria, which are the hives that spread around all over the body. Okay, now as far as what else is happening inside the body, okay, the body wants to try to protect the lungs, so it's going to tell the bronchi to start constricting. Okay, so we have vasodilation, but we have bronchial constriction. Now, if the patient were to constrict their bronchi, sir, what lung sound would that cause?
Sorry.
If they cause bronchial constriction, or they have bronchial constriction, what lung sound would they have?
Be wheezing.
It could be wheezing. Okay, so our patients are going to have wheezing lung sounds. And wheezing is generally heard upon exhalation. So as that patient breathes out, that's what we hear as we're approaching them. Okay, because the body's trying to protect the lungs, make sure that nasty crap stuff doesn't get in the lungs, so it shuts down the airway. Now, the body usually does things that make sense. Sometimes it doesn't, right? So in this case, right, the body's trying to protect the airway. Cool, it makes sense, but it can get so bad to where it shuts down the own airway. It's like, well, that's kind of defeats the purpose, right? So by giving the patient epinephrine, we're going to reverse the effects. Epinephrine is basically adrenaline, which is going to cause the patient to kick what response? What response?
Sympathetic.
What response?
Sympathetic.
So therefore, what happens to their airways? They kick the sympathetic response.
Dilate.
It dilates. What happens to their blood vessels?
They constrict.
They constrict. Okay, so by administering epinephrine, okay, we reverse of the effects of what's happening to the body. Right? I open up the airway so we can actually start breathing again. Okay, and I start constricting blood vessels to take that blood from the skin and bring it back to the core of the body to maintain core perfusion. All right. Now, like I said, epinephrine is not the true actual fix of anaphylaxis. We can't give a medication for that. Okay, this is only going to basically keep the patient from dying because of the anaphylactic reaction. All right. So epinephrine doesn't do anything for the hives, doesn't do anything for the itchiness. Okay, but it is going to fix the respiratory and cardiovascular problems, right, by causing bronchial dilation, opening up the airway, and constricting the blood vessels. Right, now that is something you guys screw up all the time. How frequently?
All the time.
Because you guys try to memorize the different terms. And when you guys see it on a question, you see bronchodilation, you're like, oh, choose the first one that I see. Okay, without reading the actual word after that. Okay, epinephrine, when administered, causes bronchial dilation and vasoconstriction. Okay, so when we give our patients epi, it's going to cause bronchial dilation, opens up the airway, and it causes vasoconstriction, constricting the blood vessels. Because when our patient's in anaphylaxis, what's happening to their blood vessels? They're dilating, and what's happening to the airway?
Constriction.
It's constricting. Okay, so I just want to reverse those effects, and we do so by giving the patient epi. Now, as far as the administration of epinephrine, as far as administration of an EpiPen, okay, per California, right, Title 22, okay, we're actually allowed to carry epi, but the company that we work for has to be approved to do so, right? And they have to be approved by LEMSA, which is the local EMS agency, right? Now, in that case, right, basically LA County would say, yeah, that's totally fine, but you've got to buy it and supply it for everybody in your company, have it in stock, and have it in reserve. Right, if you guys were following the news a few years back, were these things pretty cheap?
No.
Hell no. Okay, so your company's not going to want to buy hundreds of units of EpiPens at $400 to $500 a pop, right, to have in reserve that we may not ever use. So they're like, yeah, now we're good. Okay, so most places we're not going to do that. Right now, there's other medications we might be able to, and we'll talk about those later. Okay, but we will be able to give this drug if the patient has prescribed to them. Okay, that's called assisting with administration. All right. The difference between assisting with administration and actual administration is that if I'm administering, I as the EMT am supplying the drug. If we're assisting with administration, the patient is supplying the drug. Okay. But if I wanted to, I can take the EpiPen and give it to them without them having to worry about it. And normally that's how we'd like to do it because we know what we're doing, hopefully. So as far as the indications for an EpiPen, okay, the indications for epinephrine are signs and symptoms of severe anaphylaxis. Okay, so the indications for epinephrine are signs and symptoms of severe anaphylaxis or severe asthma. Okay, so indications for epi, signs and symptoms of severe anaphylaxis or severe asthma. Okay, so I can give it for severe anaphylaxis because we've already talked about it, right? I want to cause vasoconstriction, bronchodilation. But I can also administer for severe asthma. And I can give it for severe asthma because asthma is a bronchospasm problem. Okay, so by giving them epi, in the case of an asthma attack that's really bad, I open up the airway. Now, as far as contraindications, when I cannot give epinephrine, okay, it's the only drug we will allow you to say this. Okay, we do not give epinephrine if they do not meet the indications, because there are no contraindications if they meet the indications. Every other drug that we will talk about in this course will have other specific contraindications that you need to state. Okay, therefore I like to call it a no shit contraindication, because no shit, if they don't meet the indications, we're not giving them the drug. Okay, but again, all your other meds, they will have their own specific contraindications. For this one, if they're not showing severe anaphylaxis, do I stab them with epi?
No.
If they're not showing severe asthma, do I stab them with epi?
No.
But if they are showing severe anaphylaxis, do I stab them with epi?
Yes.
And if they are showing severe asthma, do I stab them with epi?
Yes.
Yes. Okay. Now, the reason why I say this is probably the easiest drug that we can administer, because it's the only drug that we can help them with that actually has instructions on the actual drug itself. Okay. When in doubt, read. Okay. So, as far as epinephrine, okay, first and foremost, as an EMT, we cannot, I say again, we cannot administer it through clothing. Okay, which means we have to expose the area. Right? These are designed to go through clothes, yes. Okay, but if our patient was playing out in the park, right, and they got dirt all over their clothes, and I stab them, okay, where's that dirt going to go? Into the wound and possibly cause what? Infection. Okay, so we don't give it through clothing. Right, so we have to expose the patient's mid-lateral thigh. Okay, so we want to expose this region right here, nice meaty portion of the thigh. We'll take an alcohol prep pad, and we want to clean in a very specific pattern, going from small circles to big circles. Again, the reason why I go small to big is I want to push all that nasty stuff away from my injection site, away, that way we have a nice clean area. And if I go big to small, I'm now bringing nasty stuff to the point where I want to stab. Okay, now once you've cleaned the area after exposing, we're going to take the EpiPen and we're going to hold it like so. Okay, I want to make sure that both ends are open, right, as I pop off the safety cap. Okay, now once that safety cap is off, this thing's live, right, and now we're ready to go ahead and administer, pressing the colored end against the patient. Okay, so when we're giving an EpiPen, okay, all we have to do is take it to the thigh and press. It's not like the movies you have to yell, ah, and then jab it in. Okay, we just go and place it to the thigh, and then we Press. And this is a trainer, so don't worry. Okay? So we go ahead and press it. Okay, we want to hold it down for about 10 seconds. For how long?
10 seconds.
Okay, that way we let the medication work into the muscle. And after those 10 seconds, we take it out and we dispose of it into a sharps container. Okay, now usually this little sheath will come out protecting the needle, but I don't want to have a sharp laying out. Okay, this isn't San Francisco yet, right? So we want to go and drop it. Want to go and drop it in the sharps container, right? To go ahead and keep it safe. Right, now after that, we want to massage the area for about 10 seconds with a 4x4 piece of gauze. And that's going to help that medication work into the muscle, absorb it a little bit quicker. And these are going to have pretty large bore needles coming out of it, so there will be a little bit of bleeding. Okay, so we want to control the bleeding, and we can do so just by putting a simple Band-Aid on. Usually that's fine. Okay, so if you like Minions or SpongeBob, whichever you got for the kids, you can go and slap that on the thigh. Right, and from there we're ready to go and transport the patient. Okay, now whenever I give a medication for the purpose of class, okay, we're going to be transporting code 3, so reassessing their vitals every 5 minutes. And hopefully, and again for class purposes, we will have them, ALS is going to be in the back with us as we're transporting. Okay, so anytime I give a drug, it's a code 3 transport, reassessing every 5 minutes, and we'll have ALS in the back with us as we go. All right, so any questions on epi? No? All right, so I'll pass around the EpiPen trainers for you guys. Okay, so you can go through the motions of it. Now, if you guys are going to press it to your thigh, that's fine. Again, there's no needle. It's all safe. Okay, when you guys are done, you're going to press these 2 tabs in and then push it back down until it clicks in place. All right, that we can reset it. All right, again, all you have to do is press, pops out, and then just reset it for the next person.
Say you were like administering that, but you weren't holding it for 10 seconds. For some reason, it came out after 10. Would you then apply that?
So most of them will inject within 3 seconds,
Okay.
right? But 10 seconds will just ensure that we're able to get as much of that medication in there as we can. Yeah. All right. And as far as holding it, again, you want to make sure that you keep both ends clear. Heart is going to be more likely to cause cardiogenic shock. It's going to be the left side of the heart. And the reason why it's the left side of the heart is because the left atria contracts, pushes blood out through the aortic valve, out to the aorta to the rest of the body. So if the left side of the heart can't push blood out to the rest of the body, is that going to cause widespread inadequate tissue perfusion?
Yes.
Yes. Okay. Now, can I see inside of my patient's chest?
No.
But can I tell which side of the heart is damaged based on outward signs?
Yes.
Yes. Okay. How? Do the stuff that Matt was grilling you guys yesterday to understand the importance of for right now. Because if my patient were to have damage from the right side of the heart, blood will start to back up from the right ventricle back through which valve, sir?
I don't know how to memorize off the top of my head.
Sir?
Right ventricle back into the vena cava, or into the right atrium.
But which valve is it going to have to back up through first?
Tricuspid.
Right, the tricuspid valve into the right atria, and then from the right atria into the what?
Pulmonary valve?
No.
Pulmonary artery?
Nope.
Vein cava?
The vena cava. Okay, so it's going to go down into this inferior vena cava and go up into the superior vena cava. Okay, if we have it going up to the superior vena cava, okay, we're going to have jugular veins start popping out in the neck, giving the patient JVD. Okay, now we'll talk about it on Wednesday of next week. Okay, but we're going to talk about the signs we see when blood starts going down, right, to the superior vena or inferior vena cava. Okay, but when it goes back up to the superior, we're going to have JVD. Now, if I have blood backing up from the left ventricle, okay, blood's going to back up through the left ventricle, back through which valve?
The bicuspid valve.
AKA
Mitral?
mitral valve, into what chamber of the heart?
The left atrium.
Left atrium, and then to which vessels, sir?
Sorry?
Which vessels is that blood going to back up once it goes through the left atria?
To the pulmonary?
Pulmonary
Valve? Or
Well, yeah, pulmonary. Well, it's not the pulmonary valve because that's from the right side. What vessel? Which one of the pulmonary vessels? Left atria going back goes to the pulmonary.
No arteries.
Nope.
Vein?
Pulmonary vein. And what's special about the pulmonary vein?
It's where diffusion of there's diffusion that's happening there, but the
Nope.
blood is going.
It's not happening in the pulmonary vein. Sir, what's special about the pulmonary vein? Sir, what's special about the pulmonary vein?
provides oxygen to the lungs.
To where?
The lungs?
Nope.
It backs up into the lungs.
It backs up into the lungs, but that's not what makes it special. Sir?
It carries oxygen-rich blood.
Right. It's the only vein in the body, besides umbilical, okay, that carries oxygen-rich blood. Okay, because oxygen-rich blood is coming from the lungs where diffusion occurs, and normally it's going back to the heart. Because veins take blood where?
Oh, wait.
No.
Towards the heart.
Towards the heart. Okay? Veins bring blood towards the heart. Generally, it's oxygen-poor blood from the body. But in the case of the pulmonary veins, it's bringing oxygen-rich blood from the lungs back to the heart. Okay? So when you have a backup, it goes from the left ventricle up through the bicuspid valve, aka mitral valve, into left atria, back into the pulmonary veins, which then puts that blood back into their lungs. And now that patient has fluid in their lungs. And sir, what do we call fluid in the lungs?
Pulmonary edema.
Right. And what lung sound do we hear?
With fluid in the lungs?
Yep.
Rails?
Rails. Okay, so now that patient's going to have rails, okay, which would be fluid buildup in their lungs. Okay, so again, I can't see inside of my patient's chest, but I will have an idea of which side of the heart is damaged, okay, based on where that blood starts to back up. If the right side of the heart is jacked up, okay, blood backs up to the neck and to other parts of the body. If the left side of the heart is messed up, it's going to start backing up to their lungs. Right? Now, with these patients who have left side of heart problems, generally causing cardiogenic shock, again, they will have pulmonary edema. When they got fluid in their lungs, are they going to have an easy or difficult time breathing?
Difficult.
So, do I want to leave that patient down? No. We want to keep them up in the Fowler's position. Okay. Now, as far as the signs and symptoms and treatments of shock, cardiogenic shock, okay, this is the other patient that will have our classic signs. They will be pale, cool, and diaphoretic. Okay, they will have a rapid and weak pulse, aka thready pulse. Okay, now for class purposes, if our patient has an irregular meaning not regular. Okay, if they have an irregular pulse, that tells us it's a cardiac problem. But for the purpose of class, when they go into shock, okay, they go into survival mode, right? And now they're going to have a thready pulse, a rapid and weak pulse, as the heart is trying to compensate, okay, for its damage and its failure.
So blood in the lungs means this.
Not necessarily. Right? Because we'll talk about on Tuesday the other causes of pulmonary edema that don't have to do with the heart. Okay. So for cardiogenic shock, our patient will have a thready pulse, but if it's just a cardiac problem, they'll have an irregular pulse. And if their pulse is irregular, how long do we check their pulse for?
1 minute.
1 minute. Okay, so if they got an irregular, a not regular pulse, we count for a full 60 seconds. And in that case, would it be okay to state an odd number?
Yes.
Yeah. Yes. Okay, as long as it is an actual odd number that we count in those 60 seconds, that's fine. Okay, but if we're counting for 30 seconds, multiplied by 2, can I state an odd number?
No.
No. Okay, as far as skin signs, eventually patients will become cyanotic when they're in shock. Okay, but that's a later stage of shock. Right, we obviously want to give them some high flow oxygen because they're complaining of chest pain and more than likely shortness of breath. That's it. So when we get to B in our patient assessment, we need to ask ourselves what question?
Does the patient need oxygen and how to administer it?
Thank you, sir. What is it?
Does this patient need oxygen, and if so, how do I administer it?
What is it?
Does my patient need oxygen, and if so, how do I administer it?
Again?
Does my patient need oxygen, and if so, how do I administer it?
Right. Okay. So again, we got to ask yourself, does the patient need oxygen, and if so, how do we administer it? And if they're having cardiogenic shock, they're going to go, my chest hurts and I can't breathe. Okay. They're not going to be like, I'm in cardiogenic shock. Okay. They're going to be complaining of chest pain and shortness of breath. Right. And if they were even conscious and talking to us, okay, they're more than likely going to be altered as well. Okay, because their heart is failing so bad, right, that they can't get blood up to the brain. Okay, so usually they're going to be severely altered as well when they're suffering from cardiogenic shock. All right, so we need to make sure we're looking out for that and suction out our patient as needed, and we'll talk about suctioning and rules of suctioning come Tuesday. Now, as far as our other pump problems and the last kind of general type of shock we're going to talk about, okay, that is going to be obstructive shock. Now, with obstructive shock, it is a pump problem, but usually there's nothing wrong with the actual heart itself. Okay, there is no damage to the myocardium with obstructive shock. It's just that something is not allowing the heart to do its job. So the way I think about cardiogenic shock and obstructive shock, okay, I think of the heart as an actual literal pump. Okay, with cardiogenic shock, right, we have damage to the pump itself. That'd be somebody like taking a hammer and smashing a pump and breaking it. Whereas obstructive shock would be like somebody unplugging the pump so it can't function. There's no damage to the pump, but it can't do its job. Right? Now, there's 3 primary causes of obstructive shock. One of them is cardiac tamponade. And cardiac tamponade is when I have fluid, generally blood, building up around the heart's own little potential space between the pericardial sac and the myocardium. Okay, so our heart is like just about any other organ in the body that it has its own protective layer around it. Okay, that is called the pericardial sac or the pericardium. Okay, just like the thoracic the visceral and parietal pleura, we have a potential space between the two. Between the myocardium and the pericardium, we also have a potential space. All right, now if fluid starts getting in there, we call that cardiac tamponade. Can I see inside my patient's chest?
No.
No, but can I see signs of cardiac tamponade?
Yes.
Yes. Okay, there are 3 signs we're going to see to indicate cardiac tamponade. The first one is going to be relation in blood pressure. Okay, so they will have systolic hypotension. Okay, so our patient will have systolic hypotension. Okay, so our patient's going to have a lower blood pressure. All right, sir, what is the normal range for a blood pressure for an adult?
120 over 80.
That's a perfect textbook bullshit blood pressure, but what's the actual range of a systolic blood pressure?
120 through 140.
Nope.
60 to 100.
Nope.
Is it 100 to 120?
Nope. Miss?
I thought it was 60.
Nope. Okay, well, it's got to be in your head. Miss? Miss?
80 to 120.
Nope. Sir?
112 to 120.
Nope.
80 to 100?
Nope.
90 to 140.
Thank you. Okay, 90 to 140. Okay, and I told you guys last night you have to know normal because you need to be able to identify abnormal.
Abnormal.
Okay, especially when it comes to shock. Okay, when we talk about our different stages of shock coming up shortly, it's all about the blood pressure to know if my patient is compensating or, oh shit, they're now decompensating. Okay, and I know they're going to go from compensating to decompensating when their blood pressure starts getting below normal. Right? And a vast majority of you guys would not be able to tell the difference between somebody who's compensating and somebody who's decompensating. Okay? Because the blood pressure is what's going to tell me what stage they're in. Okay? So, this patient with cardiac tamponade is going to have systolic hypotension, which means their blood pressure will be less than 90. Okay? But in addition to that, they're also going to have a narrowing pulse pressure. So they have systolic hypotension and a narrowing pulse pressure. And sir, what is the pulse pressure? By definition, what is it?
The pressure that is exerted on your blood vessels?
Nope, because that's a diastolic pressure, a systolic pressure. Sir, what is the pulse pressure?
I do not know.
What's pulse pressure? What's pulse pressure?
The difference between systolic and diastolic?
Right, it's the difference between your systolic and your diastolic blood pressure. And again, I told you last night, you need to know it for tonight. Because there's 2, how many? 2 conditions that relate to pulse pressure. Cardiac tamponade is one of them. Okay, and the other one we're going to talk about when we cover head injuries. And you guys will always confuse the 2 because they're the only 2 things that have to deal with blood pressure, but they're total opposites of one another. Okay? With cardiac tamponade, our patient has a narrowing pulse pressure. They have a what?
Narrowing
Pulse pressure.
pulse pressure.
Right, narrowing pulse pressure. And that's because of that systolic hypotension. Okay, for example, a patient with cardiac tamponade is going to have a blood pressure of 86 over 78. Okay, where those 2 numbers are very close together. Okay, whereas a patient who's got a normal textbook bullshit blood pressure of 120 over 80, right, it's a difference of 40. But in the case of a patient with cardiac tamponade, it's probably less than 10. Okay, and that's telling us that poor little heart is getting smashed inside of its own pericardial sac. Okay, so the heart, just like with tension pneumo, can't refill with blood, right? Therefore, it can't push blood out. Now, in addition to that, okay, our patient's going to have JVD because that poor little heart, right, can't refill with blood, so blood's going to back up. That's why, again, JVD by itself doesn't mean anything to us, right? Because patients will have JVD for other reasons, right? We know patients with a tension pneumo will have JVD. Patients with a regular pneumothorax will also have JVD. Patients laying supine will have JVD. Cardiac tamponade will have JVD. Okay, so we got to look for JVD plus other signs and symptoms to let me know what it actually is with the patient. All right, and then lastly, things we're going to hear with a cardiac tamponade patient. We're going to hear muffled heart tones. Okay, so we're going to hear muffled heart tones. So when we auscultate, which means listening through a stethoscope, okay, when I auscultate their heart sounds, instead of not hearing a nice loud boom boom, we hear a very soft boom boom, right? Because of all that fluid building up around the pericardial sac. Okay, so if you have a patient with systolic hypotension with the narrowing pulse pressure, jugular vein distension, and muffled heart tones, okay, those three things together tell us they have cardiac tamponade. And we have a name for those three signs because some bastard named it after himself. So we call it Beck's Triad. What do we call it?
Beck's Triad.
What do we call it?
Beck's Triad.
All right, so Dr. Beck, whatever his first name is, right, decided to name it after himself because he's like, oh yeah, that's mine. Right? So we're going to see Beck's Triad. Now the other thing that has to do with pulse pressure is also named after somebody else, and they also call it a triad because it's one of three things, which further brings us to the point of why you guys screw them up all the time, because you're not understanding why we see those different signs or symptoms. You see, pulse pressure triad, I don't know which one it is, I'm going to go with the first one I see, right, which is usually going to be incorrect. All right, so we'll talk about Beck's Triad a little bit more later with trauma overview. We'll talk about it again on Monday. We'll talk about the other triad tonight, and again we'll talk about it again on Monday. Okay, reinforcing the differences between them. We already know about tension pneumo. That's a lot of air that builds up in their
Lungs.
not in their lungs.
Potential space.
In their what?
Potential space.
In their what?
Potential space.
In their what?
Potential space.
Right, in their potential space, okay, causing a shift of everything inside their chest. Can I see the shift?
Yes.
No. Can I see signs of the shift?
Yes.
Yes. Okay, so time number 5, Miss. What are the signs we see to indicate a tension in pneumothorax?
JVD, respiratory checking, respiratory, there's a JVD subcutaneous edema, and then
Not edema, because edema would be fluid.
subcutaneous air travel.
What do we call it?
Emphysema and tracheal deviation.
Right, tracheal deviation. Okay, again, all of that one-to-one correlation of what's going on inside the body versus what we see on the outside. So again, as all that pressure is building up, causing a shift, poor little heart's getting smashed, can't refill with blood backs up to the jugular veins, popping out the JVD. Okay, we're getting all that air from the fatty layer of skin, or getting stuck rather than the fatty layer of skin, creating that snap, crackle, pop sensation, and eventually, as everything's going past midline, okay, that trachea is going to get shifted over to the other side as well. All right. Now, as far as lung sounds, okay, if our patient has a tension pneumothorax, when I auscultate, which means to listen through a
Stethoscope.
okay, we have absent lung sounds on the injured side. Okay, so if they have a tension pneumothorax, the patient will present with absent lung sounds.
Is it more common to get it on one side than the other?
As far as like right versus left,
Yeah.
no. It just depends on where the injury's at. All right, so they'll get on absent lung sounds on that injured side because there's nothing left on that side of the chest because everything has started to shift. Okay, now with a regular pneumothorax, we'll have JVD. We may get a little bit of subcutaneous emphysema, but we're going to hear diminished. What are we going to hear?
Diminished.
Right, diminished lung sounds. Now, diminished lung sounds would be clear, but just quiet. So instead of hearing like you normally would, you'll hear because there won't be as much lung tissue present on that one side. Okay, but once you don't hear anything at all, when the patient goes in and out, and you hear, then you go, oh shit, that's tension pneumo. Okay, over the course of the next traumatic injuries lectures, we'll talk about there may be something we can do for it. Sometimes there isn't, just depends on the cause. All right, and then lastly, we have a pulmonary embolism. Now, as far as a pulmonary embolism, that is a blockage of some sort, be it a blood clot, an air bubble, or some other foreign body that we'll talk about later in class that gets stuck in the patient's blood vessels in their lungs, primarily the pulmonary artery. Okay, so pulmonary embolism is a blockage that could be a blood clot, an air bubble, or some other foreign body that gets stuck in the blood vessels in their lung. All right. Now we'll talk about the cause of an air bubble later on tonight. Okay, we'll talk about the blood clot causes on Tuesday, and then again the other foreign body we'll talk about much later on in the program. Okay, but either way, we have something that gets stuck in the blood vessels in the lung, and therefore will affect the body's ability to let that oxygen meet with the blood, causing decreased perfusion. Now, as far as recognition of a patient who has a pulmonary embolism, they're going to have a sharp pinpoint chest pain. Okay, so they will complain of a sharp pinpoint chest pain. And they can point to exactly where that pain is. And it's usually where the actual obstruction's at. So when I go through my OPQRST, when I get to R, region, radiation, recurrence, hey, with one finger, can you show me where that pain is? Yeah, it hurts right here. Okay, does that pain move anywhere? No, it stays right there. All right, as far as recurrence, have you felt this before? It depends on the patient. Okay, but at the very least, it's a sharp pinpoint, non-radiating pain. All right, so they have that sharp pinpoint chest pain. They'll have crappy O2 saturations. Okay, so they have crappy O2 saturation with adequate or good tidal volume. Okay, so sharp pinpoint chest pain with crappy O2 saturations, but good or adequate tidal volume. Now, the reason why, okay, they have the sharp pinpoint chest pain, it's just the way our body is nerved. Most pleuritic or lung issues tend to be described as a sharp chest pain. Most cardiogenic issues, just because the way your body perceives pain for around the heart, it's more of a dull, achy pain. Okay, so as we're going through the OPQRST, again, our detective questions, right, based on the quality of the pain, when they have chest pain, if it's more dull and achy, it's probably cardiac. If it's sharp and stabbing, it's probably pleuritic or dealing with the lungs. And then with the other questions and answers, we'll be able to tell what exactly is going on. All right. As far as the crappy tidal volume, crappy O2 sats, right? When our patient inhales, the airway itself is not blocked. Okay, the blood clot is in the blood vessels, but the airway, right, is patent. Airway's what?
Patent.
Okay, so they can suck in as much air as they want and send it all the way down to the alveoli. But that blood clot or other blockage won't let that blood get all the way down to the capillaries surrounding the alveoli, and therefore diffusion doesn't occur. Okay, so that's going to cause their O2 saturation levels to drop. And as far as normal SpO2 levels, that's what's considered normal for an adult patient or for a healthy patient. For the SpO2, what percentage? All right, 94 to 98%. So my patient who has pulmonary embolism, okay, they might be sitting in like the high 80s or low 90s. Okay, and that tells us that, hey, they're not able to get that oxygen perfusion to their blood, but if they can suck in as much air as they want, then that tells us something's up. Now, if the patient had carbon monoxide poisoning, okay, is the airway obstructed?
No.
No, right? Is there any interruption to blood vessels?
No.
No, so they won't have the crappy O2 saturation, even though they're not really absorbing oxygen. Instead, how is their SpO2 going to change?
Is it going to decrease? It increases too high.
Right, it goes way higher than it should be. Okay, again, normal is 94 to 98%, but if that carbon monoxide poisoning, what would it read?
About 100.
Right, it'd read 100%. Okay, and that should be a clue for you to go like, wait a second, that's not right. Okay, if you got a patient who's got 100% SpO2, right, and the environment that they're in dictates the possibility of carbon monoxide poisoning, okay, which is a product of combustion. So if they're on anything, okay, that is burning, we have to suspect carbon monoxide poisoning. And whatever happened to them can happen to us. Okay, so we have to think about that, right? Again, later stages, they turn that bright cherry red appearance. Earlier signs would be headache and an ALOC. Okay, so we got to think about those things and be like, ah, crap. All right, it's probably what's happening to our patient. So here we have signs of cardiac tamponade. So again, Beck's Triad. All right, systolic hypotension with the narrowing pulse pressure. The systolic and diastolic numbers get really close together. Patient will have JVD, which would be jugular vein distension. And we're going to hear those muffled heart sounds, sometimes written out as muffled heart tones, same thing. All right, and our tension pneumo, Okay, so when you have blood, or I'm sorry, air rather, building up into the potential space, eventually causing a shift. So, going to play that video again from last night, and we're going to see a picture later on of an X-ray of somebody who died from tension pneumo. So you'll see exactly what happened. So we'll be hitting cardiac tamponade more on Monday when we talk about chest trauma. We'll probably talk about it again with the trauma overview. I can't remember, right? But it is something we're going to be seeing quite a bit. Okay, we got to be able to identify what it is. Now, there's nothing we can do to fix it besides go, oh crap, I think they have cardiac tamponade, right? Because we have to get them in the hospital ASAP to fix the problem. All right. And for a lot of these things, the most important thing we can do is recognize what's happening to our patient. Crap, they're having a pneumothorax, right? Oh crap, it's gone tension. Crap, they got a subcutaneous, they got a pulmonary embolism. We got to go to the hospital. They have cardiac tamponade. We got to go to the hospital. Okay, so while there's not much we can do to fix it, we at least can assess it and hopefully identify the issue to transport to the hospital. So, play it again.
A plastic bag. Pleura. Okay, here we have some guts, lungs, and a heart in there. It's intubated in a plastic bag to mimic the pleura. Right. Now this lung does have a little hole in it, so we have a pneumothorax just around the side, just a little wee punctured lung. I'm bagging a bit faster than we normally would, but as you can see, the air is escaping from the lungs and into the pleura. And little by little, the bag is getting filled more and more. So currently there's no pressure against the lungs that I'm feeling. It's just as easy as it has been. It's starting to get harder to bag it now. It's really hard to bag it now. And those lungs just are not inflating at all. So it's really tension.
Need a needle decompression there? Or bring a thoracotomy?
Oh, need a finger thoracotomy on this bag. Let's see if we can release the pressure. A little hole there.
Yeah, the lungs can inflate.
And inflate the lungs. It's quite a tiny hole you made there, so it's still a bit hard to inflate the lungs. It's certainly easier than it was before. Maybe enlarge that hole a little bit. Oh, yeah, this is not tiny.
Finger thoracostomy.
There we go. And we can re-inflate those lungs.
So again, just showing that air will start building up in that pleural space. Basically, air pressure is going to start squishing the lungs to the point where it can't inflate. Coronal heart's going to get smashed. And like I was saying yesterday, we are going to have a dividing line in our chest. That's where we get a shift instead of just an even collapse inward, right? And as far as fixing the issue, right, somebody, not us, okay, but somebody else is going to have to make a hole to vent all that pressure. Now, as far as what they'll do in the field, they kind of showed it. Little tiny hole, right? And then when they get to the hospital, doctor's going to make a much bigger hole and quite literally shove their finger inside of their rib cage, right? Spread it around like they did to open up that hole and then shove a tube in to release that extra pressure, right? So again, we have to try to recognize that, ah, crap, they've got a tension pneumo. Nothing we can do about it, but we have to go to the hospital, okay? So, there we go. As far as treatments, like I was saying, right, nothing we can do besides recognize these issues. Crap, they got cardiac tamponade. Crap, they got a tension pneumo. Crap, they got a pulmonary embolism. Where we can go ahead and transport the patients to the hospital to get those issues fixed. Now, with the tension pneumo, if they do have an open chest wound or a sucking chest wound, there is something we can do about it, right? But in the case of a closed pneumothorax that goes tension, there's nothing we can do about that stuff. Okay, so the most important thing we can do for these conditions is recognize the signs and symptoms to identify the issue and then transport to the hospital. All right. In the meantime, it's all supportive treatments. Airway, breathing, circulation to the best of our ability, treat for any shock, and then transport. Recognize what it is so we can transport and they can get it fixed. Okay, if we delay patient care for these patients, obviously they will die. So we want to get them out to the hospital as soon as we possibly can. Now, as far as respiratory insufficiency, okay, this is all caused by what we refer to as a ventilation perfusion mismatch. Okay, there's a ventilation perfusion ratio, which is common sense when you think about it. Ventilation is movement of air from the environment into the lungs back out again. Perfusion is circulation of oxygen, right, through blood or out that organs or tissue. So basically with that ventilation perfusion ratio, the more air I suck in, should I be better perfused?
Yes.
Yeah, that's all it is. The more air I suck in, the more perfusion there should be. But if we have a mismatch, right, if I were to suck in as much air as I possibly could, but I still have poor O2 saturation, is that a problem?
Yes.
Yeah. Okay, and that's essentially what happens with a pulmonary embolism. With that airway being patent, suck in as much air as they want, but because the blood vessels are blocked, they can't get to blood can't get to the alveoli, so therefore they can't pick up the oxygen. Hence why they have good tidal volume, but crappy O2 saturations. Okay, toxic gas environments like carbon monoxide, okay, leads to the same thing. Their airway's not blocked, they can suck in as much as they want, but it's all that nasty poisonous gas. Okay, and depending on the gas that it is, it's not going to allow for proper perfusion. So the carbon monoxide, again, it's going to attach to the red blood cell. The SpO2 thinks that everything is fine, but that's just because it measures the amount of stuff that's on the red blood cell, not actually oxygen. Okay, so realistically, our patient is going to be hypoxic. Okay, cyanide poisons work the same. Okay, it's going to interrupt the body's ability to use oxygen. Okay, so that too can lead to a ventilation perfusion mismatch. So in that case, we just have to treat any respiratory insufficiency that they may have. So give them some high flow too. We may have to provide ventilations for our patient. All right, and support any other airway and breathing issues we can. All right, and this is going back to that Fick principle. Air goes in and out, blood goes round and round, and tissue gets perfused. But we have something to interrupt that, in the case of blood going round and round, or in the case of air going in and out, or the two being able to meet, that too can lead to shock. So, as far as treatment, it's just supportive, airway, and breathing. Okay, so make sure they have a patent airway, suction if we have to. We'll go over that stuff again on Tuesday. Okay, administer oxygen through whatever device we have to. We'll talk about that on Tuesday. And then for circulation, it's usually secondary to respiratory issues, but we'll treat any circulatory problems they have too, like shock. Okay, so maintain airway and breathing as best as we can, and then treat any circulatory issues afterwards. All right, so like I said, things that will cause it: carbon monoxide poisoning, cyanide poisoning. Okay, these are going to affect the body's ability to use oxygen, therefore affecting metabolism. All right, so I'm going to be coming up on the different stages of shock. So once we've identified, okay, what type of shock are they in, now we have to determine, is it early? Are they still compensating? Are they decompensating? Or is it too late and now they're in irreversible shock? Okay, and the way we're going to tell the difference between their different stages is by looking at their vital signs. The worse off their vitals are, the worse off the patient is. Okay, and that's why you have to be able to identify normal so we can actually identify abnormal, especially for that blood pressure. Okay, so our different stages are compensated, decompensated, and irreversible. Now with compensated shock, I like to say that the patient is still in the fight. So if they're compensating, okay, they're still in the fight, which means their body's still able to fight off whatever is causing shock. Okay, they're still able to perfuse relatively okay. And the best way to know if they're actually still compensating is by looking at their blood pressure. If their blood pressure is within normal limits, they're still compensating. But once that blood pressure gets below normal limits, now they're decompensating. They're now losing the fight. Okay, and we do have a distinct line of when the patient has gone from compensated to decompensated shock. All we got to do is look at their blood pressure. But as far as patients going from decompensated to irreversible shock, there's no way that I can tell the difference in the field. So I don't know when they've gone from this stage to this stage. The only way we would know is that nothing works. Okay, and by the time they get to irreversible shock, they're pretty much dead. It's just a matter of time. Okay, so that's why if we see or suspect shock, especially in certain patients like kids, okay, we want to go and treat it right then and there. We want to try to at least put shock on pause as best as we can to keep it from getting worse. So as far as signs of compensated shock, okay, again, the first thing is blood pressure within normal limits. So for an adult, the blood pressure is still going to be above what number?
90.
Above what number?
90.
Above what number?
90.
Right, it's still going to be above 90. Right, because once it gets below 90, now that's hypotension, and now they're decompensating. Now, as far as being able to know if our patient has a decent blood pressure, obviously we'll check it. Okay, but to know if they're decompensating where it's under 90, there's a very easy way of doing that, and we'll talk about it on the next slide. Now, the early signs that we often miss when patients go into shock, it's going to be agitation, anxiety, and restlessness. Okay, the earliest signs of shock that we tend to miss the most: agitation, anxiety, and restlessness. And the reason why we miss it the most is because we just think about, okay, whatever happened to this patient, they're going to be a little worked up. I would be too. Okay, but that's when they start getting into that shock progression. And then as time goes on, things get worse and worse and worse. Okay, they may have an ALOC, not to the point where they're like completely out of it, but they may do things such as repetitive questioning, where they ask the same question over and over and over and over again. Either identical questions, same time, or they're going to mix it up a little bit. So for example, let's say a patient was involved in a motorcycle accident, usually motorcyclists, right? The first thing they're concerned about is not themselves, but what?
The bike.
The bike. Where's the bike? What happened to the bike? How's the bike? Where's the bike at? What happened to my bike? How bad is it? Where's the bike? Okay? They're not focused on themselves, they're asking about the bike, and they're asking it over and over and over and over again. Okay? And based on the MOI, how bad was the crash, we have to suspect, hey, this person might be going into shock. Okay, so we got to think about that earlier on, right? But again, you think about it too, like, oh damn, that was a nice bike. I'd be upset too, right? That's why we tend to miss the very, very early signs, because okay, yeah, they're in distress, right? Yeah, they'd be stressed out a little bit, so would I. Okay, but we have to think about it. Shit, now they might be going into shock. Okay, they're gonna have a feeling of impending doom.
Like the world's gonna end type?
No, not necessarily. Maybe for them. Okay, but you've all had that feeling before. Okay, that sinking feeling you get in your gut when you get bad news, where you know something's going to happen, right? That's a feeling of impending doom. Just like when it was report card day in high school. Yeah. Right. So that patient's going to have that kind of sinking gut feeling as well. All right. They may have pale, cool diaphoretic skins, but is every single patient who is in shock going to have pale, cool diaphoretic skin?
No.
No. Right? But we're keeping it simple now. They're going to have the classic signs of shock. But if they're septic, for example, they'll have the hot flush diaphoretic skins. Okay, so skin signs will be present. Now, when it comes to nausea and vomiting, don't ever write this down because you're wasting your time. Okay? Is there just a handful of things that cause people to get nauseous and throw up?
Yes.
No. Okay? Everything will cause nausea and vomiting. So don't even bother with that. Okay? Just know, okay, yeah, they're going to feel nauseous. Yeah, big deal. Okay, but it doesn't help me identify anything about the patient. Okay, but they will have nausea and vomiting with shock. Patients will get thirsty. Okay, so they'll have a marked thirst. right? And they'll be sitting there like, oh man, can I get something to drink? Okay, but we usually don't want to give them anything by mouth because they may not be able to maintain their airway. Okay, that's the body's way of trying to get fluid back into it to try to help maintain pressure. Okay, so that should be another thing too. If your patient's just saying, oh, I'm really thirsty, I'm really parched, my mouth is really dry, right? That's an indication that, you know, they're trying to replenish fluid, and again, they're kicking the sympathetic. When you're in a sympathetic response, what happens to your salivary glands? They stop producing saliva, right? So they kind of get that dry mouth. Okay, so these are all things we're going to see in the earlier stages of shock. But the main thing to know is their blood pressure is still within normal limits. But once they get below normal limits, now they're decompensating. Okay, so once that systolic blood pressure gets below 90, okay, now we can say the patient is decompensating. They're not losing the fight. Now, the easiest way to know if our patient is decompensating is through the absence of a radial pulse. Okay, so if they don't have a palpable radial pulse, then I already know for a fact they're decompensating. Because in order to generate a radial pulse, the systolic blood pressure has to at least be what?
Below 90.
80.
Oh.
It's right there on the slide. Okay? It's got to at least be 80, right, to generate a palpable radial pulse. Which means if I can't feel the radial pulse, I know their blood pressure is under 80. Okay, and if we can't get a radial, we then go for the brachial, which the blood pressure has to be at least
70.
And if they can't feel a brachial, we go for the cardiac, which has to at least have a blood pressure of
60.
And if they don't have a carotid pulse, for all intents and purposes, they're dead. Okay, so when I'm going through COPS and they're conscious, right, or at least, you know, awake, okay, and I don't feel a radial pulse and I'm in the right spot, okay, crap, I already know this patient's in decompensating shock. Okay, but of course you have to make sure you're in the right spot. The radial pulse, little pocket in your wrist on the thumb side. If you guys are checking right here like, oh no, I can't get a radial, well no shit, because you're not in the right spot. Okay, so we want to make sure that we're getting right in the radial pulse right here. As far as breathing, okay, it's going to become more labored, so they're really having to work to breathe. It starts becoming more irregular as well, more shallow as well. Okay, so the respirations start becoming way more funky than usual. They may be cyanotic, which means they're turning what color? Blue. They may start to become ashen as well, which means they're turning gray. And they might even be mottled. And mottled is like a splotchy, grayish, bluish kind of discoloration to the skin. Okay, obviously, ashen and mottled are very, 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 very late signs, right, of hypoxia, whereas cyanotic is just the late sign of hypoxia. All right, they're going to have a thready or absent radial pulse, because again, we already talked about the blood pressure. They're going to have dull eyes and dilated pupils. So by dull eyes, it means they kind of have like a blank stare to their face. So where it looks like they're looking through you and not looking at you. Right? Pupils are going to be dilated, because again, they're in the sympathetic response. And they're going to have a poor urinary output. But are we going to see that in the field? No, because we're not with our patients long to be like, hey, this guy peed less than yesterday. All right, but in a clinical setting where the patient will be there long term, will they determine the patient's got a poor urinary output?
Yes.
Yeah. Okay, and that's even something we could possibly ask if we're picking up from these skilled nursing facilities or anywhere else. Right? We can ask them, hey, has there been a decrease in the urinary output of our patient? Right, especially if they're they have a catheter, they'll be measuring how much urinary output they're actually having, and they'll be like, yeah, our patient, you know, is peeing 30% less than he did yesterday. Okay, and that tells us that they're running out of fluid, or the body's trying to hold on to as much fluid as they possibly can to maintain pressure. Now, as far as compensated from decompensated, again, we can tell the difference based on their blood pressure. But from decompensated to irreversible, there's no way we can tell the difference. The only way we know they've gone into irreversible shock is if they were to do a complete blood transfusion and they're still dying. Okay, so we have to assume that if they're hypotensive, we're just going to assume the worst and hope for the best. We're going to assume they're already here, try to pause it as much as we can, that they can go to the hospital. Hopefully, fingers crossed, they'll be in decompensated shock where they can fix the issue and reverse it. Because decompensated can still be reversed. It's just a lot harder compared to compensated. So by the time they get to irreversible shock, there's been so much acidosis in the body that they're undergoing tissue death and organ death, which then leads to patient death. Okay, so again, a complete blood transfusion, if they were to replace every single drop of blood in their body with fresh oxygenated blood with no acidosis, it ain't gonna make a difference. Okay, because the organs are now shutting down. And the only way to fix this, if they were to replace every single vital organ in the body, including the brain. And can we do that? No. Not yet, at least. All right, so at this point, again, it's just a matter of time till the patient dies.
How long does this usually occur over? Like,
I was literally just going to open my mouth to say that after answering the question. It depends. It depends on the cause of shock, right, and how quickly your patient's able to compensate and things like that. Okay, so for example, with septic shock, septic shock can take days to develop. It can take hours to develop. So it just depends on the infection and how quickly it can spread around the body, right? Hemorrhagic hypovolemic shock can take a little bit. It can take hours. It can take minutes. So it just depends on what's the actual cause and how quickly, right, they'll be decompensating from there. Right? That's why if we see it or sometimes we suspect it, we treat it and we try to stop it right then and there. So we just try to do whatever we can, but by the time they get to irreversible shock, nothing that can be done is going to fix them. Right? They're going to die, it's just a matter of time. So, just some things that can cause different kinds of shock. Got it all set up right here. Okay, so hypovolemic shock can be caused by multiple fractures. Okay, bones contain a lot of blood inside of them. Okay, but when a bone breaks, they're also razor sharp, which means they can start cutting up tissue on the inside. Okay, including blood vessels. So that can cause hypovolemic shock. Chest injuries can also cause that due to whatever issues got going on there, especially rupture to solid organs in the abdomen. Can lead to a ventilation-perfusion mismatch. Okay, so that can cause things like a pneumothorax that can go tension. Right, with some types of trauma, we may get air bubbles developing in the bloodstream. We'll talk a little bit about that later. Neurogenic shock, right, with spinal injuries, where they have what kind of appearance? Two-tone. What kind of appearance?
Two-tone.
What kind of appearance?
Two-tone.
Right, whereas they're pale, cool, diaphoretic above the injury because they're still able to kick what response? Sympathetic. Whereas below the injury, okay, they're flushed, right, they're dry, they start warm and cool down because they can't kick the sympathetic, so they default to what response? Parasympathetic. Okay, and that's all simply because the brain can't communicate anywhere below the injury. All right, septic shock, severe infections, cardiogenic shock from a massive MI, usually on the left side of the heart. Anaphylaxis is when they get exposed to something their body's not too happy with. Okay, and it overreacts to the immune system. All right, metabolic hypovolemic shock in the case of plasma loss. So due to excessive vomiting, diarrhea, urination, salivation, heat stroke, anything like that. And then psychogenic shock is basically patients who suffer a syncopal episode, which is just a fancy way of saying they fainted. So we got to think about the different causes of the types of shock, and of course, what categories it fall under, what do we got to do to treat it, how to identify the difference. All right, and we go from there. Okay, now with shock, of course, this is something that's going to be pervasive throughout the entirety of our course, right? Because we'll be talking about things that can usually lead to different types of shock. Okay, so something that's always pretty much going to be in the background of things we got to worry about. So we're going to go ahead and get into a trauma overview. Okay, we're going to pretty much do an overview of most of the things we're going to talk about for the rest of the next 2 nights, these lecture nights. All right, so we'll be kind of touching upon a few things, reviewing a few things we've already talked about, okay, setting up for what's to come. So when it comes to trauma, okay, we have to assess the mechanism of injury to determine what type of injuries we may suspect to see when we actually get to our patient. Okay, so just like we talked about yesterday in patient assessment, I'm looking for any physical clues, right, essentially playing CSI to see what I'm going to expect on my patients. Okay, so looking at damage to vehicles, skin marks, right, damage to the patient's body itself, things like that to determine what type of injuries we're going to expect to see. All right, so we have to worry about a little bit of physics, obviously not a physics class, Okay, but we do have to worry about a few things. Okay, things like kinetic energy, right? How fast somebody's moving for the impact. Potential energy usually relates to falls. The higher up they are, right, the more energy they're going to experience, especially once they hit the ground. Okay, as far as momentum and whatnot, okay, things in motion tend to stay in motion, right? Which is pretty much what we're going to see here, right? Which is going to be a series of ejections, right, from different car crashes. So that's a person.
Jesus.
This was not really an ejection, but still. All right, so as far as seatbelts, wear your seatbelts, kids, right? As far as that, we do have to worry about these types of injuries, right, for patients who are going to be suffering from ejections, right? So things like speed and stuff like that are going to be things we got to consider when it comes to car crashes, all right? So again, speed of travel at the MVA. So MVA stands for motor vehicle accident, sometimes referred to as a TC or a traffic collision. Basically, those are just fancy ways of saying car crash. All right, so we want to determine, again, how fast were they going at the time of impact? Okay, were they wearing seatbelts? If they weren't wearing seatbelts, what might happen to them? Ejections. Okay, but if they are wearing seatbelts, do I also have to worry about injuries caused by the seatbelt?
Yes.
Yeah. Okay, so were they not wearing seatbelts and thrown around inside the car, or were they thrown clear of the vehicle, depending on the issue? Right? Or were they wearing seatbelts and now I got to worry about that causing trauma to our patient? Okay, so we'll be talking about that. We'll see a few pictures. Now, when it comes to bruising, okay, bruising is always a late sign. Always what kind of sign?
Late sign.
Okay, so we always have to worry about that happening a couple hours after the actual incident, which for our purposes, especially for trauma, is a late sign. All right, so we may not see bruising right away, but we do have to be suspicious of it. Now, when it comes to car crashes, right, we have to worry about 3 different types of impacts: primary, secondary, tertiary. The primary impact will be object versus object. So car versus tree, for example. Okay, that is a primary impact. Secondary impact is patient versus the interior of the vehicle. So that would be chest versus steering wheel, for example, or head versus windshield. Okay, it's going to be some part of the patient versus some part of the inside of the vehicle. And then tertiary impact is internal structures of the body versus the body itself. So for example, brain versus skull, or lungs versus ribs. Okay, now when we're establishing some type of MOI for car crash, we have to think about these 3 things. Okay, so for primary impact, we'll look at any deformation to the vehicle itself. So we can see here, right, the front end's pretty messed up as it plowed into that hole. Okay, so that's a primary impact. Secondary impact, we'll be looking for anything like we saw yesterday: cracks along the windshield at roughly head level, bent steering wheel, airbag deployment, stuff like that to see, okay, what happened to the actual outside of the body. And then we have to turn on our x-ray powers and suspect what happened on the inside. Okay, so again, playing a little bit of CSI, right? You want to slow it down, turn on your x-ray powers, okay, when they hit their chest and the steering wheel, the heart is still moving inside of their body, smacking into the sternum, right? Or that brain is still moving inside of their skull, smacking against the front end, and there may be enough energy to make it rebound and then hit the back of the brain. There might be so much force that there's still enough momentum to go back into the front again. Okay, and then we got to worry about specific types of injuries based on those types of impacts. Okay, so we have to kind of recreate those injuries in our head to suspect what we may see later on, or what could potentially develop as time goes. So we want to look at PSI, or passenger space intrusion. Okay, so take a look at PSI, or passenger space intrusion in this case, which is how much of the car is going into the area in which people should be sitting. Okay, the more of the car that's going into the passenger compartment, the more energy there was. Now, based on that, PSI alone, For certain agencies, that'll be enough to indicate if this is a major trauma patient, therefore requiring transport to a trauma center. So I believe LA County is 18 inches. So if there's 18 inches of passenger space intrusion, we automatically take them to a trauma center. Because that means 1.5 feet of the car is no longer there. Right? We want to look at airbag deployment. Okay, see if the airbags have deployed. Right, things like that. So we'll talk about different types of impacts, but we have frontal impacts. Where obviously that's where the impact is happening to the front of the car. Now with frontal impacts, most modern cars are designed to have crumple zones, so they tend to look a lot worse than it usually is, right? Because they will deform and absorb some of that energy, transferring less to the actual patient themselves. All right, but we still have to assume that it looks bad, it's going to be bad. Okay, we also have to evaluate for any airbag deployment. Right, now most, again, modern cars will have airbags. Hopefully they will deploy. If they didn't deploy, crap, that means that patient took the full force of that blunt trauma. Now, can airbags cause injuries themselves?
Yes.
Yeah, right, but it's usually worse than your head going to the steering wheel. Right, but we still have to worry about injuries from the airbags themselves. Right, again, we can see a fair amount of PSI, passenger space intrusion. So unless they were sitting and driving like this, right, they're crumpled up pretty close, right, to that steering wheel. Okay, if our patient is pinned inside of the vehicle, we have to remove them via what process?
Extrication.
Right, extrication. Not extraction, but extrication. Okay, so we'd have to go and use the jaws of life to go and take that patient out. All right, so again, we got to look for seatbelt marks on the body as well. Okay, so these red marks that we see, not quite bruising yet, okay, but we call these abrasions, which is basically like a friction burn. So as that seatbelt tensions up as they're moving, it'll cause a friction burn on their body, giving them this appearance. Now, we do have to worry about internal injuries as well, okay, especially when it comes to the abdomen. Right, that seatbelt, right, usually comes across right here, and it may cross that left anterior axillary line. Right, now, of course, do we have to know what organs are where inside the abdomen?
Yes.
So, what organ do we have in the left upper quadrant?
The left upper quadrant, that's your spleen, stomach,
Okay, and
the intestine.
which ones?
Both.
Which are?
The large and small.
Right, gotta be specific. Okay, so small, large intestine. Now, between those organs, which one is a solid organ?
The spleen.
Spleen. Okay, and that spleen runs right across the left anterior axillary line right here. Okay, so if that patient gets that seatbelt hit right there, can that cause internal bleeding?
Yes.
Yeah. Okay, and those solid organs tend to tear, right, especially with blunt trauma. The hollow organs, since they're hollow, they will squish and give a little bit, right, but the solid organs don't. So in this patient, right, I'd have to worry about internal bleeding, and we can tell because they have a rigid and distended abdomen that's painful enough for quadrants, and when I check their skin signs, what skin signs would they have? No. Cool, pale, and because they're losing a lot of, and they're going into what kind of shock? Holy shit, do you guys see it now? Wow, can you see it now, Mr. Krabs? Okay, so, right, we want to go ahead and make sure that we're able to identify that stuff through the context of a patient assessment. Right, I'm walking up to somebody, hey, partner, go hold the head for me. All right, talking to our patient, getting airway, breathing, circulation, checking skin signs. Oh shit, he's pale, cool, diaphoretic. Checking his pulse, it's rapid and weak. Checking his cap refill, it's delayed. Right, he's saying he's got abdominal pain. Checking the abdomen, it's bulging out a little bit. I palpate, ow, 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 ow. Oh crap, this dude's got internal bleeding. He's going into hypovolemic shock. We got to get him out of here, right, so we can transport to a trauma center, taking him code 3. Right, that's kind of the gist of a primary assessment right there. Right. So we got to look out for that stuff. Now, could peritonitis happen? Sure. But peritonitis compared to internal bleeding is something that happens later on down the road. Okay. Again, it takes a little bit of time before the nasty stuff starts causing an infection. Okay. But internal bleeding is going to more acutely occur, acute in this case meaning sudden onset. It's going to develop a lot more quickly. Now, as far as rear impacts, okay, if somebody were to get rear-ended, we get a lot of whiplash injuries. Right, especially if they're not prepared for that impact. Okay, so if they're just sitting, doing whatever they're doing, then bam, somebody hits them in the back, that head's going to whip back, possibly hit the back or hit the headrest, and that brain is going to slosh backwards, hit the skull, may rebound forward, and then if there's enough energy, go back again. Right, obviously there's going to be cervical spine injuries as well. Okay, so we definitely do have to worry about those neck and head injuries, right, for rear impacts. As far as lateral crashes, okay, so these are your T-bones. Okay, these tend to be the most fatal of car crashes because of the lack of protection, right, to the passenger space. In the front, you got the engine compartment for most cars. In the back, you got trunk space for most cars. Okay, but with a lateral impact, you've got the door, maybe the A or B post, and that's about it. Okay, and depending on what it is that hits patients from the side, that's not going to do anything for them. Okay, and with these lateral crashes, we tend to have a lot of lateral whiplash injuries. The patients go side to side. And while our body's not designed for violent movement as a whole, okay, we don't tolerate side-to-side violent movement nearly as well as we do front and back violent movement. Okay, so lateral whiplash injuries, right, will crack necks. Okay, it can also, right, cause what's known as aortic shearing, which is where the aorta and the heart do this. Okay, and if that happens, is your patient going to survive?
No.
No, they're done right there. Okay, so we got to worry about those types of impacts as well if you're getting T-boned. Okay, we also have to worry about the actual blunt force trauma to the side of the body itself that gets hit. Okay, and if they're sitting down like this and a truck comes from the side, this whole side is screwed. Okay, we have injuries to the upper extremities, to the chest, the abdomen, the pelvis, the legs, lower legs, right, the head. Okay, so obviously a lot more damage here instead of a steering wheel to the chest, right, or head whipping to the back. All right, so we got to look out for that kind of stuff. And it's not only just T-bones, it's, you know, when cars get wrapped around trees or poles or anything like that from a spin out or they lose control, it's still going to have the same effect on the body. All right. As far as rollovers and rotational crashes, okay, if our patients aren't secured, what can happen to them? They get ejected. Or in the case of a rollover, what's worse would be a partial ejection. And a partial ejection would be worse in the case of a rollover because they might get squished. Okay, so if they're hanging outside halfway out of the car and the car is rolling, they just, and that's it. Right? Now, sometimes they may get thrown clear of the actual rollover itself, but they're still being thrown out of their car at a high rate of speed. Okay, and the same thing happens with rotational crashes. While the car's not spinning end over end, it's spinning around and around and around, okay, where they can still get thrown out of that car. All right, so part of our assessment is to try to get, reports from eyewitnesses to see, okay, what happened? What did the car do? Right? Was it spinning around? Okay? Or was it rolling over? Right? We'll have to do a walkabout of the scene to make sure that nobody actually did get thrown out and we didn't see them, right? And we missed that patient. Okay, so we generally do have to do a walkabout of the scene to make sure that there's no other patients there, right? And get an idea of, scene hazards and things like that before we actually start treating our patients. All right. Now, as far as auto versus pedestrian, who's going to win?
Auto.
Auto always wins. Okay. So we have to think about damage to the patient, obviously. Okay, where exactly did the car hit the patient? And there's different MOIs based on size of patients. Okay, usually between adults and pediatrics. For us, if we were to get hit by a regular sedan like a Honda Civic or whatnot, okay, most of the impact is going to be to the lower part of the body. Okay, it's going to take out our pelvis, which would be bad. Take out our femurs, still pretty bad, right? But it's usually lower injuries. And when we get hit as adults, we tend to go up and over the car. Whereas kids, since they're lower, they're going to get that impact more to the core of the body. And they tend to go down and under when they get hit. Okay, so we have to think about that type of injury pattern to our different patients. And we can do so by looking at the damage to the vehicle itself. Okay, because when a car hits a person, there will be damage to the vehicle. It's not like GTA where it's like, oh well, right? Okay, there will be damage to the cars. When it comes to auto versus bicyclist, who's going to win? Auto. Okay, so we're going to look at the same types of injury patterns for bicyclists, but now we're going to ask, okay, were they wearing their helmet? And if they were, what damage was sustained to the helmet? And whatever damage was sustained to the helmet, we're also going to assume that type of damage was sustained to the head. So if they cracked their helmet, we have to assume they also cracked their skull. Right? Assume the worst, hope for the best. Okay. So if they got a broken helmet, we're going to assume they're going to have some type of head injury, skull fracture, at the very least. Okay, and then we'll treat for any other types of injuries. Of course, for both pedestrian and bicyclists, we got to worry about spinal injuries. Okay, so we want to prep them for spinal mobilization, which we'll talk about later tonight. right? For motorcyclists, again, car will always win. But there's other things we got to think about. Just like a bicyclist, we got to worry about the helmet. Whatever happened to the helmet, we assume happened to the head. Okay, but also if they're wearing any protective gear. Okay, so if they're wearing their slide-resistant clothing. Okay, we want to determine if they were sliding in the first place. Right, or if they're one of those knuckleheads that's wearing a tank top and shorts and flip-flops on a bike, doing 120 down the highway. All right, we want to look out for that kind of stuff. Now, different types of crashes. There's a head-on crash, which is exactly what it sounds like. The bike goes head-on. Usually, that results in ejection. Okay, since there's nothing holding on somebody to a motorcycle, right? Again, obvious motion, stay in motion. They hit something, they go flying over. Okay, we got to worry about angular crashes. Okay, where the motorcycle comes off at something and then may bounce off. And if that's the case, we're going to see a lot of crushing injuries to the legs. Okay, so if they're coming up and they were to sideswipe a car or something like that, a wall, okay, they may crush whatever leg is on that side and then eventually go down. We also have to worry about controlled crashes. Okay, so did the rider see an impact coming, and that's when they put the bike down into a controlled slide and then go from there. And now, just because they put the bike down intentionally doesn't mean they're not going to walk away from this injury. Right? They still could be going at a high rate of speed, and that's where we have to look at skid marks. Right? How long was the skid mark, indicating about how fast they were going? Okay, what does the equipment look like that they're wearing? So if they were wearing their leather equipment, right, is it burned all the way through, or is it just kind of scuffed? And if they weren't wearing any type of protection, how bad, right, is the actual trauma to their body? Okay, these are things we got to worry about. And of course, possible spinal injuries. When it comes to falls, okay, first thing we want to consider is height of the fall. So the national training standard, it's kind of in between right now. They say anything between a 15 to 20 foot or higher fall will be considered critical. Okay, so 15 to 20 feet or above will be considered a critical fall, or 3 times the patient's body height. Okay, so 15 to 20 feet, or 3 times the patient's body height will be considered a critical fall. Because they're taking into account, NBA players and stuff like that. All right, but there's also other things we have to look at. So, in addition to height, what was the surface they fell onto? Okay, so what kind of surface did they fall onto? Did they fall on concrete? Or did they fall in like wet grass or mud? Or was it at the playground? They landed on that soft spongy material? Okay, what was it that they actually landed on? And then we have to figure out what part of the body hit first, followed by the path of energy displacement. Okay, so how high did they fall? What surface did they land on? And what part of the body hit first? So in this case, we have a kid falling out from a tree, okay, landing feet first, right? Now, based on the way this is, their knees look kind of straight. So when they land, right, their knees probably won't bend to absorb. Instead, they're going to lock straight, which will transfer energy through the knees up to the femurs, right, and then possibly cause hip fractures, hip dislocations, anything like that. Maybe, right, blow out their knees and bend them backwards and dislocate them as well. Okay, that's why I always tuck and roll. Okay, so when you land, knees bent, that'll act as a shock absorber, right, reducing the amount of energy going in, and again, may allow the patient to roll. So we want to ask them what part of the body hit first, or ask somebody else if the patient's unconscious. How do they fall? They land feet first, head first, on their side, on their arm. That way we know which way the energy was going and what injuries we have to suspect. Now, in the case of falls too, we got to worry about the spine. Okay, when we talk about spinal injuries, we got to worry about compression injuries. When they land, the vertebrae will do that. Okay, and the vertebrae may fracture. We may have herniation of discs. Okay, so the cartilage in between will kind of pop out a little bit. Okay, so we have to worry about those types of injuries as well, not just, they landed on their feet, so we got to worry about feet injuries. All right, for blunt trauma, okay, this is all going to be the start of trauma being very
straightforward.
Straightforward, finally. Okay, trauma being very straightforward. Trauma is also very binary as well. Okay, because we have blunt trauma, which is where the skin is closed in most cases, but we also have penetrating trauma, where the skin is now open. Right, so we have blunt trauma, we have penetrating trauma, closed injuries, open injuries, fractures, dislocations. Okay, different types of things. It's one or the other for trauma. Now with blunt injuries, okay, again, the skin is generally going to be closed. Okay, so everything's going to be happening on the inside. Do we have x-ray powers?
No.
No. So I can't see what's happening inside the patient, but are there going to be outward signs to indicate what's happening on the inside? Yes. Okay, and that's the stuff we have to look out for. So again, seatbelt marks across the abdomen. Okay, this is what distension looks like. But distension just means bulging out. Okay, this guy could have a beer belly. Right? Technically, that's distended. But is that really a problem? Not by itself. Right? But if I were to palpate and it feels like he's got a six-pack and he's groaning every time I palpate, does that indicate a problem?
Yes.
Yeah. Especially if I see bruising, which is what kind of sign?
Late sign.
It's a late sign of internal bleeding. Okay, so bruising doesn't necessarily happen right away. Okay, it's a much later sign that we may not even see in the field when we're with our patients. Okay, but the fact that it's rigid, distended, with pain in all four quadrants, and he's pale, cool, and diaphoretic, right, that is what's going to tell us that the patient has internal bleeding, and is therefore going into what kind of shock?
Hypovolemic.
Kind of shock?
Hypovolemic.
Kind of shock?
Hypovolemic.
Right, due to what kind of organ rupture?
Internal. Or
Solid. Solid organ rupture. Yeah, obviously internal. Okay, solid organ rupture. All right. Technically, no.
Technically not.
All right. So we'd have to be on the lookout for that. And when it comes to trauma, just again assume the worst, hope for the best. Okay. Yeah, this guy may just have a beer gut, right? But when I palpate and it's firm to the touch and hurts every time I palpate, it's more than just that. All right. We know that it's going to be full of blood, or in the case of hot flush diaphoretic skin, full of nasty stuff, causing peritonitis. All right. When it comes to penetrating injuries, okay, this is when the skin is now open. Just to let you guys know, we're in trauma now, so there will be some graphic pictures. Figured most people would know that. I had a girl in my last class start feeling nauseous when this came on, not knowing that trauma was coming up.
So, like, do you get, like, desensitized to it after a while? Because I'm, like, cringing every time I see one.
Yeah, you get used to it. It's different when it's in person, but pictures are nothing nowadays. So, as far as penetrating injuries, okay, again, this is when the skin is now open. Now, with penetrating injuries, we have to be careful about internal bleeding. Right? Now with this, yeah, there's some blood there, but especially with these types of injuries, the guy's got a little trickle of blood. I know, when you look at it, it doesn't look that bad. Okay, but there could be a lot more potential for internal bleeding on the inside that we can't see. Okay, so we always assume the worst and hope for the best. Okay, we don't know, again, how much damage is actually inside the body. We don't know what caused these wounds. Okay, but there's going to be things such as cavitation we got to worry about. We'll talk about that in a little bit, especially with high velocity penetrating injuries. Okay, and when it comes to penetration injuries, the higher the velocity, the more damage there tends to be, more so compared to the mass of the actual object itself. Okay, so it's really a matter of velocity over mass when it comes to damage.
Is that because it just has a higher chance of piercing the organ?
Not necessarily. We'll talk about it. So, this guy's got quite a few different injuries, obviously. So he's got what we call an avulsion, and we'll talk about these terms more on Monday. He's got an avulsion to the scalp, okay, which is basically a flap of tissue that's been cut off. All right, either partially or fully. Looks like a partial avulsion here. He's got a laceration, which is a fancy word for a cut, right across his neck. There's a very specific treatment we'll talk about in a bit. And he's got penetrating injuries to the chest, resulting in possible sucking chest wounds. So whoever this guy pissed off, he pissed off really bad, right, causing different types of injuries. Okay? Now, as far as low energy or low velocity penetrating injuries, okay, these are things like stab wounds or impalements. Right, now with certain types of MOI, we do have to worry about internal injuries. For example, with stab wounds on the outside, we don't really see a big, giant open wound in most cases. It's usually a little slit the size of the knife blade. But on the inside, could there be more damage?
Yes.
Absolutely. Okay, especially if the attacker stabbed the patient, twirled that knife around on the inside, right, creating a cone of damage, and then maybe they pulled that knife out, and again, all we see is a little slit in their body. And they could have done it again, stabbed, twirled, taken out, stabbed, twirled, and done that multiple times. Okay, so we have to be on the lookout for, a lot of internal bleeding, especially depending on where the injury's at. Now, as far as impaled objects like this, where it's still in the patient, okay, we stabilize impaled objects. Okay, so we stabilize the impaled object unless it interferes with CPR or it obstructs the airway. Okay, so we stabilize impaled objects unless it interferes with CPR or it obstructs the airway. We'll talk about different techniques for stabilizing on Monday, okay, but I want to try to leave that in place unless it gets in the way of CPR or it obstructs the airway. Now, as far as the airway, we want to take it out because airway is king. Okay? If they don't have a patent airway, they can't breathe, they die. So we take that object out and we do what I like to call quick and dirty bleeding control. Okay, so just do whatever you can to quickly stop that bleed, but we want to focus on the airway. Now, in the case of interfering with CPR, okay, we want to take it out because we want to try to do CPR if they're in full rest. All right, now it depends on where the actual penetrating injury is at. Okay, if it's directly in the heart, obviously we got to take it out. But if they stab their heart, is CPR really going to help? No. Okay, in the case of most traumatic full arrest, CPR is not going to help. Okay, all we're doing really is putting on a show. All right, we're following protocol. They don't have a pulse and not breathing, we do CPR. All right. Now, in most cases, we're not going to transport the patient. We're going to work up the mandatory amount of time CPR we have to do and be like, okay, that's it, they're done. All right, because we generally don't know what's happening inside, right? Especially with like heart crashes and whatnot, they could have that aortic shearing. If the heart and the aorta aren't attached, no amount of CPR is going to fix that. Right? So we just have to do it just because we're protocol driven in that sense. But if the object is not in the way of CPR and not obstructing the airway, what do?
CPR.
We stabilize it.
Oh.
Yeah, we stabilize it. Even if they are in cardiac arrest, if they got stabbed down here, is this going to interfere with CPR? No. So I just stabilize it and I just do CPR. Right? We'll leave it as is. Now again, the time we use prone is if we have one of these impaled objects in the back that does not meet the indication for removal. Okay? So if I got a patient who got stabbed in the back of their leg, okay, can I take it out?
I don't know.
No, you can't. Is it going to get in the way of CPR? No. Is it in the airway?
Oh, no.
Absolutely not. Okay, so we just leave it as is, right? Therefore, if they're conscious, right, then I go ahead and just keep them prone, but keep that head off to the side. But if they're in cardiac arrest, okay, and I roll my patient supine, right, then we have to take it out. Otherwise, that knife just goes right through the leg. Don't want to do that. Okay, so if it doesn't meet the indications for removal, then we just leave it as is. Now, when it comes to gunshot wounds, okay, the velocity, again, has to do with the amount of damage that's going to be on the inside. So gunshot wounds are medium or high velocity penetrating injuries. A medium velocity penetrating injury will be caused by patients who get shot by handgun caliber rounds, 9mm, 45, anything like that. Shotgun shells as well. Okay, so buckshot, slugs. Whereas high velocity would be anything from a rifle.
If you were to show up on a scene and there's a gun that's outside of its safety, would that scene be considered dangerous still, or safe?
You could make it a case to call for law enforcement at night. Yeah. All right. And usually any type of shooting, right? Whenever a gun's been discharged, law enforcement will be there. So, as far as cavitation, okay, cavitation is essentially the transfer of energy from that projectile into the body. And the faster the object is going, the more cavitation there will be, the more transfer energy there will be. And there's two different types of cavitation. There's temporary cavitation and permanent cavitation. Okay, we have to consider both of those when it comes to injuries due to gunshot wounds. So as far as temporary cavitation, just as the name implies, it's only there temporarily. Okay, quite literally for just a split second. In fact, the way I usually think of temporary cavitation, I think of it more of an explosion compared to anything else, because it's just a quick inside the body. Right, but as things expand, whatever's inside of that range, okay, is going to get damaged. Right, whereas the permanent cavity is basically the hole or the tunnel that's left inside the patient's body. Right, so with this clay, right, and they'll do all testings with different ballistics and whatnot. With clay, it doesn't go back like it normally does. It'll stay open. So this will give you an example of how big the temporary cavity can be, right, compared to the entrance and exit wounds. Okay, so let's say, for example, I have a patient who gets shot in the right upper quadrant. All right? Miss, what organs do I have to worry about in the right upper quadrant?
You need to worry about the gallbladder, liver,
And
appendix.
nope, the appendix.
Liver.
Nope.
The small intestine and large intestine.
Right, the small, large intestine. Okay, so if that patient were to get shot in the right upper quadrant, does the bullet have to hit the liver to affect the liver?
No.
No, it doesn't. Okay, all that has to happen is that liver has to be within the range of that temporary cavity for it to get lacerated. So they can get shot a little bit below the liver, right? But the liver can still start bleeding, okay, as it gets hit by the temporary cavity. Not only that do we have to worry about for gunshot wounds, okay, but bullets don't go through people in straight lines. Okay, they will zigzag, they will not come out of the body, they will tumble, they will fragment, they will ricochet. Okay, bullets will do some very weird stuff when they enter a human. Okay, so usually when we have a patient who gets shot somewhere in the core, we do a complete strip and flip. What do?
Strip and flip.
Right, we cut off all their clothes, right, and we check the body front and back, checking for entrance and exit wounds. Okay, so as far as the relation, right, here we have the temporary cavity in blue and the permanent cavity in red. Okay, so again, this is there for just a split second. Okay, but whatever's in the way of that temporary cavity is going to be damaged. So again, the bullet doesn't have to hit the liver, for example, directly, but the liver can still be damaged in the case of gunshot wounds. Okay, you can see the bullet enters in, but it tumbles and then happens to just go back out in a straight line, right? But that tumbling will also carve more tissue. Okay, certain bullets like hollow points, again, they will mushroom and expand out, creating a bigger wound channel. Okay, those things can also fragment and then start causing different multiple wound channels in the body. They can hit bone, right, which will cause the bullet to fragment, can ricochet. The bone fragments can then start causing more damage. Okay, so there's a lot of different things we got to worry about once somebody's been shot. All right, so as far as assessment for gunshot wounds, we have to try to. So patients can be sitting completely still and not moving, but to them, the whole world's spinning all over the place. Okay, so that's going to be a very common complaint for patients who have sustained, right, some type of barotrauma, right, which is injury caused by pressure differences. All right, as far as other things, we got to worry about neurologic injuries, primarily head and spinal injuries, especially if the patient is flying through the air, just like they do in the movies. Okay, they can land on their head, compromise their neck. Okay, we have to worry about traumatic amputations. So again, limbs may be blown off, right? There may be severe lacerations due to shrapnel on the patient, so a lot of blood loss. Okay, so obviously when patients are injured by explosions, there's usually a lot of things that are going on with the patient. All right, when it comes to injuries of the head, which we'll have our own chapter coming up next, okay, we have to obviously worry about the brain being damaged in the case of head trauma. So here we have an example of a patient who's receiving a secondary injury, right, secondary impact injury from their head smacking the windshield. The tertiary injury is their brain going into the skull, causing trauma. Okay, now that brain is surrounded inside the head by cerebral spinal fluid, or CSF. Okay, and it's going to act as a cushion and a shock absorber for most of the time. But in cases of head injuries like this, the brain's not designed to rattle back and forth inside the skull. So the brain's going to smack the front of the skull. It's going to squish and rebound, hit the back of the skull, and depending on how much energy is left, may go back and hit the front one more time. Okay, so we have damage to the front and back of the patient's brain, right, with the different lobes being affected. So, sir, what is the name of the lobe in the front of the brain?
The frontal lobe.
Perfect. What is that responsible for?
Okay. Real quick. So it's not touch. It's not sight. Motor functions.
No. Sir? What's frontal lobe responsible for?
Would it be touch?
It would not be touch.
Behavior and mood.
Right, behavior and emotion. Okay, so if I got a patient who's got damage to the front of their brain, okay, could they have mood swings?
Yes.
Could they be altered?
Yes.
Yeah. Okay. As far as the back portion, sir, what's the back portion of the brain called? What lobe? Yes.
The occipital lobe.
And what is that responsible for?
Balance.
Nope.
Motor control.
Nope.
Sight.
Yes. Vision. Okay, so in this case, right, our patient who's got frontal lobe damage, okay, they may start having mood swings. They may become combative. Okay, they're going to be altered. All right, and because now that brain's rebounding on the back of the skull, could they have some visual problems?
Yes.
Yeah, right. They may have, double vision. They may have blindness. Okay, they may have specks in their field of view. Okay, they may have some type of vision problems, right? And that's why we have to know what different parts of the brain do, because we can determine which part of the brain has been damaged based on deficits our patient will sustain. Same thing goes for patients who are suffering from a stroke. Okay, if that brain becomes ischemic, right, there's going to be issues with that, and I can tell where that stroke is happening based on the deficiencies our patient will have. All right. Now, in case of most of these back and forth injuries that we call coup contre coup injuries, okay, it's French, so they spell it all weird. Yep, C-O-U-P. All right. So with the coup contre coup injury, okay, we typically are going to see frontal and occipital lobe damage as that brain is rattling back and forth. Okay, but in the case of side to side movement, okay, that brain can also be sloshing side to side, causing damage to temporal regions, right? And as far as the temporal lobe of the skull or the brain, sir. What is the temporal lobe responsible for?
Motor function?
Nope.
Hearing speech.
Hearing and speech. Okay, so therefore, with that side-to-side movement, right, our patient may have problems with hearing and speech. Okay, so again, we have to try to figure out what's going on. Now, when that brain gets injured, the brain begins to swell. Okay, in fact, any injured tissue, no matter what it is, will begin to swell. Think about it. You sprained your ankle, is it going to stay the same size? No, it's going to what?
Swell.
Because your tissue has been
Damaged.
Injured. Right? And the brain is no exception. And when that brain begins to swell, sir, what's going to start building up inside of that head?
Pressure.
What do you call that pressure if it's inside of the head?
Intracranial pressure.
Intracranial pressure. Okay? And when we have that buildup of ICP, right, if the meninges have been torn, that brain juice, that CSF that surrounds the brain and spinal cord, may start to leak out of the ears or out of the nose. So as we're doing a physical exam, right, if I see brain juice coming out of there, crap, that tells me they got some ICP. And at the very least, they've also torn their meninges. Okay, there's also going to be changes to vitals we'll talk about, okay, that we're also going to see when our patient has ICP, or intracranial pressure. All right, there's a whole slew of signs and symptoms that go along with it, and any type of neurological deficit you can think of can possibly be caused by head injury. So we just have to know if there's an MOI that may cause brain injury. All right, as far as injuries to the neck, okay, obviously the neck is very important, right, because we have a lot of vital stuff going through the neck. We, of course, have the trachea, which is the airway. Okay, we have the esophagus, which is going to be putting food right down to the GI tract. We have our major blood vessels, being the carotid and the jugular vein, so the carotid artery and the jugular vein. Okay, so if the patient sustains a blunt injury to the neck, possibly even the trachea, that can cause tracheal rupture. Right, and if they rupture that trachea, essentially think of like a steam pipe that'll have a leak and start putting all this pressure out. The trachea is kind of the same way. Not nearly as much pressure, but we're going to start leaking air into that fatty layer of skin surrounding in the neck, which will lead to subcutaneous emphysema. Sir, what else will lead to subcutaneous emphysema?
Tension, pneumothorax.
There we go, finally. But what other signs am I going to see in the neck besides subcutaneous emphysema to indicate a tension pneumo?
Jugular vein distension.
And
subcutaneous that. No.
Sir, what else are we going to see to indicate a tension pneumo besides subcutaneous emphysema and JVD?
I don't have the answer.
Sir?
Is it swelling?
Nope. Sir?
Some tracheal, I don't know the other part of it. It's just like when it shifts.
Right.
There's something tracheal. I forgot the other part.
You got to know the other term, sir, but you're right. The trachea is moving. Miss, what do we call that?
Tracheal deviation.
Right, tracheal deviation. Okay, so if our patient has tracheal deviation, jugular vein distension, and subcutaneous emphysema, those three things together are indications of a tension pneumo. Okay, but as far as subcutaneous emphysema, all that is air trapped in the fatty layer of skin. Okay, which our patients will have if they have blunt injuries to the neck, especially affecting the trachea. Okay, so they'll have the snap, crackle, pop, but there's no JVD and there's no tracheal deviation, right? Because we just have air escaping to the local space, right, local area. Right, now technically, again, I can have subcutaneous emphysema happening anywhere in the body. Okay, if I were to take a little, box cutter or whatever, cut in somebody's abdomen and take an air hose and put air into there, is that going to cause subcutaneous emphysema? Yeah. Okay. So we can get that air in the fatty layer of skin anywhere, right? But if I have with those other signs, then we know for a fact the patient's got a tension pneumo, where they have all that air building up in there.
Potential space.
And they're what?
Potential space.
And they're what?
Potential space.
And they're what?
Potential space.
Right. Okay. Now, as far as lacerations to the vessels, right? If our patient has a carotid artery laceration, we'll talk about how to fix that later. Okay, but they're going to have bright red blood spurting out of their neck. Okay, and is that a life-threatening injury?
Yes.
Absolutely. So we see it, we treat it, and we'll talk about that on Monday. Okay, the other laceration we have to worry about is a jugular vein laceration. Now, with a jugular vein laceration, okay, because it is a venous bleed, right, the blood that's coming out is going to be dark red, and it's going to be oozing out of the patient, right? So venous bleeds are dark red, and they ooze out of our patient's body, whereas arterial bleed tends to be bright red, and it spurts out of the body. Now, with the jugular vein laceration, okay, not only do we have to worry about blood loss coming out of the patient, but we have to worry about air getting sucked in to their bloodstream. Okay, since we have that blood draining from the head, working its way down, right, and we have a laceration, it's a negative pressure vessel, which means it's going to start sucking in air, right, as that blood is flowing down. Okay, and if we have an air bubble that accumulates in the circulatory system, okay, it can eventually get stuck in their lung, creating a pulmonary embolism, which is one of our obstructive shocks. Okay, now in order to fix that, where we don't get that air going into the circulatory system, we have to take a very special type of dressing, known as an occlusive dressing, known as what?
Occlusive dressing.
Right, occlusive. Occlusive just means airtight. What does it mean?
Airtight.
And this is an example of an occlusive dressing. Okay, I can use anything that's airtight and preferably sterile. Okay, now this is a Vaseline gauze. Okay, so inside we have a 4x4 slathered in Vaseline, but we actually don't use that. Okay, so what we do is we take this, we open it up, we throw away the contents, and I use the wrapper of the actual Vaseline gauze as my occlusive dressing. Okay, so that's kind of the joke in EMS. The contents of this thing are basically useless. The wrapper is more important than anything else. Okay, so we go ahead and toss whatever's inside, and the inside of this is sterile. Inside is what?
Sterile.
So obviously that's the side I want against the patient. All right, so we'll place this over the jugular vein laceration, and we want to seal it off on all four sides. So we're going to take our tape. Okay, we're going to tape it down using what I call the 50-50 method, because half the tape goes on the dressing and half the tape goes on the skin to create a seal. All right, so we'll go ahead and seal this off. All right, just like so. Okay, and then what we're going to do is we're going to press it over the laceration and try to seal off as best as we can. Okay, and what this does is prevent any air from going into the jugular vein, right into the bloodstream, therefore stopping air bubbles and reducing pulmonary embolism. All right, so we want to go and seal that off, right? And that's really our main concern with the jugular vein laceration. Yeah, we do want to take care of the bleeding eventually, but I want to stop that air from going in because that's going to create a much more serious complication that's really hard for us to fix. In fact, it's impossible for us to fix in the field. All right. Now, we are going to be using occlusive dressings for other injuries. Okay, we can use it for eviscerations, we can use it for sucking chest wounds, and of course we can use it for jugular vein lacerations. Okay, and there's different ways in which we'll seal off those dressings depending on what the actual injury is and what it calls for. All right, so as far as injuries to the chest, okay, we have the same breakdown. All right, we have the same issues here. So we have open injuries, closed injuries. As far as injuries to the chest, one closed injury will be a flail chest, which is 3 or more ribs that are broken in 2 or more places. Okay, so 3 or more ribs that are broken in 2 or more places. And that will create a paradoxical movement. What kind of movement?
Paradoxical.
Right. Paradoxical is a fancy word for opposite. So now we get an opposite movement of that flail segment of the ribs. Okay, now the reason why we end up getting that paradoxical movement is those 3 or more ribs that are broken in 2 or more places are no longer attached to the rest of the rib cage. Okay, if it's broken in 2 or more ribs, right, that's not enough to create paradoxical movement. Right, the body's still able to compensate for those 2 broken ribs being completely detached, but once they break a 3rd rib, the body can no longer compensate for that detached segment.
Do they have to be like,
Consecutive, yes. Yeah, got to be consecutive. Cool. Yeah, I can't have broken rib here, broken here, right? Because the intercostal muscles will be holding those ribs together. But if it's all together in one chunk, then that's going to be creating paradoxical movement. All right. So as far as what the paradoxical movement actually is going to look like, all right, we'll see this and play it back a few times. Okay, but obviously the side with the tube going into the chest, that's the injured side. Okay, so you can see that his chest is moving in opposite directions every time they inhale. Okay, now every time we breathe in, our chest expands outward, creating negative pressure, right? But that broken piece is getting sucked inward because those ribs are no longer attached to the rest of the rib cage. Right, so inhalation as the belly goes up, chest goes out, right? But we can see that broken piece get sucked in. Now, about half of the patients that end up sustaining a flailed chest don't survive. Okay, because there's blood vessels that run under each rib. Okay, so obviously when the ribs are broken, those usually break, causing a decent amount of bleeding. And the more ribs you have broken, the more bleeding you have. Okay, broken bones are razor sharp. So the ribs are going to start poking holes in their what? Lungs, creating a pneumothorax, which is just going to complicate this problem even worse. Okay, now like I said, years ago, we used to have a treatment for this. But now we just go, damn, that sucks. Let's go to the hospital, and that's it, right? Because the treatment didn't do anything for the patients. All right, so we just identify it, get them out of there. Now, as far as a pneumothorax, that's just a collection of air in the potential space. But a tension pneumothorax is a lot of air collecting in their potential space, eventually causing a shift of everything inside of the chest. Okay, now again, tension just means what?
Pressure.
Pressure. There we go. Right. Tension just means pressure. So the tension pneumothorax, that's a lot of air creating a lot of pressure inside of the chest.
How painful is it, like that stuff moving to the side?
I would imagine it's fairly painful. All right. So as far as the differences in the X-rays here, okay, this is just a regular plain old pneumothorax. Right. Everything in the chest still looks like it's where it's supposed to be. We do have a collapsing of the lung because I can see the ribs on this side, whereas this lung is still intact. Okay, so when I auscultate lung sounds, I'd have diminished lung sounds. I'd hear since we can still hear everything over here. But with this patient who's got a tension pneumo, okay, this little magnet, when they're reading X-rays, right, they'll put a magnet RL to show which side it is. This is obviously the right side of the patient. Okay, here we have nothing going on. So if this patient were dead, okay, every time they'd auscultate, the patient would inhale. Right, we'd have diminished lung sounds because that poor little lung's getting squished, and there's nothing but air on this side. Okay, now eventually things will start to shift. Okay, this mass right here is the patient's heart. And where is our heart supposed to be, on the right side or the left side? It's supposed to be on the left side. But it's now shifted completely over to the right side. So if your heart is on the exact opposite side of the chest, do we have a problem?
Yes.
Yes. Okay. Now because of all that pressure, that poor little heart is getting smashed between those lungs, causing blood to start backing up to the patient's jugular veins. So what would you see in their neck? JVD. Okay, this tube right here is the trachea. And the trachea is supposed to run where?
Down
the middle, so down what line?
The midline.
Midline. So that trachea is supposed to run all the way down here. But we can see that it's starting to shift over to the right side. Okay, so that trachea is getting dragged over as everything has moved past midline. Okay, now with all this air pressure building up in here, it wants to move out to an area of low pressure where it can relax. Okay, but it can't completely escape the body. It's going to get stuck in our fatty layer of skin, creating what condition?
Subcutaneous
emphysema. So if I were to go to palpate, we get what sensation?
Snap,
crackle, pop. Okay, from all that air building up here. Right, now like I said, that plastic bag video that I showed you, everything's squishing in because there is no divider. But in the chest, we do have a dividing section here. So pretty much everything inside the chest, except for the lungs, lies in a cavity known as the mediastinum or mediastinum. You don't have to worry about spelling, we'll see it later. Okay, but that's going to separate the right side from the left side. So as we have all this air building up on one side, it's going to fill up in this little cavity and then cause everything else to move over as it makes room for itself. Okay, and that's where I would end up getting the shift. Now, we don't really talk about it, but we can see movement, right, of everything else inside the abdominal cavity. So the diaphragm now is going to kind of do this weird wonky thing, right, and moving abdominal contents out of the way as well. Okay, but we're focused on looking at things in the neck to identify what's actually happening. Question?
Yeah, could that, like if it shifts so much, could like aortic shearing occur?
No.
No.
All right, because the aortic shearing is a violent movement. It's got to happen super quick. This is a little bit more gradual.
And it would never gradually shift until...
They'd be dead by that point.
Gotcha.
Yeah, the heart would be smashed to where it's not going to pump.
In stabs and gunshots, why doesn't the air just come back out the hole?
It does, as long as that hole is still open. But if there's blood will eventually coagulate and clot up and plug up that hole. Yeah. All right, so as far as abdominal injuries, right, we have to worry about the different types of organs inside being ruptured. Now here we see bruising, so is that an early sign or a late sign?
Late sign.
That's a late sign, right? So that tells us that patient's been bleeding for a couple of hours now, right, for it to start getting that kind of discoloration. Okay, but at the very least, we do know that there is some type of solid organ rupture happening inside the abdomen. All right, so we do see a little bit of distension as well, kind of a bigger belly. Now I can't tell if it's more significant bleeding because I have to palpate to really tell the difference, right? But again, we do see a bigger belly, right? That's going to be an indication of distension. Now, if the patient were to rupture hollow organs, creating peritonitis, are we going to see bruising?
No.
No. Okay, because bruising is bleeding, right? Whereas peritonitis, there won't be any type of bruising. Okay, it's just going to be a big belly, firm to the touch, and hurts every time we palpate. And their skin signs, because they have infection, would be what? Hot, flushed, and diaphoretic, because they're fighting off what? The infection, right? Fighting off peritonitis. Now, if that infection were to travel around the body, what kind of shock would they be in now? Septic. They'd be in what?
Septic.
They'd be in what?
Septic.
But is peritonitis itself the same as septic shock?
No.
No, because peritonitis is not widespread. Okay, peritonitis is just a localized infection in the abdominal cavity. A big infection, yes, right, but it's not traveling and affecting multiple body systems. It's self-contained within the abdomen. Okay, but once that nasty stuff gets access to the bloodstream, all right, it can now travel wherever it wants in the body and then cause further infections. Okay, so we again have to pay attention to their vitals to determine, okay, is it just a regular old infection like peritonitis, or holy crap, has this thing gone septic? Right. As far as multi-system trauma, the more places there's injuries, the worse off your patients will be. It's common sense, right? Especially in certain parts of the body, right? Chest and abdominal injuries, we got a lot of important stuff in here, right? So the more areas that are involved, the more trauma and injuries we suspect. So this guy here has appears to be a gunshot wound, obviously some type of puncture injury at least, okay, and that could be a sucking chest wound. So to fix that, again, they take an incision, cut between the ribs, and then shove a tube in there to vent out any excess blood and air coming out of the patient's chest. All right. So we're going to want to transport these patients to a trauma center with multi-system trauma to get them the best care they can, because again, they'll have the most resources and training to take care of this patient's condition. So our job on scene, right, is to stabilize our patient, package our patient, all right, and assess them, and get them off scene within how many minutes?
10
How many minutes?
10.
And what do we call those 10 minutes?
Priority.
Platinum 10, because we're trying to beat what hour? The golden hour, right, where they have the time of onset of injury illness, the time of definitive care. Okay, so again, we want to get these patients off scene as soon as we possibly can to get them to the hospital as quickly as we can to give them the best chance of survival. Okay, now here in LA County, most of the time we should be able to beat that golden 10, or golden hour rather. But in other places, right, where we have 3 to 4 hour transport times, are we going to beat that? No, right, because it's too far. Therefore, what do we have to call for?
Helicopter?
We have to call for a helicopter, right? We'd have to consider flying that patient out, right, to get him to a trauma center within a reasonable amount of time. Okay, so while we don't have to do that much here in LA, sometimes we do, right? If you end up working in some places more rural, yeah, you're going to activate air medical and get them flying out. That's pretty much it. I don't have to go over the actual levels of trauma since we covered that already. All right. So now we're going to get into head and spinal. Okay, so for most of our other trauma chapters, we're going to be focusing on specific body parts, specific types of trauma, whatnot. Okay, and for Monday's lecture, there will be quite a bit of review since there's only so much trauma we can actually talk about. All right, so as far as head and spinal injuries, okay, are these going to be serious injuries?
Yes.
Yeah, right, because there's going to be some pretty important body parts that are going to be affected. Right, what do most of us have inside of our head?
Brains.
Right, okay, and of course there's also spinal cords, right, that are running through there as well. So as far as the nervous system, right, we have the central nervous system, which is the brain and spinal cord itself. And then we have the peripheral nervous system, which is everything else branching out of the brain and the spinal cord. So the three nerves that we are going to talk about in this class are all part of the peripheral nervous system. All right, the oculomotor nerve, the vagus nerve, the phrenic nerve. Okay, they're all parts of the peripheral nervous system. There are sensory nerves, right, that will bring information from the environment into us to process. And there's motor nerves, okay, they're going to go out to muscles and control those different types of muscles. Okay, so does that also include smooth muscle?
Yes.
Yes. Okay, smooth muscle does have motor nerves going to it. That's why if our patient sustains neurogenic shock, okay, below the injury, yes, what's going to happen to their blood vessels below the injury with neurogenic shock?
Can you say that again, please?
What's going to happen to the blood vessels below the injury when the patient sustains neurogenic shock? Yes?
Don't they go back to regular?
What do you mean go back to regular?
They're different. It's two tones.
Okay, but that's not what I'm asking. I'm asking what happens to the blood vessels below the injury when they sustain that type of injury.
Where part of it is cut off.
Yeah. Nice.
Dilate?
Are you asking me? You tell me.
Tell me. They dilate.
They dilate. Why do they dilate?
Because they fall into parasympathetic.
Okay, so why do they dilate? Why are they going to the parasympathetic? Whereas the rest of the body's going to the sympathetic?
Because they no longer receive signals from the brain.
That's it. Okay, because the brain can no longer communicate with the part of the body that's below the injury, okay, they're going to default to a parasympathetic state, which means those muscles are going to relax and dilate. So, what skin signs would they have as far as color below that injury?
They would be sort of like, not red, but like pinkish, I guess.
Well, pinkish would be considered normal.
Well, they wouldn't turn like pale or blue, because then that would be like, wouldn't
Okay, so then what color would they be if their blood vessels are dilated?
red,
Which we call?
flush.
There we go. All right, they're going to be flush below the injury. Okay, because those blood vessels are dilating, blood is going to be going out to the skin. It gives them that flushed appearance. Okay, whereas again above the injury, because they can still communicate with the brain, they're going to be kicking their sympathetic, causing vasoconstriction. All right. So as far as understanding neurogenic shock, you have to understand the nervous system. Okay, because if you don't understand the nervous system, then you don't understand neurogenic shock, which means you will miss the question and/or cause damage to your patient. Okay. It's all simple, again, one-to-one anatomy physiology to understand pathophysiology. You got to understand normal so you can identify abnormal, just like your vital signs. Okay. Now, as far as different portions of the brain, it's broken up to three main sections. We have the cerebrum, which is where we have those four lobes: frontal, parietal, occipital, temporal. Okay, where they each have their own different functions. So again, the frontal lobe is responsible for behavior and
Sensation.
no. Emotion. Okay, so that frontal lobe is responsible for behavior and emotion. So again, like you said, when that gets injured, your patients will be combative, they may be violent, they may be altered. Okay, the parietal lobe, that is where we get touch and sensation. The temporal lobe will be hearing and speech. All right, and the occipital lobe controls your vision. As far as the cerebellum, right, the next part of the brain, sir, what is the cerebellum responsible for?
Cerebellum?
Mm-hmm.
Sight?
Nope. Sir? Sure.
Balance and motor, fine motor movement.
Right, balance and fine motor skills. Okay, so that'll help keep us upright, right? Also will control fine motor skills such as using your fingers. Okay? Now, the cerebellum is usually not damaged in trauma unless it's directed to that part of the head, right? But when that thing's getting placed under pressure due to ICP, then we may start to have some problems with that. And lastly, we have the big bad brainstem, which has 4 different control centers. So, sir, what is one control center and what does it do?
The respiratory control center
What does it do?
controls your respiratory.
Respiratory. What about respirations?
Just that they're happening.
Sir, what does it control about respirations?
It controls the rate.
How?
Through specific receptors. I think they're chemoreceptors.
Okay.
And they pick up the carbon dioxide and acidic content in the blood.
So if acid levels go up, what happens to breathing rate?
The breathing rate would increase.
Right. It's like deja vu. It's like I asked you this question earlier tonight. Okay. Hopefully you guys again get it. All the repetition. Okay. So we have the respiratory control center, right? That is going to control our rate of breathing. All right, sir. What's another center and what does it do?
The cardiac system acts for blood flow.
I was like all wrong, sir. Okay. The cardiac control center does what? Sir, what does a cardiac control center do?
Well, control your heart.
So it controls it like 100%. Miss, what does the cardiac control center do?
It controls the pressure inside the heart.
I'm sorry?
It controls blood pressure.
Nope.
How much the heart pumps out.
Not quite. What does it do?
Is that, oh, it controls vasoconstriction?
Nope.
Or constriction, rather.
Nope. Elaborate on that, please.
Oh, well, yeah, I don't really know.
Sir, what does the cardiac control center do?
Controls how fast the heart beats.
Is it cardiac output?
No, it's not cardiac output.
I would say influences
Influences what?
heart rate.
Right. It influences the heart rate. It doesn't tell it how fast to beat. Okay, because there's a very special bundle of cells in the heart itself that will tell it how fast to beat. What are those very special bundle of cells? Killing me. Sir? Special bundle of cells that controls the heart rate. What is it? Sir?
Would it be...
You had a test question on it.
Specifics, would it be smooth muscle cells?
Mm-mm. Sir?
Not sure.
No?
The SA node.
What does it stand for?
Sinoatrial.
All right, the sinoatrial node. Okay, that very special bundle of cells in the right atria, the SA node, the pacemaker of the heart, is what's actually going to set the pace of the heart rate. Okay, but the cardiac control center influences the heart rate by telling it to either speed up or slow down based on... No, it's not cardiac output. It's different. Miss, what influences the heart rate? Miss, what influences the heart rate?
Like adrenaline can influence it by...
If you want to go there, what causes secretion of adrenaline then? Because it's the same thing.
When you're in a sympathetic... Like, when your body falls to like a sympathetic state.
Well, adrenaline causes the body to go to a sympathetic state. Sir?
Say it again.
What influences the heart rate besides
Blood
the cardiac
pressure.
control? Blood pressure, or just pressure in general. What kind of receptors?
Chemoreceptor?
No.
Baroreceptors?
Baroreceptors. Okay, so if we have an increase in pressure, what happens to the heart rate?
It goes down.
It goes down. And if we have a decrease in pressure, what happens to the heart rate?
It goes up.
It goes up. Okay, so with the baroreceptors and heart rate, there's an inverse relationship. Okay, if one goes down, the other goes up to compensate. Okay, so if pressure decreases, heart rate goes up to try to compensate. And if pressure goes up, heart rate goes down to try to compensate so you don't start bursting out blood vessels all around the body. Okay, sir, what is another control center and what does it do? We have cardiac and respiratory. So what's left?
Nervous?
Well, this is all part of the nervous system, sir.
I'm drawing a blank.
Sir?
Can we say GI tract?
Well, the GI tract is not a part of the brainstem.
Oh, okay.
It's related to it in some way, shape, or form, but it's not a part of the brainstem. Because if you got shit in your brain, that's a problem.
One of the control centers would be the reticular activating
Yeah,
system.
I know it's a long day. I get it. Okay, reticular activating system, perfect. And what is that responsible for, sir?
That would control if I'm awake or asleep.
Yeah. Okay, that controls basically our consciousness, tells if we're awake or asleep. Okay, and apparently all of your RASs were shut down as we covered the brainstem. Okay, so, sir, what does that leave us with? No? Sir? What does that leave us with? No? Miss?
Vasomotor.
Vasomotor center. What does that control?
The smooth muscle.
And where do I find smooth muscle in the body?
In your lungs and
What do you mean lungs?
in your respiratory tract.
Okay.
In your gastrointestinal tract.
Okay.
In your blood vessels and
Miss, where else do we find smooth muscle? In the pupils. Okay, so we're going to find smooth muscle in the blood vessels, in the respiratory tract, the GI tract, right, and the pupils themselves. Okay, hence why, again, if our patient sustains neurogenic shock, can they communicate with the brain below the injury? No. So all the smooth muscle that's below there, right, just goes back to its normal sympathetic or normal state. That's why we have vasodilation below the injury, because the vasomotor center can't tell the blood vessels to constrict past the severing of the spinal cord. Okay.
Is there any connecting receptor in between the process of the vasomotor control center, like in the respiratory control center, with the chemoreceptor?
The chemoreceptors?
Yes. Is there any like connecting receptor that will control the smooth muscles?
It's all based on other things, based on the endocrine system, right? Other input from the nervous system, things like that will also affect smooth muscle. All right, so it's kind of all over the place. All right, so with the brainstem, right? Again, it's vital because it controls all of our vitals. Okay, your respiratory control center is a direct control of your respiratory rate. Okay, the cardiac control center influences the heart rate. Is the pulse going to be fast? Is it going to be slow? Is it going to be about normal? Okay, the RAS is part of our Glasgow Coma Scale as far as patient's responsiveness and AFU, right? Could also be part of their ANO status as far as how they answer questions. Okay, the vasomotor center has a direct control on the blood vessels, right? Therefore, helping us with diastolic blood pressure. Controls the pupils with pupillary constriction dilation. Okay, the lung sounds as far as wheezing with bronchospasm. Okay, all that stuff is regulated by the brainstem. Now, when we start talking about head injuries coming up, okay, with ICP, do you think there's going to be damage to the brainstem?
Yes.
Yeah. Okay. Do you think the vitals will change in response to that damage?
Yes.
Is it going to change in a specific manner that you need to know the brainstem in and out?
Yes.
Yes. Because you'll be able to identify, oh shit, right, it's a brainstem injury because of these vitals changes that are very specific to a patient who's got ICP. Okay? So, there we have it, right? Breakdown of the brain yet again. Okay? So the frontal lobe, right, behavior and emotion. The parietal lobe, touch and sensation. Temporal region is going to be for hearing and speech. Occipital will control our vision. With the cerebellum, that's going to be our balance and fine motor skills. And we got the brainstem with the respiratory control center setting the rate of breathing. Okay, we have the cardiac control center influencing the heart rate. The vasomotor center regulating my smooth muscle. And the reticular activating system controlling our consciousness. Okay, and whenever we have any type of head injury, there will be deficiencies noted across the different portions of the brain. When it comes to brain cell death, again, they will start to die in 4 to 6 minutes without oxygen, but after how many minutes they're completely dead? 10. All right. So, as far as the meninges, okay, the meninges are the layers surrounding the brain and spinal cord. Okay, it's a protective covering around them, and there are different layers within the meninges themselves. If those meninges were to get infected, sir, what do we call that infection? Meningitis. And what classic signs would I see to indicate patients got meningitis?
Headache and
Headache doesn't tell me anything, sir.
If the react to light or light hurts or causes pain.
What do we call that?
I don't know.
What do we call that?
Photophobia?
Photophobia. What else would indicate meningitis?
Pronunciation, sorry. Is it nuchal rigidity?
Close enough. Nuchal rigidity. Okay. So what is that in layman's terms?
Stiff neck.
All right, it's a stiff neck, right? So if they got a stiff neck and like, oh man, can you turn off the light, please? Okay, and if they got other signs of an itis, right, fever-like signs or symptoms, then we suspect they got meningitis, right? Now, as far as that, we don't have to worry about that for now, but again, the meninges will get infected, causing those issues. With trauma, there are 3 different types of brain bleeds we have to worry about, okay? And it has to do with the actual location within the meninges, or at least surrounding the meninges, as far as how quickly we're going to see their signs and symptoms. So the duramater, or duramater, pronounce it however you want, tomato or tomater, right? If it's an epidural bleed, okay, it's going to be happening on top of the duramater. So epidural bleeds happen on top of the duramater. And that's due to rupture of a meningeal artery. You don't have to worry too much about the actual name itself, right? But that is the artery that will be ruptured when patients have an epidural bleed. Okay, now the meningeal artery is a fairly large blood vessel in relation to everything that's going on inside the head. So if that were to rupture, do you think it's going to be dumping out a lot of blood relatively quickly?
Yes.
Yeah, because it's a fairly large blood vessel. Okay, now just below the duramater, we have the arachnoid mater. And the arachnoid mater is a layer of blood vessels that kind of make a weave. Kind of looks like a spider web, hence why they call it the arachnoid layer. But the arachnoid mater is made of a bunch of veins, which are lower pressure vessels. So if we have a bleed inside the arachnoid mater, okay, that's going to cause blood to just kind of ooze out of those blood vessels. Now, as far as the pia mater, okay, that's the very, very thin layer that surrounds the actual brain itself. So that would be the visceral meninges that attach to the organs, whereas the duramater would be the parietal meninges that attach to the skull or the vertebrae themselves. Okay, now anything that's happening under the duramater is technically intracerebral. So cranial means head, whereas cerebral means brain. Okay, and that's the thing that you guys commonly confuse. Totally understand as to why. All right, but cranium is head, cerebral is brain. So an intracerebral bleed is a bleed inside the brain. Intracranial bleed is a bleed inside of their head. All right, so with the pia mater and an intracerebral bleed, okay, that's going to be affecting blood vessels inside of the brain, the intracerebral arteries. They're just that, they're arteries, but they're smaller arteries when compared to the meningeal arteries, which is a much fatter blood vessel. Okay, so when we talk about speed of bleeds in a little bit, okay, one will be considered fast, while the other one will be super fast. All right, so as far as CSF is produced inside of the brain, and again, it acts as its own cushion. It also goes down the length of the spinal cord, hence why it's cerebral spinal fluid. And when the brain begins to swell, okay, that CSF will start to get pushed out. Because when there is brain swelling, something's got to give. right? And what we'll give is some of that CSF. So that will start pushing out of the patient's head to make room for the brain swelling. And where do we see that CSF drainage?
Ears and nose.
Ears and nose. Okay, so any type of orifice, and an orifice is a hole. It's a what?
A hole.
Okay, any type of orifice in the head we have to assess for something, right? The eyes, right, are still considered an orifice, so check around there. The ears, the nose, the mouth. Okay, checking for anything that might be coming out and obstructing those possible areas. Okay, so around the nose and the ears, we got to check for CSF drainage. Okay, so as far as the different kinds of nerves, we have our sensory nerves that, again, will gather information from the environment. Motor nerves will move information from the nervous system out to different muscle, smooth muscle and cardiac muscle included. We also have special connecting nerves that we typically use for reflexive actions. Right? So the common example, and we'll even see a picture of it, right? If somebody were to touch a hot surface, are they going to sit there and ow? Are they going to do that?
No.
No, right? They instinctively want to pull away. Okay, and that's because of these connecting nerves sensing that there is pain and possible trauma, right? And the body wants to try to preserve itself, so it's going to cause a reflexive movement to come away, right, from that pain source. All right, so that's all in relation to those connecting nerves. And even though it's a very, very, very short delay, right, we're going to start moving stuff away from that pain source as the pain signal is still working its way up to the brain. Right, so again, just a few milliseconds later, that's when we go, that shit hurt, right, as we're already pulling your hand away. All right, so breakdown of the nervous system, right, we got central nervous system that talks with the peripheral nervous system. They will communicate back and forth. The peripheral nervous system branches off to autonomic, where we have no control over that whatsoever, versus the somatic, where we have complete control over that. And then with the autonomic, we have sympathetic and parasympathetic. Sympathetic is our fight or flight. Parasympathetic is the feed and breathe. And between the two, which one do we prefer to be in?
Parasympathetic.
Parasympathetic, because again, there we are intaking energy. Over here in the sympathetic, we are expending energy. And obviously, you want to be taking in energy whenever you possibly can. Right, but of course, too much of anything is bad. So we shift too far over to one side, that can be really bad for us. So that's pretty much what we have with our connecting nerves. So again, it's a reflexive action, right? That'll be happening within the motor nerves and the spinal cord itself, allowing us to pull away. All right, you don't have to worry too much about that, but that's what we have going on there to reflexively have us move. Okay. Now, when it comes to head injuries, obviously head injuries are very, very serious. Okay, most of the time when patients have multi-system trauma that involves the head, it's usually the head injury that tends to kill them. Because again, most of us have something very important in there, that of course being the brain. Okay, motor vehicle crashes are very, very common, right? Where again, that head is going to be whipping back and forth. So we have that conjugal injury, that brain sloshing around inside the head. Okay, so it doesn't have to hit the windshield to make that, but it's a very common cause of conjugal injuries, right? Again, people getting rear-ended, that head whipping back and hitting their seat. Okay, that too can also cause conjugal injuries. Right, assault, of course, people getting hit in the head with a baseball bat or a brick. Okay, that will cause direct trauma to the brain itself. Okay, so if the MOI indicates possible head injury, we're going to assume they have a what? We're going to assume they have a head injury. All right, so if the MOI presents with the possibility of it being there, we'll just assume it's there. All right, so with trauma being very straightforward, okay, again, it's also very binary. We have closed head injuries where the head is still closed, and we have open head injuries where the head is now open. All right, go figure. Okay, now both of these are obviously really bad. Okay. In my opinion, I think closed injuries are a little bit worse, right? Because injured tissue begins to not die. Before it dies, swells. Okay, injured tissue swells. And when it comes to brain swelling is bad. Okay, in most cases of closed head injuries, there's only one place for that brain to relieve pressure when it begins to swell, and that's going to be the big hole at the base of the skull. And what do we call that big hole?
Foramen magnum.
Right, the foramen magnum. Okay, and the first thing to get squeezed out of the foramen magnum is probably the most vital part of our brain, that being the what?
Brainstem.
Oh, shit. And when that brainstem starts getting squished out, is that going to cause a change in my patient's vitals?
Yes.
Because it controls the what?
Vitals.
Vitals. Okay, and again, we're going to start to see very specific changes to their vitals, indicating they've got brainstem injury. It's also, as a part of the brainstem, trying to compensate for the head injury, but also as that thing is getting squished out of that foramen magnum, okay, we're going to start seeing some abnormal changes. Now, with open head injuries, it's still pretty bad, but at least we'll have some place to vent out a little bit of pressure. All right, so we don't see nearly as much ICP problems, right, with an open head injury versus a closed head injury. But then the brain itself is exposed, and again, that opens up to a bunch of other problems. Okay, so while both are bad, I think closed injuries are just that much worse because of the ICP buildup. So, when it comes to scalp lacerations, we'll talk about this on Monday. Okay, with the scalp, there's a lot of blood vessels there, yes, but they're relatively small blood vessels. So when they rupture, they're actually able to constrict themselves and pinch off blood flow. Okay, so the injuries, this one being an exception, the injuries usually look a lot worse than they actually are. Right? Just because we see blood on somebody's head or face, it just kind of creates a psychological thing for us, like, that's really bad. Right? But in the grand scheme of things, most of the time, they're not going to die from blood loss. All right, now again, like I said, this is an exception because this right here is an open head injury. Okay, so we can obviously see the scalp is torn away. Right? It looks like we have a layer of the skull, and right up in there, right, it's the guy's brains. All right, now it's because of this, right, when we're palpating around the outside of somebody's head, you want to take your hands and keep them nice and wide as they come around the outside of the skull. All right, I don't want to do this and poke and prod, because if I do that and I stick my finger in here, what am I going to poke?
The brain.
I'm going to poke their brain, right? And then they do a little eye twitch and they're just not the same after that. Okay? So, you want to make sure you're palpating around the outside of the skull, just checking for any type of generalized decap ETLS. Okay, tomorrow night we're going to run you guys through a physical exam to show you the proper way of palpating. Because again, I don't just sit there and poke and prod my patients however I want. There are certain ways that we palpate. Okay? Now, as far as this stuff coming out of the guy's ear, right, what do you think that is? That's cerebral spinal fluid mixed with blood. And usually it's going to be mixed with blood. Okay? Now, the way we can tell there is CSF mixed in blood, that blood is going to look like it's watered down almost. Right? Almost like a vinaigrette that's kind of separated. Right? We're going to see a separation between blood and CSF. Now, they don't really recommend doing this as much as they used to, but what they used to do was take a 4x4, hold it up to that drainage, right? Catch some fluid, and the fluids will actually separate. We called it a halo test because we'd have blood in the middle, and we'd have the CSF fluid making a ring around the outside as the fluid would separate onto the gauze. Right? They're like, it's not really that scientific, so they kind of don't advocate it that much anymore, but that is a tool that we can use to see if there may be some CSF drainage mixed in their head, or mixed in their blood. All right, now as far as brain injuries, there's two different types. There's a primary, aka direct injury, and there's a secondary, aka indirect injury. So I just call them direct and indirect. The direct injury is caused by the direct injury to the brain itself. All right, so that brain smacking into the skull is an example of a direct injury. Okay, and of course there I have trauma to the brain itself. Possible bleeding. And as far as the secondary or the indirect injury, those are basically complications following the initial trauma. Okay, so hypoxia, hypotension, cerebral edema. So edema does also mean swelling. We typically use it in the context of fluid. All right, but sometimes you will see that as swelling. So there will be some brain swelling. Of course, bleeding inside the brain with hemorrhage. All right, there's going to be infection, possibly, especially if it's an open injury. Okay, and ischemia. Ischemia is cell injury due to hypoxia. Okay, so ischemia is cell injury due to hypoxia. And we'll talk about that term a little bit later on next week. Okay, but you will be seeing ischemia a lot when we come to medical issues. All right, so basically if we have some type of traumatic brain injury, these are some complications that will start to follow secondary to the injury itself. Sometimes it may be happening pretty much right away, other times it may be more delayed. All right, as far as signs and symptoms, okay, there's going to be a lot of different signs and symptoms that go along with head injuries. like I said, any type of neurological issue you can think of could possibly be caused by a head injury. All right, so edema, again, is swelling inside the brain. Brain swelling is bad. Okay, so as that brain begins to swell, something's got to give. All right, meninges are torn, CSF will start to push out, but we only have so much room to swell. Okay, here we have a depressed skull fracture, so there's a dent in the patient's head. Okay, again, we got to be really careful about how we palpate, because if I use my fingers, I'm going to drive those bone fragments into their what? Into their brain. And again, they do an eye twitch and they're just not the same. Okay, so you want to make sure we're palpating around the outside of the skull, right, to not push things into their brain. All right, now as far as recognition of patients who have intracranial pressure, okay, again, there's going to be a direct change in their vitals that will indicate that. Okay, in fact, there are 3 changes to their vitals, so we call it a triad. And some guy named Cushing decided to name it after himself. So, it also has to do with the pulse pressure and blood pressure, which means you guys will confuse it every single time with the other triad we talked about tonight, that being Beck's triad. Okay. So, with Beck's triad, again, that is an indication of cardiac tamponade. Okay, when you have blood filling up, or fluid rather, filling up within the pericardial sac of the heart. And with Beck's triad, we have a narrowing pulse pressure with systolic hypotension. With Cushing's triad, I have hypertension with a widening pulse pressure. So they're complete and total opposites of one another, and you guys go, oh, triad, and you choose the first one that you see. Okay, but they're total opposites of one another. All right, with Beck's triad, as that poor little heart is getting smashed, all right, systolic blood pressure goes down, and the diastolic, and systolic pressures get really close. Okay, simply because that poor little heart's getting smashed. But with Cushing's triad, we have hypertension. What do we have?
Hypertension.
With a widening pulse pressure. Okay, what should you ask yourself?
What is why?
Why? Why do we have that hypertension with the widening pulse pressure with patients who got ICP and Cushing's triad? Okay, it has to do with what's building up inside of the head. What's building up inside the head? Pressure. Right? And we call that pressure what?
Tension.
No, not tension. Intracranial pressure. Okay? I mean, you're not wrong, but... All right, now, as far as why we have that hypertension, okay, we have to overcome the amount of pressure that's building up inside the head. Now, just for numbers' sake, just to kind of help you guys conceptualize this, let's say the pressure inside the head is at 180 millimeters of mercury. Okay, so the pressure inside the head is 180. Okay, in order to get blood inside of the head, the pressure has to be over 180. Okay, so the heart and the blood vessels have to work together to try to generate enough pressure to overcome whatever's inside of that head to make sure the brain is still getting blood. Because does the brain need a constant supply of blood?
Yes.
Yes. Okay, so because of that, right, we got to jack that pressure up, okay, to go ahead and get that blood developed delivered inside the brain. So we have this really stupid high systolic blood pressure, and to help with that, the blood vessels constrict and they get really, really tight. Now, as far as the diastolic blood pressure, what it's doing, it's measuring how resistant the blood vessels are when they're constricting. Okay, now every time we feel the pulse, right, our blood vessel is doing this when we feel it, and then when we don't feel it, the blood vessels do this. And when they come back down, that's basically what your diastolic blood pressure is. Okay, now, just like we talked about with shock and compensation, right, to start moving blood towards the core and increase our perfusion, what do our blood vessels have to do?
Constrict.
They got to constrict, right? They got to squeeze that blood, right, to move it over here. Right? And if you guys know anything about, fluid, the smaller the pipe is, the more pressure we generate. Okay? So, to try to fix that, right, our blood vessels will constrict and get super duper tight. Right? So when the body does constrict, right, and does systolic pressure, the blood vessels are tightening right down right away. Okay, and that's going to help move that blood up into the brain. Now, this number here, this example of 210 over 120, is pretty much maxing out systolic and diastolic blood pressures. Okay, if we go much higher than this, blood vessels just start rupturing. All right, now because of the risk of blood vessels rupturing with all that pressure, the cardiac control center in the brainstem goes, oh shit, we got a lot of pressure. To compensate, what's going to happen to the heart rate?
Slow down.
It's going to slow down. And that's why our patient's going to have, in this example, a heart rate of 44. And if they have a slow heart rate, what do we call that? Bradycardia. Okay, so we have hypertension with a widening pulse pressure. We have bradycardia, right, a slow heart rate. Okay, we have rapid, erratic respirations. Okay, so Cushing's triad is hypertension with a widening pulse pressure, bradycardia, and rapid, erratic respirations. Now, as far as why the patient has rapid, erratic respirations, okay, it's in an effort for the body to try to hyperoxygenate the brain, right, to try to get some more oxygen for the brain. So now we are kind of not looking at chemoreceptors, but we also want to try to get rid of acid at the same time. Okay, help try to flush out the acid in the brain. So we have the rapid. Now, as far as erratic, that's just straight up due to damage from the brainstem coming out of the patient's head. Okay, there are two different respiratory patterns we're going to talk about on Tuesday. We'll see the names for them on the next slide, but we'll talk about what they actually are on Tuesday. Okay, then we're going to see for patients who have ICP and Cushing's triad. Okay, but if you see vitals like this, right, and the question is indicating some type of head injury, right, we should already be able to put 2 and 2 together that it's Cushing's triad, right? Where if you have a patient who's got chest injury and you have hypotension with narrowing pulse pressure, right, with JVD and muffled heart tones, well, now we know the patient's got cardiac tamponade. Okay, so you also have to look at the question itself in addition to vitals. Okay, but again, you guys will screw this up all the time if you try to memorize it. Okay, so you have the weekend to completely forget when you take your quiz, right, and you start seeing questions on Cushing's triad. All right, now as far as our different respiratory patterns, again, we'll see them later, so if you don't get the names down, not a big deal. Okay, but we have Cheyne-Stokes respirations, okay, as well as BIOTS, aka ataxic respirations. Okay, so Cheyne-Stokes. So they actually decided to share credit this time. So we got Cheyne-Stokes or BIOTS respirations, which is totally different. And again, we'll talk about what those are on Tuesday. As far as our treatment, it's going to be taking care of any possible spinal injuries that they may have. And the only other thing we can do for them is to provide positive pressure ventilations with a BMV at a rate of 20 breaths per minute. Okay, so we have to ventilate our patient at a rate of 20 breaths per minute. And the reason why we want to ventilate at that rate is going back to the rapid erratic respirations. They're probably breathing so fast and not getting good tidal volume, but they're also breathing really fast because they want to make sure they get enough what to their brain? Oxygen. And they also get rid of enough carbon dioxide. Okay, so by us ventilating for them, we're also helping out with that problem. Now, to accomplish a rate of 20 breaths per minute, a little bit of math, how many breaths do I have to give every few seconds?
1 breath every 2 seconds.
1 breath every 2 seconds. I realize I phrased it wrong. Right? But essentially, we're going to be squeezing the bag at a rate of 1 breath every 3 seconds to accomplish 20 breaths per minute. Okay, now that's the only time for adult patients that we ventilate at a rate other than 1 breath every 6 seconds, right, whenever we have to ventilate. Right? So other than that, it's all pretty much supportive treatments. Okay, recognize, go, oh crap, they got ICP, because we got to get them to a trauma center. They got to find ways to relieve that pressure, otherwise the patient will die. Right. So when it comes to bones in the skull, so we got the frontal bone, parietal bone, temporal bone, sphenoid bone, occipital bone. All right, we got the different facial bones, the orbits, nasal bone, zygomatics, the maxilla, and the mandible. All right, for trauma and fractures, there's really not much we do besides identify the possibility they may have a fracture. Now, the most common type of skull fracture is a linear skull fracture. And with a linear skull fracture, it is simply a crack in the skull. Okay, so a linear skull fracture is simply a crack in the skull. And the only way to know if the patient has a linear skull fracture is if they go receive an x-ray. And they'll be like, oh yeah, you got a crack in your skull. Now, as far as us being able to identify the possibility they may have a linear skull fracture, if I'm palpating and they say, ow, ow, we're going to assume they might have a linear skull fracture. Okay, I may not feel crepitus, right, as I'm palpating. Okay, so if the MO indicates the possibility they may have a possible skull fracture, right? And they say, when I palpate, I'll just assume they got a skull fracture. Okay, until it can be proven otherwise. As far as depressed skull fractures, can we tell if the patient has a depressed skull fracture?
Yes.
Yeah, because they're going to have a dent in their skull. Right? And because it may be completely detached, again, I don't want to take my finger and poke and prod, because now I'll be driving those bone fragments into their what? Brain. And that would be bad. As far as open skull fractures, can we tell they have an open skull fracture?
Yes.
Yeah. Right? We'll see a lot of blood coming out of their head. Okay, and again, we'll be able to see into their head itself. So again, be very, very careful. Don't take your fingers and poke inside of there, because you're going to poke their what?
Brain.
Right. As far as a basilar skull fracture, okay, that's where we're going to see bruising around the eyes that we call raccoon eyes. What do we call it?
Raccoon eyes.
And we're going to see bruising behind the ears that we call battle signs. Okay. Battles, again, being named after Dr. Battle. Whoever it is. So, we're going to see bruising behind the patient's ears. Okay, and as far as where the actual fracture occurs is going to help us determine why we see those signs. If it's more of an anterior fracture along the front, we see raccoon eyes. More of a posterior fracture, we're going to see battle signs. Usually, in most cases, it tends to be one or the other. But if a patient's really screwed up, you might see both. Now, if our patient were to have one of these types of skull fractures, could there also be ICP inside the head?
Yeah.
Yes. Okay, because whatever happened on the outside could also happen on the inside. All right, now, for the purpose of class, again, we focus on differences. If you see bruising around the eyes or the ears, that tells you for sure, it's a basilar skull fracture. Whereas if I see CSF drainage out of the ears or their nose, for sure, that tells me they have ICP. Okay, can I have both together in the same patient?
Yes.
Absolutely. Okay, but try to keep them separate from one another for class. Bruising is a fracture. CSF drainage is ICP. All right. Now, as far as what it looks like in real people, there we have it. So there we see battle signs. So bruising behind the patient's ear. Usually it's behind one or the other. Again, we don't really see it in both. Okay, as far as raccoon eyes, that's bruising around both eyes. Now, technically, yes, my patient could have raccoon eyes if they get punched in the face at the same time, right? But for the purpose of class, if they have a basilar skull fracture, right, that's going to be the indication of raccoon eyes.
So battle signs are one or the other, but are raccoon eyes usually both eyes?
Yeah. All right, and again, it's bruising, therefore it is a
late sign.
Late sign. Okay, so we're not going to see it happen right away, right? And we do see these basilar skull fractures with assaults. Okay, patients who do get assaulted to the head, they may have a basilar skull fracture. Okay, falls is also very common, especially when they slip and hit the back of their head. Okay, and it doesn't have to be a high fall. A ground level fall where they do this, right, is enough to cause a basilar skull fracture. Right, and along with that, we also have coup-conjugal injuries. Right, even hitting their head on other things can cause basilar skull fractures, right? Hitting on the sink, counter, whatever. All right, now as far as concussions, okay, for our purposes, concussions are mild traumatic brain injuries that are reversible. Okay, so concussions are mild traumatic brain injuries, or TBI, that are reversible. Okay, which means the symptoms will go away on their own. Okay, and the patient will make a complete recovery. Now, obviously, if people have multiple repeated concussions in relatively short periods of time, is that going to cause long-term damage?
Yes.
Yes. Okay, but your isolated concussion every few years, all right, is not going to cause a lot of long-term damage compared to multiple repeated concussions in relatively short periods of time. Now, as far as the difference between a concussion and a contusion that we'll talk about on the next slide, okay, we really can't tell the difference in the field. So we assume the
worst,
but hope for the
best.
Okay, we'll assume it's a contusion until we can rule it out, which we really can't do in the field unless the patient all of a sudden starts to become better. Okay, patients with concussions don't always lose consciousness. Okay, so in fact, a vast majority of patients who have a concussion are conscious throughout the entire time. Okay, they don't KO, they don't knock out. And if they do KO, then it's usually something a little bit worse. All right. Now, patients may have what's known as a lucid period, where they're totally aware of what's going on, but then they suffer amnesia afterwards, to where they don't remember what happened. So you could have a conversation with them, and they could be answering like nothing's wrong. And then the next day, they're like, oh, I didn't remember seeing you at the house yesterday. It's like, what are you talking about? We were having a conversation about all this. I don't remember any of that. Right? So that's an example of something that may happen for patients who have concussions. Okay, but again, the brain will go back and it will fix itself, and the patient goes back to 100%. With contusions, on the other hand, that doesn't happen. Okay, and a contusion is basically bleeding inside of the brain. In fact, we typically call contusions bruises. So this would be bruising of the brain. Now, when it comes to different types of bleeds and the brain, blood cells and brain cells don't play well together. Okay, so if a blood cell comes into direct contact with a brain cell, that blood cell obliterates that brain cell and it kills it. Okay, now usually, of course, there's blood and brain that are close to each other, but the blood is contained within the blood vessels. Okay, and stuff is able to move from the blood vessels into the brain cells, but the blood cell and the brain cell don't actually come into contact with each other. Okay, but as soon as that blood is free to start moving around inside the brain, it will just outright kill brain cells. Right? So if our patient does have bleeding inside of their head, again, they will have some long-term permanent damage. Because once a brain cell dies, can it be replaced?
No.
Can it be revived? No. Once it's done, it's done. Right? So that's why contusions are going to have more long-term, possibly permanent brain damage. Right? Since there will be bleeding, there will be injury, and again, injured tissue swells, and brain swelling is bad. So then we start to see signs of Cushing's triad, where we get that hypertension with what kind of pulse pressure? Pulse pressure. Screwing it up already. What is it, sir? Widening. What is it?
Widening.
Right. The systolic and diastolic pressures get really far apart, right, to try to help overcome that pressure inside the head to maintain perfusion to the brain. Okay, so we get that ICP, which causes hypertension with the widening pulse pressure. Because we have that increase in pressure, what happens to the heart rate?
Slows down.
It slows down. So now the patient experiences bradycardia, and they'll have the rapid erratic respirations. And you go, oh crap, this patient has ICP. Right, and then we go ahead and stabilize for possible spinal injuries, and then we transport to the hospital. Right, management for a patient who has a contusion is just supported treatments. Again, treating them for ICP, we'll have to go and provide ventilations at 20 breaths per minute, aka 1 breath every 3 seconds. Of course, maintain oxygenation and transport to the hospital, treating for any other injuries we may see. So, as far as contra injury, so we have a counter, but also could be spelled contra, R-A. Okay, but again, that's that rattling back and forth inside the skull. Okay, so we'll see that with a lot of whiplash injuries, right? Car crashes, assaults, falls, things like that, where the patient's head starts rattling back and forth. All right, depending on the injury, edema may start happening right away, or it may start happening a little bit later. Just depends on the issue. Okay, it also depends on where that blood is coming from inside of the brain itself, or within the different layers of the meninges. All right, so we just want to look out for that stuff. Okay, if the meninges have been torn, then we have that CSF drainage coming out of the ears or out of their nose, letting you know that they do in fact have some ICP happening inside of their head. All right, now when it comes to our different brain bleeds, okay, we have 3 different brain bleeds, and the name of the bleed has to do with the location in which they originate from, and the location which they originate from has to do with the speed of onset of the signs and symptoms. Okay, so we have an epidural bleed. It's happening on top of the
epidermis.
Not the epidermis, because that's the outer layer of skin. The dura mater, right? Because again, we're talking about meninges. Okay, so an epidural bleed is happening on top of the dura mater, basically between that and the skull. And that's where we have rupture of those larger meningeal arteries. So because they're big arteries, they're going to dump a lot of blood pretty quickly. So the onset of signs or symptoms, we describe it as super fast. How do we describe it?
Super fast.
Super fast. Okay, because they'll be dumping a fair amount of blood in a pretty short period of time, causing signs or symptoms already. Now the layer right below that, it's under the dura mater, we call it the subdural, because it's under the dura mater. In this bleed, it's a subdural bleed. All right, so the bleed is happening in the arachnoid mater, yes, right? But it's a slow bleed because, again, the arachnoid mater, these subdural layers, they're veins. So when they bleed, they just ooze that blood out of the body. And as far as intracerebral, that's happening inside of the brain. Okay, so therefore it's going to be affecting intracerebral arteries, but they're smaller arteries compared to the big fat meningeal arteries. But because they're arteries, they still will be gushing out blood relatively quickly, just not as much compared to the meningeal artery. So therefore, it's just a fast bleed.
Then does the subdural account for both the arachnoid and pia, or?
The pia mater is just a layer. It's a lining. It's not really containing any blood vessels itself. So with the intracerebral versus the epidural, right, it all has to do with diameter of the artery. That's it. A bigger artery is going to bleed faster because it carries more blood. Okay, now as far as the time that it takes for symptoms to develop, there's no specific time frame, but they will come on more quickly compared to other ones, especially the epidural. So just for number's sake, okay, an epidural bleed, the patient may be symptomatic in, let's just say, 3 minutes. Okay, so 3 minutes from the onset of the bleed, they're already showing severe signs or symptoms. Whereas an intracerebral bleed maybe takes 6 minutes. Still pretty dang quick, right? But it's a little bit less time, or a little bit more time rather, compared to an epidural. A subdural bleed may show symptoms 45 minutes after the actual injury itself, right? Because it's going to be a much slower bleed. Now, as far as geriatric patients, okay, we talked a little about it yesterday. Okay, we have to speak more slowly, clearly, and distinctly for them because of physiological and anatomical changes to their brain. Right? So we're going to talk about later, but we'll just talk about it right now. Old people have small brains. Okay, so because they have small brains, right, there's more space for blood to accumulate inside their head before it starts causing problems. So basically, those time frames that I mentioned may be shifted a little bit longer because it takes more time for blood to build up inside of that extra space. Okay, so let's say the epidural bleed, instead of taking 3 minutes for an adult, takes 5 minutes for a geriatric. It's not much, right, but they get a little bit more time before it starts becoming a problem, right? That intracerebral bleed going from, 6 minutes, it's now 9 minutes, right? The subdural, that's where we really have to be careful with geriatrics. Because in the case of the adult, I said 45 minutes, it could be a matter of hours for a geriatric patient. Okay, and for them, right, if grandpa were to trip over the rug and hit his head, he'd be asymptomatic there, but he'd have a subdural bleed going on, and we wouldn't know because he won't be showing any signs or symptoms. Okay, therefore, would you want to take them to the hospital?
Yes.
Yes. However, we'll talk about this again for geriatrics, they don't want to go. Okay, and they usually don't want to go because they think they're going there to die. Damn, you guys are morbid. Okay, right? Yeah, no, it's absolutely true. They think they're going to go there to die, right? So they're going to be like, I'm totally fine. Yeah, my head hurts. I hit it on the floor. Of course. What do you think? Right? But we got to tell them, hey, you might have a very slow bleed happening inside of the head. You feel fine now, but then you will die. So let's at the very least take you to the hospital, do a scan on your head. If they don't see anything, they'll send you back home. If they do see something, they'll fix it and then send you back home. Right? So we want to try to convince that patient to try to be transported. And if they're signing out AMA, we have to tell them of the risks up to and including death. And if they have a subdural bleed, will they die?
Yes.
Yeah. Okay, so it's just a matter of telling them. It's not scaring them. It's telling them, you will die if you don't get this taken a look at.
So if you talk to, if they had a head injury, could they be ALOC?
Yeah.
So would you talk to, their child who could be present?
If that case, if they're altered, right, then we take them under implied consent. Right? We can inform the patient's child about that and say, hey, we think your dad's got this going on. We'd really like to take him to the hospital. Right? But the only time that we'd have to do that and ask for their consent is if they're the designated power of attorney. Right? So if their parent already has Alzheimer's, for example, right, they already are technically altered, so they can't make decisions for themselves. So I have to say, hey, your dad, has a bruise on his head. He might have some bleeding on the inside. Is it cool if we take him to go get taken a look at to see if there's something going on in there? And they got to go, oh yeah, that's totally fine. Go for it. Right? If they say no, well, hey, he might have some bleeding inside of his head. He may be okay right now. It may not be anything different, but he may deteriorate a lot quicker. And because he's got Alzheimer's, you may not be able to tell the difference, and it may be too late. So again, you do want to try to tell them, hey, we want to try to do this for these reasons here. All right. Now, as far as signs of bleeding inside of the brain, okay, if there is a tear in the meninges, we're going to see that blood and CSF coming out of their head. Okay, so like we saw with that guy coming out of his ears, right, we are going to see that blood and CSF mixture coming out of there. But that's only if the meninges have been torn. If they haven't been torn, everything stays inside of the head. So then we got to look out for the signs of ICP. Okay, do I see Cushing's triad? Does this patient have hypertension with a widening pulse pressure? Do they have a really slow heart rate? Do they have rapid erratic respirations? And if the answer is yes, then we know they have ICP. So at that point, we'll again treat our patient by providing hyperventilation. Okay, so breathing at a rate of 20 breaths per minute. And then we'll move on from there. So as far as head injury indicators, again, there's a lot of different things that can cause head injuries. Or symptoms, rather, that can be caused by head injuries. Okay, like I said, if you can suspect it possibly caused head injuries, or is caused by a head injury, it will be caused by a head injury. So the first and most obvious sign we typically tend to see is an ALOC. Okay, that's going to be one of the first or the most acute indicators of a head injury. All right, so if they hit their head and they're ANO times 2, well, they probably have some type of head injury. Okay, even if they go and they self-resolve like a concussion, okay, it's still classified as a head injury. All right, next up, they'll have pupillary changes because eyes are windows to the brain. So then we might see some of those abnormal pupillary signs we saw yesterday in patient assessment, right? They may have sluggish reaction to the pupils. They may do opposite of what they normally would do. Right? There may be unequal pupils.
Are they kind of vomiting?
Mm-hmm. Yep. So again, that's another thing too, is projectile vomiting. Not where the patient just goes, bleh, right? But they spray it all over the back of everywhere. Right, that's usually a sign of head injuries. Convulsions and seizure activity is a very common one. Right, that's why, again, if you were to see patients who get hit in the head and like during fights or something like that, they stiffen up. So they do go to corticate, but then they're on the floor and they start having convulsions. Right, that's all directly due to head injuries. And next Thursday, so a week from tonight, we will be talking about seizures, right, as well as other medical neurological issues.
Will the projectile vomiting, will it have blood in it or just?
No, that's like The Exorcist. But no, this is just, no, this would be whatever they have in their body.
Oh.
Yeah. All right, so as far as the actual trauma we're going to see to the head, it depends on whatever caused it to occur. So we may have avulsions where you have a flap of the scalp kind of hanging loose. There may be lacerations. There may be actual skull fractures, depressed skull fractures, open skull fractures. It just depends on the actual MOI. Right? We might see bruising around the eyes. What do we call that?
Raccoon
eyes. Or bruising behind the ears that we call vital signs, indication of a
basilar
skull fracture. Okay, so if we see bruising around the eyes or the ears, it tells us they got a basilar skull fracture, which again is a type of head injury. All right, pupils again will change, so they may not be pearl. So again, they may be sluggish, they may be unequal, okay, they may be opposite, just depends. There may be some neurological issues, so numbness or tingling in the extremities. Okay. Also possible indication of a spinal injury. Irregular respirations, all going back to that Cushing's triad. Dizziness doesn't tell me much. Visual issues, especially telling me their occipital lobe has been affected. Okay, and in really, really, really bad cases, we're going to see decorticate and decerebrate posturing. And as far as the simple word for decorticate, sir, what's that simple word for decorticate? Sir? Yes?
Tension?
Nope. Yes?
Flexion.
Flexion. What about decerebrate? Mm-hmm. Extension. And how many points would our patient get for decorticate posturing under the motor response category for GCS?
Decorticate was 2, or was it 3?
Which one?
One of them was under 11. extension is low, is less points.
So decorticate would be, and decervate would be, right. Okay, so if they have decorticate posturing in response to pain, right, that means they get 3 points in that motor response category. Okay, and if they have decervate posturing where they open up, they get how many points?
2.
How many points?
2.
And if they don't do anything at all, they get
1.
Right? Again, nobody gets 0. Everyone gets points for playing the game. Okay, so with that, again, very, very late signs. And like I was saying, way back in the human body, okay, if they're doing that, they got really bad brainstem injuries to the point where they're probably not going to survive. Okay, especially if it goes to decervate posturing. Right? Because again, now that body's opening up to pain as opposed to trying to protect itself from pain.
Can dead bodies, can you find dead bodies in those positions?
That's part of rigor mortis, though. It's something totally different. All right, even patients who are comatose, sometimes you guys might see during the ride-alongs, they will already naturally be decorticate. Right? So when they're comatose, they'll be like this and they're stuck like that. Now, if I were to do painful stimuli and they were to open up, right, then we already know that, hey, that's decervate posturing. Right, so as is, their baseline being this is obviously not normal. All right. Now, as far as non-traumatic brain injuries, this is also what we're going to talk about more on Thursday. Okay, these are obviously not caused by trauma. We like to call them cerebrovascular accidents. You may know them as a stroke. Okay, so a non-traumatic brain injury is a cerebrovascular accident, also known as a stroke. Now, a lot of the signs and symptoms of a stroke and head injuries are pretty much identical because they're both injuries to the what? Brain. Just one is caused by trauma, the other one isn't. Okay, but the end result is pretty much the same. Right, the only difference is with strokes, there isn't going to be CSF drainage coming out of the head, but there still may be IFCP because the brain is still injured and injured tissue can swell. All right, so we'll be talking about all these different causes and whatnot when we actually get to strokes next week. So as far as treatment of patients who have head injuries, recognize the possible head injury they have and get them to the hospital. That's really all we can do. If they have ICP, we ventilate at a rate of 20 breaths per minute or 1 breath every 3 seconds. Consider spinal mobilization that we'll talk about in the next chapter, next part of this chapter, and then we get them out to the hospital. Okay, so it's really supportive treatments. Right, pretty much almost immediate load and go. We get them on a backboard and then get them out of here.
That was my question. So head injuries are generally going to be code 3?
Yes. Right. So we want to get the level of consciousness, their baseline level of consciousness as well. Okay, we'll talk about this more with geriatrics too. Okay, but if I got a patient who has, an ALOC to begin with, like Alzheimer's or dementia, okay, I got to know, okay, how are they normally presenting and what's different about them now? Okay, because again, if they're found on the floor and they have a history of dementia, okay, yeah, they could be altered, but how do I know that's not their normal level of being altered? All right, so who do we ask?
Family?
Whoever knows the patient. Yeah, family usually. Right, hey, is your dad normally like this? Does he normally not know where he is, or does he normally not know the day? Oh yeah, that's normal for him. Oh, okay, cool. Or no, he normally knows where he's at. Well, he doesn't know now. Okay, crap, he's altered. Right, and again, we'll talk about that when we get to geriatrics. So as far as the spine, right, obviously we got a bunch of different vertebrae. Okay, we got a pair of nerves coming out of each one. So when it comes to different types of spinal injuries, we have to worry about nerve damage. Okay, there's different types of spinal injuries. So we talked about compression injuries earlier, especially when it comes to falls. Right, if they land feet first and they don't bend their knees, okay, that energy is still going to go through the spine and cause a vertebrae to smack into each other. Okay, so that can cause the disc between them to kind of pop out a little bit, causing herniated discs, okay, pinched cords, and just vertebral fractures in and of itself. Okay, we have rotation flexion injuries. Okay, so those are whiplash injuries where the head's flexing back and forth, but also rotation injuries of people who spin around like they're trying to crack their back. Okay, but they hyperspin. Okay, that too can cause the vertebrae to twist like that, causing injury to the spine and the muscles. Hyperextension we don't see very often, right? But that guy that was starfishing through the air in that video, okay, that would cause hyperextension injuries as that centrifugal force is basically pulling the spine apart. Okay, so any type of unnatural motion can possibly cause spinal injuries. right? So look at the MOI. Hey, does it possibly cause that type of abnormal spinal motion? If it does, let's get ready to put them on a backboard. Okay, so we are going to look at high MOI injuries to consider the possibility of spinal injuries. All right, so motor vehicle collisions, so car crashes, especially with neurological complaints. My neck hurts, my back hurts, I can't feel my feet. Okay, anything like that, we got to consider possible spinal injuries following an MOI. All right, and even if we get called to those, insurance claim calls of a boom, oh my neck, right? We still have to assume, right, they have some type of possible spinal injury because we can't rule it out. All right, auto versus pedestrian, clearly falls, blunt trauma, and any type of penetrating trauma to the head, neck, back, or torso. And the reason why we have to worry about spinal injuries in those cases, okay, can I see the internal damage? No, especially when it comes to gunshot wounds. Okay, do bullets go straight through people?
Yeah.
No. Okay, they may go through them, but they may zigzag before they exit out the body. Okay, there have been plenty of cases where somebody has been shot in the front and they have an exit wound on the same side, as that bullet essentially made a U-turn and went out the other way. Okay, so once a bullet goes in, we have no way of knowing where it really goes. So if they get shot here, that bullet can zip around and hit them in their spine.
Why does it do that again?
It just has to do with how it slows down. We're mostly water, bullets will do all this kind of stuff. All right, they can fragment, they can ricochet, they can do a bunch of different things. All right, so any type of penetrating injury, especially gunshot wounds, to anywhere where the spine is located, we have to worry about that. Okay, even like penetrating injuries to the neck, if they get stabbed, right, could that knife go through and hit part of the spinal cord?
Yes.
Yeah. Okay. We'll talk about diving accidents with environmental issues later. Hangings, clearly, if they're hanging themselves from the neck, okay, that'll cause spinal injuries. So again, if we suspect the possibility of a spinal injury, we'll assume there is one there. Now, like I was saying the other day, okay, we're in a transition period for class. Any possible spinal injury, we throw them on a board. Okay, but out there, any type of spinal injury, we'll consider putting on a board maybe later, right? And nowadays, even if they do put people on boards, it's really stupid, okay? But we put them on a board, we pick them up, we put them on the gurney, and then we take them off the board. And then we tell them, don't move, and then we transport, okay? So that's kind of what we're doing right now. Again, it's really stupid, right? And we always go from extremes, from one end to the other, right? And we never happen to find a happy medium. It's always back and forth, back and forth, back and forth. Right, so probably in 5 years, they're going to be like, oh shit, yeah, people are getting a lot of spinal injuries. It wasn't so bad when we put them on backboards, so let's just go and backboard everybody now. Okay, so don't be surprised if we have to go back to that immobilizing everybody just for the hell of it. All right, but for the time being, again, we don't really put people on backboards that much now. Now, as far as securing the spine, we want to go ahead and maintain manual mobilization of the head as soon as I determine the possibility of a spinal injury. So in the context of my patient assessment, first things first, gotta have her what?
BSI.
Gotta have her what?
BSI.
And then we have to go through scene size up using what mnemonic? Penman. Okay. PEMDAS, sir. Math. Okay. I'm gonna go through Penman. Okay. And when I get to that last N in Penman, the need for extrication or the need for spinal motion restriction. Oh. Gosh, that was terrible. Okay, scaring me for tomorrow already. Don't do that, please. I already have a long enough day. So, as far as the need for spinal mobilization, right, we have to determine that based on the mechanism of injury. Okay, based on what we see or suspect, am I going to need to put this patient on a backboard? And if the answer is yes, we're going to have to get ready to start doing this. I get up on scene and I see my patient for the first time. We develop our general impression. Okay, then we can finally go and immobilize our patient's head as we run the rest of our assessment. Because the last thing I want to do is come walking up and be like, la-di-da-di-da, I'm checking APU, blah, blah, blah. Patient goes, hey, what's up? And breaks her neck. Okay, so before we start approaching our patient, after the general impression is complete, we have our partner immobilize the patient's head. Okay, and like I said, a week from tomorrow, we're going to show you guys how to actually put people on backboards. All right. Now, as far as our different devices, we have to determine what device we're going to need. So we're going to first show you how to use a longboard for supine patients. Okay. The following Friday, for your last skill day, okay, we're going to show you guys how to use the KED, or the soft-seated spinal mobilization device. And we're going to show you how to use the longboard for a patient who has a spinal injury, but we find them in a standing position. Okay. So we'll show you these different devices, and you have to know which ones we have to use and what the indications would be. We'll cover that a little bit later. Now, as far as the whole kind of procedure that we're going to follow. Kind of went over that right now. So BSI, pen man, walk-ups on scene, develop a general impression. Hey, partner, go hold the head. We mobilize the patient's head, and then we continue our primary assessment, finding and treating any
life-threatening
injuries. Okay. Now, when we cover musculoskeletal in the next chapter, okay, broken bones don't kill people. Okay, in your vertebrae, they're just what? Bones. Your vertebrae are bones. Okay, and if they're broken, is that going to kill them? No, because I just said broken bones don't kill people. Okay, so therefore we don't provide any type of splinting whatsoever in the primary assessment. And the backboard is just a full body splint. Okay, now again, I identify the need for spinal mobilization in the primary, just as I could possibly identify the need for splinting in the primary, but I don't do it right then and there. Okay, broken bones are not a see it, treat it deal. All right, so we run through our primary assessment, take care of the life-threatening injuries first. And if you think about it, if I find something or don't find something that's life-threatening and my patient dies and I'm putting him on a backboard, what am I doing?
Strapping dead body to a board.
Yeah, we're playing with dead bodies, okay? And that's illegal, okay? So we want to take care of any life-threatening injuries first, fix it, and then we put them on a backboard. And patients who are in severe extremis, where they're super-duper life-threatening, screw the backboard, okay? You get them on the gurney, you throw them on there, and we haul ass to the hospital, right? Because, again, if I take a dead body to the hospital, are they going to be happy with us?
No.
No. Oh, but at least they're nice and packaged on a backboard, right? He's going to move to the morgue, okay? But we don't want to have to worry about that.
What was in the last slide? Didn't you say that you put the collar on first, like right when you get there?
No. No, we don't want to put the collar on. We just want to mobilize the head manually.
Oh.
Yeah. All right, so as far as holding onto the head and running through the primary, we're going to run a rapid physical exam. Okay, and how long should it take to run a rapid physical exam?
60 to 90 seconds.
60 to 90 seconds. Okay, we want to do a full body assessment. And when it gets to the hands and feet, we got to check what?
Circulation.
CMS, which stands for?
Circulation motor sensory.
What is it?
Circulation motor sensory.
Right, circulation motor sensory. Okay, so we check pulses, motor, and sensation on all four extremities. Because the backboard is just a full body splint. Okay, now once they've checked CMS, then we apply a C-collar or a cervical collar to our patient to try to restrict motion of their neck. All right, so we have two different sizes of C-collars. There's different manufacturers, right? But we have an adult size collar. Okay, we have a pediatric or small adult size collar. And the selection between the two collars is all about the width of the patient's neck, not the length. Okay, so those who have a wider neck get the bigger collar. Those that have a skinny neck get the yellow collar, or the smaller one. Okay, now as far as measuring out the length, right? Again, it'll make more sense when you're actually doing it next week. Okay, but we're going to measure from the tippy top of the trap, okay, which would be the part closest to the neck and closest to the back. So we go from the tippy top of the trap and we go to the bottom of the chin. So we start at the tippy top of the
trap.
Tippy top of the
trap.
And we go to the bottom of the
chin.
So where do we start?
The tippy top of the trap.
Where do we start?
Tippy top of the trap.
And we go to the
chin.
We go to where?
Bottom of the chin.
Bottom of the
Bottom
chin.
of the chin.
Okay, so let's try this again. We start where?
The tippy top of the trap.
And we go to the
bottom of the
bottom
chin.
of the chin. Okay, we're using our fingers to measure those points between the tippy top of the trap and the bottom of the chin along the side of the neck right here. Okay, now based on the amount of fingers that we have holding up against the patient's neck will determine how long we are going to extend the collar. Okay, so we can adjust the collar. These are usually adjustable. All right, now as far as numbers that we're going to see here along the side, ignore them. I've never figured out what they meant. Never. Okay, so just disregard. We use the length of our fingers to determine where we actually measure the collar. Okay, and we'll go over this more next Friday because again, it'll make more sense if I do it now. I'm just wasting time. Okay, but we'll go ahead and measure it out. We'll adjust it, and then we'll place the collar on the patient. All right. Now, as far as the C collars, okay, they do not completely restrict movement of the cervical neck. Okay, apparently they only do it by about 40%. Okay, which is less than half. It's more of a deterrent than anything to keep that patient from moving around. Okay, but these things are not made for comfort. Okay, so these patients will still inevitably be like, oh man, this thing's not comfortable for my neck after having a spinal injury and they're moving their head around like this. Okay, so we want to try to prevent that from happening, hence why the person holding onto the head has to hold the head. Okay, now once we have that collar on, we're going to go and get ready to put our patient onto the backboard by doing a log roll, rolling them over, assessing the back, and then putting them onto the board, centering the patient onto the backboard, and once they're centered, we now have to strap the patient down. Okay, and with the backboard, there's a very specific strapping order we have to follow. Okay, we essentially go from heaviest part of the body to the lightest part of the body. So, with the heaviest part of the body, the first strap goes over the chest. Okay, so the first strap goes over the patient's chest. And if I can, if the left arm is uninjured, I want to leave that arm out to check vital signs. And the reason why we preferably leave the left arm out instead of the right is because we sit on the left side of the patient in the back of an ambulance. Okay, so it's a lot easier for me to just bring this arm out and check a blood pressure and then put it back instead of me having to reach over my patient and use the right arm. But if they have an injury to the left arm, I secure it and I leave the right arm out. Okay, so chest strap goes first. And as I tighten down that strap, I want the patient to take a nice big deep breath in, because as we inhale, our chest gets bigger. Okay, and I want to have room for chest rise and fall. So I want them to inhale as big as they can, tighten at the peak of inhalation, and then have them exhale. Okay, that way they have the room for chest rise and fall. Now if I tell them to exhale, the chest is at its smallest. If I tighten down, then they can't breathe in. Okay, so you want to allow for that chest rise and fall. Now once the chest is strapped down, we go for the second heaviest part of the body, which would be the pelvis. Okay, we don't strap over soft tissue, so we don't strap over the abdomen, we don't strap over the groin, we don't strap over the breasts. Okay, we want to try to strap over something nice and secure, like the bones. Okay, so we go from chest, we go down to pelvis. After we secure the pelvis, we go for the femurs, then we secure the tib fibs, and then lastly we secure their what?
Head.
Right, then we secure their head. Okay, so use whatever mobilization device we have, secure the head, and once that patient's completely strapped and secured, then I finally go back and check CMS, which stands for
Circulation Motor Sensory.
Right, across all four extremities. Okay, and then the spinal procedure is done, get them to the hospital, right, reassess them as we transport. All right, so like I said, we'll be going over this whole procedure next week, showing you how to do it. Okay, but again, you at least need to know what the steps would be, and then we'll get the hands-on practice later. Now, as far as opening up the airway, okay, normally we would do a head tilt chin lift, but if they have a spinal injury, do I want to move their head?
No.
No. Okay, so what we're going to do is open up the airway using a position known as the modified jaw thrust. Okay, so we open up the airway for a possible spinal injury patient using the modified jaw thrust. And I don't move the patient's head. Okay, but what I do is I take their mandible and I displace it anterior, right, basically thrusting out forward to give them an underbite. Okay, so I want to take their jaw, thrust it out like this to get that tongue out of the airway to keep it open. All right, now there's a few different techniques you can use to move that jaw out. Right, it really depends on how your hands are placed on their head. Okay, but the end goal is to get that jaw thrusted out like this to give them the underbite. Now, if you really want to practice a real one on somebody, find somebody you don't like that will volunteer, because it hurts like hell. Okay, so we can take that lower jaw and thrust it out by sinking your fingers into the angle of the jaw and thrusting out like this. All right, now as we're doing that, we have to stay in that position, right? Which means that somebody else would have to come and ventilate the patient if they're not breathing properly. Okay, because we have to use two hands to do it. And as far as immobilizing the head, if we have limited resources, I'll just use my knees to hold the head as I use my hands to manipulate the airway.
Can't you hyperextend your TNJ?
We got to keep an airway open. They can fix that later. All right.
Is that the socket?
Yeah, it's the whole joint right here. Now, you shouldn't be putting enough force to pop their jaw out, right? But we do want to get that jaw thrusted out a little bit more. All right. Now, as far as strapping, okay, we'll go ahead and strap. There's different strapping orders for different protocol and stuff, but straightforward, it's chest, pelvis, femurs, tib fibs coming straight across, and then we secure the head. Vacuum mattresses are what they're using nowadays. Now, the reason why they stopped going away from backboarding everybody is because it actually caused more complications in a lot of other patients. Right? Because it's not very ergonomic and comfortable to be laid on a flat piece of plastic. So the vacuum mattress is going to conform to the patient's body shape. So it gets rid of a lot of pressure points. And because it's conforming to their body, it's going to not allow them to move around. It's just a pain in the ass to put somebody on one of these. Right? But it will provide much, much better mobilization compared to the backboard. On the backboard, we have to fill in void spaces and stuff like that. This will do it automatically. All right. As far as patients who are in a seated position, we'll be using the CAD. And again, we'll talk about this later. All right, but this will be another device we use for our patients. Let's go over standing patients as well. Now, when it comes to helmet removal, okay, if helmets have removable face masks, we leave the helmet on and I take the face mask off. Okay, because we have to get to the airway because airway is
king.
Okay, so again, football helmets rather, they have a face mask that's removable. Go and pop it off. We get access to the airway, we're good to go. Okay, hockey helmets, again, removable face mask, leave the helmet on, face mask comes off. But if you have helmets that don't have removable face masks, like a dirt bike helmet or motorcycle helmet, okay, then the entire helmet has to come off. If our patients are in cardiac arrest, regardless if they have a removable face mask or not, helmet has to come off. Now, if we do take off the helmet completely, okay, we have to splint in position found, which would be one of our rules of splinting we'll cover in the next chapter. Now, let's say the helmet has an inch of padding between the back of the head and the outside of the shell. Therefore, our patient's head is elevated an inch off the floor. When I take that helmet off, can I just put their head on the floor?
No.
No. Okay, we have to find padding that's an inch thick to place it underneath the head to keep that head in the position it was in while it was in the helmet. All right, and that's why if we can, we'll just leave the helmet in place. All right, leave it on, face mask comes off, we're good to go. And we can just secure the helmet to the backboard or anything like that, that's fine. All right, but if we got to take it off, then we have to pad it with whatever position we got. Now, as far as removal of the helmet, okay, it's a very, very, very delicate, very risky procedure. Okay, that's what we only do it if we absolutely have to do it. Okay, now usually the person with the most experience will be the one to take off the helmet. Right, because again, it's a very delicate, very precise procedure that we have to do. Okay, I don't want to pull traction where I hyperextend the cervical spine, but I also don't want to flex the head as I'm trying to bring this thing out. Okay, so it's a very slow, very deliberate movement as we're removing the helmet. Okay, it's obviously a two-person skill, so one person has to try to hold that head as best they possibly can, while another one actually takes the helmet off. All right, and again, once the helmet's off, we got to pad in that void space with whatever we have, and then we continue our assessment from there. All right, so moving on to musculoskeletal. So we're going to go over our basic traumatic injuries, fractures, dislocations, sprains, strains, things like that, and cover a little bit of soft tissue injuries that are at the very end that you will completely forget by Monday. I can guarantee you that. Okay, but when it comes to the skeletal system, right, it provides structure for the body, provides protection.
31.
Yeah, 31. All right, provides protection for vital organs, okay, and allows as attachment points for connective tissue. Okay, bones also produce blood, so they do have some blood inside of them. And when they break, they're very sharp, so they can start cutting up tissue on the inside, causing more bleeding. So when it comes to our muscle, for right now, we're just going to talk about skeletal muscle for the purpose of this chapter. Okay, because we usually don't generally damage cardiac muscle or smooth muscle. All right, but we do have other connective tissue, such as tendons and ligaments, things you guys will mix up all of the time. Okay, and they're different. Tendons will connect muscle to bone, and ligaments will connect bone to bone. Okay, so tendons will connect muscle to bone, and ligaments will connect bone to bone. And this is just one of those things you just have to memorize. One of the few things in class where just straight up rote memorization is all you got. All right, and with a 50-50 chance, you guys will forget it about half the time. All right, so again, our tendons will connect muscle to bone, whereas the ligaments will connect bone to bone. Okay, if we have injury of these different connective tissue, right, it leads to another injury that you guys forget with another one that sounds the same, that being sprains and strains. So a sprain is a joint injury with tearing of connective tissue, being a tendon or ligament, whereas a strain is a stretching or tearing of a muscle. Okay, so sprains are joint injuries with connective tissue injury, be it tendons or ligaments, whereas a strain is stretching or tearing of a muscle.
So when people say like, "Oh, I sprained my thumb," they strain their thumb.
Well,
It's pulled back too much.
depends. They could sprain their joint right here on the thumb, right? Usually it's you sprained your ankle, right? But you could strain your bicep. Right? Now, as far as treatments of a sprain or a strain, it doesn't matter. Okay, we're going to go ahead and use RICEs, which should sound familiar to you athletes. Okay, rest, ice, compression, elevation, but now we are going to add in splinting. Okay, so rest, ice, compression, elevation, and splinting, all right, is what we are going to add in as EMS. So for rest, obviously I want that patient to keep off of the injury. So if they sprain their ankle, I don't want them to put weight on that. Okay, we'll apply ice in either ice packs or cold compresses to help alleviate some swelling. Compression will also help alleviate a little bit of swelling, as will elevation. We kind of have the general theme of RICEs there. Okay, so if we can, if it's safe to do so, I want that injured extremity to be above the level of the heart if possible. So if they do have a sprained ankle or any type of musculoskeletal injury, right, if I can, I want to try to keep that leg elevated above the heart to help reduce swelling. And we're going to add in splinting to help minimize further damage.
So in between sprain and strain, where does twisting come in?
It has to do with what is actually being damaged. So with most twisting motions, it's usually going to be classified as connective injury. All right, but if they were to like twist something weird, and then they could strain their bicep, tear that out. All right. So as far as trauma, again, trauma is very what?
Straightforward.
Straightforward, right? So we have fractures and dislocations, right? And it's very binary. You either break a bone or you dislocate a joint. And with that, we either have deformed injuries or non-deformed injuries. We have open fractures or closed fractures. Okay, so it goes either way. But treatment is going to be the same. We follow our basic RICEs. Okay, especially when it comes to splinting. All right, now in the case of an open or compound fracture, because there's bleeding, what do we take care of first? The broken bone or the bleeding?
Bleeding.
The bleeding, because do broken bones kill people?
Yes.
But does bleeding kill people?
Yes.
Yes. Okay, so we want to take care of the bleed first, and then we'll take care of the fracture secondary. All right, so as far as different types of MOI, we have a direct flow and indirect force. Right, so here we have an example of somebody sitting way too close to the dashboard, right, moving forward, okay, hitting their knees against that, and then energy is going to be transferring through the femur and potentially breaking the head of the femur or dislocating their hip. Okay, so you sit the hell back and you never have your feet up on the dashboard. Okay, we have twisting forces, right, so skiers is very common, or anyone else who gets their foot stuck in a hole and they twist out that way, so that causes spiral fractures. Okay, we have high energy impacts, which will just basically shatter bones. Okay, and again, when bones break, they're razor sharp. Okay, which means they'll start cutting up a lot of stuff on the inside. So with fractures, again, binary. They're either open or closed, displaced or non-displaced. So with an open fracture, we call those compound. What do we call them?
Compound.
Right, we call them compound fractures. So that's where the bone breaks through the skin. If it's not compound, we just call it closed. As far as displaced, that can be interchanged with deformed. So here we have a closed, displaced fracture, or a displaced, closed fracture. You can interchange them if you want. Okay, but we can see that there's deformity to the leg. It's curved in the way it's not supposed to be, but there's no bone sticking out. All right, now when it comes to splinting, we like to say that splinting is arts and crafts. Splinting is what?
Arts and crafts.
All right, arts and crafts. Okay, because we use whatever we have available to us to craft a splint, as long as we don't violate the 4 rules of splinting that we'll talk about. Again, 4 being the magic number in this class. All right. So we'll go over the various fractures in just a second. Not worry about writing all of them down. Okay, but here we have a green stick fracture, common in pediatric patients because kids are freaks. Okay, the reason why they're freaky in this sense is because they don't really have fully solidified bones just yet. Okay, their bones are relatively flexible because they may have a certain amount of cartilage content. So when they break, Okay, they don't snap like ours do. Okay, they'll crack a little bit, they may deform a little bit, but they don't go all the way through. While our bones are relatively strong, they're also fairly brittle. Okay, so when they do break, they break. All right, but with these kids, they crack a little bit. We also call them green stick fractures, as well as incomplete. And the reason why we call them green stick is because if you ever try to break a twig that you just took off a tree, you can't really snap it in half. It'll break, it'll bend, but it doesn't snap in half like a dead twig would. That's why they call them green sticks. With a, you can never pronounce this word, comminuted. This is one of those words I can't say. Basically, it's a shattered bone. Okay, and with that, again, we got to worry about these bone fragments being razor sharp, cutting up a lot of tissue inside the body. Now here we have somebody who owed the mob some money and got their kneecap shattered. Okay, and with that, right, we have all these different bone fragments of the patella that can cut up all the connective tissue inside the knee. Okay, not to mention we have a blood vessel running the back of the knee, okay, that's going to go ahead and perfuse the rest of the leg. Okay, so we have to worry about bone fragments getting stuck in the joint, causing damage to the meniscus, right? All the other connective tissue in there, again, potentially, depending on how bad it is, coming around and cutting that artery in the back as well. Okay, and that can happen to any type of bone. It just depends on the amount of force that's there. With pathologic fractures, okay, these are fractures that don't have an MOI. Okay, so these pathologic fractures do not have a mechanism of injury. Okay, these are going to be seen in patients who have pretty severe osteoporosis, which means it's generally in what kind of patient? Geriatrics. Okay, these old people are the ones who are likely to have pathologic fractures. Hip fractures, super common in geriatrics, usually because of pathologic fractures. Okay, their bones can be so brittle that it can no longer support their own weight. So you could have grandma walking down the street and her hip goes out, right, and then she falls. Okay, and one of the questions we have to ask is, did your hip pain come on before you fell or after you fell? Because if her hip broke before she fell, she's going to have pain and then causing her to fall down. But if the pain came on after she fell, then we suspect that fracture came on because of the impact on the ground. Okay, but that's one of our questions we want to ask for any type of traumatic injury for a geriatric, especially if it's a hip injury. Did your pain come on before you fell or after you fell?
Are they able to tell?
Sometimes. Sometimes it may happen so quick they don't know. They're like, I don't know. But sometimes they'll be like, yeah, no, I felt a sharp pain right before I fell, or I took a couple steps and then I fell. All right, with epiphyseal fractures, these are fractures along the growth plate of a bone, which will be either on the proximal or distal end. Okay, but if we have a fracture that goes through there and it's not treated with surgery, that bone is not going to grow. So it's going to stunt the development of that extremity. All right, so if this person were to break their arm at 9 years old, right, and it goes through the growth plate, that arm is going to stay that same size while the rest of their body will develop. So that we can't really identify. We just have pain, right, to the distal or proximal portion of a bone, and we splint it up. They have to fix that with surgery. With spiral fractures, okay, that's where you get that twisting force, and that bone will break in a spiral pattern. And again, when bones break, they're really what?
Sharp.
They're really sharp. And you can see that, right, with this type of fracture. Okay, so those bone ends are just cutting up whatever tissue is inside of there, causing even more bleeding. Okay, so you got to be really careful about stabilizing that. A lot of these spiral fractures do tend to become compound because they're basically knives that are going to be coming out to the patient's extremity. Okay, and again, we really have to be careful. It's not super common, but we really have to be careful of not cutting ourselves with their bones. Right, so don't be like, ooh, touch it, right? But we do want to be careful in handling that. All right, with a transverse fracture, okay, this is going to be a clean break right through the bone. And these are going to be one of the fractures that require, you know, pins and rods and screws and all that kind of stuff to stabilize the bones. All right, when the bones completely break, all right, that'll be transverse. And sometimes you may have bone fragments that will start to overlap each other, okay, depending on what type of injury it is. Now, as far as signs and symptoms of fractures, okay, there may be deformity, depending on the fracture, but it's not always the case. Okay, especially if it's like a hairline fracture or anything like that, there's no deformity to the bone. Okay, there may be guarding. So guarding is basically the patient protecting that point of injury. We don't really mention guarding in the abdomen because guarding can be found anywhere where there's pain. Right, so that's why, again, you may have heard it in other medical classes or other medical terms, oh, there's guarding of the abdomen. Right, I don't really stress that because everything hurts, they're going to guard. All right, swelling, some bruising, crepitus, which is going to be the bones in this case rubbing against each other. So we'll get that grating kind of feeling, right? But we'll also hear the bones rubbing up against each other. Okay, false motion. False motion is a joint where there shouldn't be a joint. Okay, so false motion is a joint where there shouldn't be a joint. So for example, if they have a fracture going through their forearm and they have a second elbow in the middle of their forearm, that's false motion. There may be exposed fragments, locked joints, and apparently pain for fractures. I would have never guessed that broken bones hurt. Right? But there may be some pain as well. All right. Now, as far as splinting, again, we want to try to splint to mobilize the injury to keep things from getting worse, right? And sometimes provides a little bit of comfort and pain relief for the patient. Not much, but it will help a little bit. So, for bleeding, obviously we want to take care of the bleeding first because bleeding kills patients. Broken bones don't. Okay, so we take care of the bleeds in the primary assessment. Once we do that, then we can take care of the splinting in the secondary assessment. Okay, because we never, ever, ever splint in the primary, we always, always, always splint in the
secondary.
Okay, and like I was saying, it's arts and crafts as long as we follow the rules of splinting. So splinting is arts and crafts as long as you follow your rules of splinting. These are your rules of splinting. Okay, so there are 4 rules of splinting. Again, 4 being the magic number in this class. Okay, the first rule of splinting, and the one that you guys will probably screw up, is checking CMS before and after we apply a splint. Okay, so we check CMS before and after we apply a splint. CMS, of course, standing for
circulation motor sensory.
What is it?
Circulation motor sensory.
All right, circulation motor sensory. Okay, so before I put on the splint, I want to make sure that we have baseline CMS, or lack thereof, right? So I want to check for pulses, just to make sure they have a pulse distal to the injury. I'll ask them to wiggle their fingers or their toes, depending on the extremity that's injured. And I'll ask them what finger or what toe are we touching, again, depending on the extremity that's injured. Okay, I do that before to make sure that everything's good to go. And then I do it after to make sure that we didn't compromise it during the move. Okay, so I check it before and I check it after. I can check it during, that's fine, but it won't count. We got to do it before we put the splint on, and I got to do it after I put the splint on at a minimum. Okay, rule number 2 is we almost always, what do we do?
Almost always.
What do we do?
Almost always.
Right, keyword is almost, hence why it is bold, underlined, italicized. Okay, almost always splint in position found, unless the patient has an angulated fracture with no distal CMS. Okay, so we almost always splint it in the position found. The only time I don't splint it as is if they have an angulated fracture with no distal CMS. So if I were to walk up to a patient and they've got this weird funky forearm fracture that's out at 45 degrees, the first thing I do is what?
CMS.
What is it?
CMS.
All right, we check CMS. All right, so we check for a pulse. Okay, cool, they got a pulse. Can you wiggle your fingers? All right, what finger's that? Oh, that's my pinky. Okay, cool, they got CMS. So I splint in position found. So I have to craft a splint to hold that arm at that weird funky 45-degree angle because we splint to position found. Now, if I were to check CMS and they don't have a pulse, can you wiggle your fingers? No. What finger is that? Okay, if they don't have intact CMS, an angulated fracture, okay, we get to move it. And we get to move it back into anatomical position. Okay, which means I get to take that arm and bring it back, and then we splint it as is, regardless if I get CMS back or not. Now, if I meet a lot of resistance as I'm trying to bring that back into anatomical position, then we just leave it as is. Okay, but generally, if I can pull a little bit of traction and then bring it back to alignment, then we can do so. And we only do that if they don't have what?
CMS.
Where?
At the point of injury?
Not the point of injury, distal to the injury. Okay. Third rule is the splint must extend past the 2 nearest uninjured. Keyword is uninjured. Again, the keyword is
uninjured.
Hence why it's underlined. Okay. Splint has to extend past the 2 nearest uninjured joints that are proximal and distal to the injury. Okay, So the splint must extend past the two nearest uninjured, keyword being
Uninjured.
joints proximal and distal to the injury. Okay, so using that forearm fracture as an example. Okay, as long as my elbow and wrist are not injured, okay, I can go ahead and make sure my splint goes past those two joints to lock that part in place. Okay, again, what I'm trying to prevent there is false motion, which is a joint where there shouldn't be
A joint.
Okay, if my splint were to just go right there, it's not going to mobilize anything. Okay, it's got to go past the two nearest uninjured joints to make sure that thing can't start flopping around. Now, let's say I have a forearm fracture and an elbow dislocation. Can my splint go past the elbow?
No. Oh, yes.
No, because the elbow is dislocated, therefore it is not uninjured. Okay, which means I have to make sure the splint goes past my shoulder. Okay, which means I now have to craft an entire splint, right, that goes through the entire length of my arm. Okay, it's got to go past the wrist because that's a distal uninjured joint. Okay, the elbow doesn't work anymore because it's injured. Therefore, we now have to go up to the elbow because that would be the nearest uninjured joint.
What if it's on the wrist?
If it's on the wrist, then we just go ahead and secure right around here. Right? If the wrist is injured, then we go all the way up to the hands. We just go all the way to here. All right, we do modify it a little bit for dislocations. Okay, but we'll just keep it for bone or with fractures for right now. All right, and then lastly, we do not taper strap over injuries or any uninjured, keyword being uninjured joints. Okay, so we don't taper strap over injuries or any uninjured joints, keyword again being uninjured. Okay, the reason why I don't want to taper strap over injuries or uninjured joints, if I strap over an injury, is that going to feel good? No, it's going to hurt. Okay, and if I were to strap over any uninjured joints, especially hinge joints like the elbow, okay, I could hyperextend that joint. Is that going to feel good? No. Could that compromise CMS?
Yes.
Maybe. Right? We don't want to do that. Okay, now if I have to move that extremity for whatever reason, if I strap over a joint, I may not be able to move it. Okay, so you also want to leave those things clear just in case I have to reposition the splint for whatever reason. Okay, now as long as we follow these 4 rules, splinting is just what?
Arts and crafts.
This is what?
Arts and crafts.
This is what?
Arts and crafts.
Right, so we can use whatever we have available to us to craft a splint. Okay, now the splints that we have here in this class for our rigid conforming splints, okay, we have these guys here. Basically, it's a like 1x3 piece of wood with some foam and plastic around it, and we have these straps that we're going to tie together. Okay, there's a little bit of padding that'll go up against the patient, but this is enough to conform and splint an extremity. Right, we have shorter ones for the arms. Right, but also in the field, okay, a lot of times companies will use cardboard splints because it's fairly rigid, right? There will be some padding in there to make it a little bit more comfortable. It's cheap, so the companies love that. And we like it because it's modular. Okay, I can cut cardboard to make it shorter. I can cut it so it can bend, or I can tape more cardboard to make it longer. Okay, so we can use whatever we got available to us to craft a splint. And there's other things we'll talk about too where we can improvise certain types of splints. So, as far as dislocations, right, we cannot pop any joints back in place with one exception. Okay, so we can't go popping joints back into place with one exception. And it's not what you think it is. Okay, so if there's a patient with a dislocated joint, we simply splint it as it is. All right. Now, with dislocations, we usually are going to see some form of deformity. So here we have a dislocated finger. So again, it looks different. Okay, dislocated elbows will look different. Dislocated shoulders will look different. Kneecaps, knees, all that kind of stuff. Okay, there usually is going to be some deformity with dislocation. There'll be loss of motion, so it may be a locked joint. Obviously, pain and tenderness, some swelling. Okay, it's more obvious to note dislocations than it is for fractures. All right. Now, as far as dislocations of the shoulder, okay, pretty common dislocated joint. Right, it can dislocate in a few different ways. It can dislocate posterior, which means that shoulder is going backwards. It can be dislocated anterior, which means it's going forward, or it can be dislocated laterally, which means it's going
to the side.
Okay, so any which way that shoulder can get popped out the socket will lead to different dislocations. Regardless of where that shoulder goes, we use the same treatment. Okay, we use a sling and swath. Okay, so for any type of shoulder dislocation, we use a sling and swath. Again, that is a sling and swath. It's a what?
Sling and swath.
A swinging sloth?
Sling and swath.
Right. Okay, it is a sling and a swath. Now the sling is the cradle for the arm. The swath is what comes around and holds the arm against the body. Now we can use the sling and swath for any type of shoulder girdle injury. Shoulder dislocations, obviously a shoulder girdle injury. Clavicle fracture, right, is going to be a shoulder girdle injury. Scapula fracture, shoulder girdle injury. AC dislocation, shoulder girdle injury. Okay, so anything affecting this region right here, we're going to treat using a
shoulder girdle injury. Or what?
Sling and swath.
Sling and swath.
God, you guys' brain shut down right at 11 o'clock. Okay, so here we have an example of one, right? So we can see the arm cradled in a sling, and he's tying off the swath right there. Now, as far as padding, okay, we only put padding if the arm is held away from the body. Again, our rule of splinting is we almost always splint position found unless it's a negative fracture, no distal CMS. So if I find a patient whose arm is pressed against their chest like this, do I take their arm and be like, oh, excuse me, sir, and do that? No. Okay, we keep it pressed against the body. Now, if I find their arms out like this, can I go, all right, and bring it in? No, because we splint in position found. So if they have their arm out like this, then we can take pillows or whatever we have, because it's arts and crafts, and fill in the void space as we create that sling and swath. Okay, and again, just if they find their arm up like this, which we usually will see with shoulder dislocations, we leave it pressed up against the chest. Okay, and we'll have to very carefully and delicately bring that triangle bandage to create the sling between their arm and their chest. Question?
Oh, but what if it's posterior? Is it still going to be like...
It's however they find it.
Oh,
Yeah. So for the posterior dislocation, they may have it pressed out like this, so they may keep it kind of pressed up against their body like so. All right, but we'll go and splint it as is. Now, as far as clavicle fractures, okay, usually like to take a poll of my classes. Right? Since the clavicle is the most commonly broken bone in the body, show of hands, who has broken their collarbone before?
Oh, yeah.
2 classes in a row. Wow. Bunch of friggin' nerds that are coming to this class. Okay?
Lots of milk.
That's a lot of not doing anything. Okay? So, right, as far as clavicle fractures, right, it is generally the most commonly broken bone in the body. And it's funny, like pre-pandemic, like half the class would be like, yeah, I broke my collarbone.
Did you break yours?
No. But I dislocated my AC and I broke my scapula. So I did something worse. Okay? So, as far as the clavicle fracture, okay, it's a shoulder girdle injury, so we treat it with a sling and swath. All right? Now, as far as AC separation, again, this I have, okay, that's where the clavicle and the scapula joint comes dislocated. So there's connective tissue right here, okay, that with most clavicle fractures does also happen. Okay, and that's going to leave a deformity that we see right there that you maybe can kind of sort of see through my shirt. Okay, so that's a common way of telling a patient has some type of clavicle injury, right? As far as scapula injuries, right, they're pretty difficult to get, yet I still managed to get one where I broke my scapula right here, right across the posterior body of the scapula. Right? That was a dirt bike accident, also got a concussion with that too, and haven't been on a bike since. But as far as humerus fractures, okay, we can also use a sling and swath. Right? Now, as far as the padded board splint, it's not really so much for immobilization, right, as it is just to kind of help support that tension on the sling and swath. Okay, but we're using that to just hold it in place. Okay, so again, anything affecting this region right here, we treat using a sling and swath. As far as elbow dislocations, okay, this is the joint we can actually pop back in place. Okay, so we can't pop shoulders back in. Even though I also dislocated my shoulder in the same injury, I still pop it back in. We're not supposed to, right? But, okay, we can pop elbows back into place. Now, do you think we can do that here in LA?
No.
No. Okay, LA kind of barely even lets us look at these patients, okay, let alone pop their elbows back into place, right? But per DOT, okay, and other protocol, we may be able to pop these elbows back in, right? But other than that, we simply splint in position found. Okay, so for this guy here, if we were to walk up and he's like, yeah, my elbow's dislocated, okay, well then we got to craft a splint to keep that arm like that, right? So I can't bring that arm and be like, all right, and just move it back down. Okay, we got to splint it however it's found. If it's out like this, then again, we got to splint it out like that. All right. Now, as far as fractures of the forearm, it's your basic rules of splinting. So just use a Riddick conforming splint, follow your rules, and that's it. Nothing really special here. Okay, there are other splints we can use besides rigid splints. It's still technically a form of rigid splint, but these are nice for certain types of fractures. So this is a pliable splint. We call it a SAM splint. It's the name, I don't know what SAM stands for. Right, but we go ahead and extend it out. Okay, and these are really nice because they are pretty flexible and they will bend to shape. This thing's pretty beat up, so it is pretty flexible. Right, but for example, if I needed to craft a forearm splint, I can fold it in half like this. Okay, with this and most other forearm injuries, we want to keep our patient in what's known as a position of function. Position of what?
Function.
Which pretty much means I have their hand grasping onto something. Now the benefit of a SAM splint is I can curl an end over like this. That way when their hand is resting in it, it's grabbing onto that, keeping it in position of
function.
Right? And then we can fold these sides in. Something like this, just a rough splint fold for right now, where it creates a little nook for the arm. We can fold this in a little bit more if I had more time to create around the wrist. And then I just wrap around, right? I can extend it out a little bit more too if I wanted to. So fold it out like so. That way it can come up and go past the elbow to make sure we're mobilizing past the uninjured joint, distal to the injury, or proximal to the injury in this case. Okay, we don't really have these, right? But if you guys want to make your own first aid kits or trauma kits, these are really nice to have, right? Because we can fold it up, keep it relatively compact, and we don't have to worry about a big old piece of wood or anything like that. A little pricey, but all first aid stuff is. As far as wrist injuries, distal wrist injuries, we call this Call's fracture, also known as a silver fork fracture, because the wrist kind of does that curvature like a fork. Basic rules of splinting, nothing special there. So there we have that position of function. So if we don't have the padded board splint, or the SAM splint, we just have the patient grab onto something round. So a piece of gauze, a piece of ace bandage, a soda can or beer can, whatever they have that's big enough to fit around their hand. Because the reason why we want it in their hand like this is because if they lose motor function, at least their hand is stuck like this, so they might be able to do that at the very least, right? Or they can open up doors. Okay, that's why when people get hands replaced, it's hooks, not just rods, right? Because if their hand's out like that, all they're good for is smacking people, and that's it. For asking, why is your hand like that, right? So we want to make sure we keep their hand in a position of function, like so, all right? As far as pelvic injuries, again, they can lose up to 2 liters of blood. How much blood do we have in our body?
5 to 6.
5 to 6 liters on average, right? So 2 liters of blood loss is a shit ton of blood, right? That can kill somebody. Okay. Now again, that's just the pelvic fracture itself, not including the descending aorta, the iliac arteries, the iliac veins, or the inferior vena cava coming back up. Because if those get ruptured, well, then it's even more blood that patient's going to start to lose inside of their pelvis. Now, one sign of a possible pelvic fracture is hematuria. So whenever you see hema or hemo, what does that mean? Blood. Okay, urea refers to urine. So hematuria is blood in the urine. Now, patients who are pissing blood by itself doesn't mean anything to me. Just like JVD by itself doesn't mean anything, delayed cap refill by itself doesn't mean anything. We see with other signs and symptoms, then that tells us what's happening. Okay, for example, patients having kidney stones, could they have hematuria?
Yes.
Yeah, right? So the fact they're peeing blood and they got really sharp, ripping, tearing pain down their back indicates kidney stones. Patients who are, urinating blood with MOI of pelvic injury tells me they have a possible pelvic injury and it's ruptured the bladder, causing them to pee blood. Okay, so we got to think about hematuria plus other signs and symptoms may indicate specific types of injuries or illnesses. Usually it's illness, but again, can happen from trauma as well. Now, as far as stabilizing pelvic fractures, it's on the next slide. Yeah, we can use. They used to use the pneumatic anti-shock garments, but like we talked about earlier with shock, okay, this did what to a lot of patients? Killed them, right? Because of all that dirty, nasty, acidotic blood coming back from the legs back into the core, and all that other clean blood going away from the vital organs. So again, they said, let's use it for pelvic injuries. You're doing the exact same thing. Just, it's a different thing we're using it for. All right, so they stopped using that. They opted for commercial pelvic splints, which are okay. Basically, it's a giant band that goes around the patient's pelvis to tie and stabilize that pelvis. And if we don't have this, for whatever reason, RC crafts. Okay, we craft what's known as a sheet splint. Not a what?
Sheath splint.
Not a shit splint, but a
sheet.
Right, sheet splint. Okay, where we go and take a bed sheet, fold it up to about a 6-inch strap or so, use pillows on the side of the hips to help stabilize, and we tie it to hold it in place. All right, so we go and use that to stabilize the pelvis to prevent any further injury. Now, as far as moving patients, we don't want to roll them if they have pelvic injuries. Okay, instead we're going to use a special piece of equipment known as a scoop stretcher. I believe we'll see on the next slide. Now, as far as hip dislocations, okay, hip dislocation is not the same as a hip fracture. Okay, hip dislocations are not the same as hip fractures. Okay, hip dislocations are when the head of the femur gets popped out of the socket on the pelvis. Okay, it takes a lot of force to do that, and usually we will have hip fractures occur where the head of the femur detaches from the body of the femur itself. Okay, so technically hip fractures are more proximal femur fractures than an actual hip injury itself. All right, now we have anterior and posterior hip dislocations, and it has to do with where that hip is going after it gets hit. Okay, so if it's a posterior dislocation, that hip gets knocked backwards, okay, and that causes an internal rotation of the leg. So as it goes back, that leg gets sucked inward. If we have an anterior dislocation, that hip gets knocked forward, and we have an external rotation of the leg. Those are really good stretches. All right, so we're going to have the legs going side to side, okay, and we just splint it however we can. So fill in the void space, put them on a backboard, or use the scoop stretcher, okay, where we quite literally break that thing in half and scoop the patient up and then put them onto a backboard. That way we don't have to roll them and put their body weight onto the pelvis. All right, here they're doing what's known as an anatomical splint, okay, where they're taking our padded board splint, running it between the middle of the legs, and then using the uninjured leg as a splint to help stabilize as well. Okay, so again, for those who play basketball or any other type of ball sport with possible finger injuries, it's basically the same thing as buddy taping your fingers. Okay, so putting a splint between the middle and taping it together, crafting an anatomical splint. We're doing the same thing with their legs. All right, as far as femur fractures, okay, with femur fractures, again, we can lose up to 1.5 liters of blood. Okay, and that's more than enough to put your patient in shock. Generally, anything over 500 mLs of blood loss is enough to put people in shock. Okay, so a pelvic fracture is 4 times the amount needed to go into shock, whereas a femur fracture is 3 times the amount of blood needed to go into shock. All right, now we have proximal femur fractures that will happen up here by the hip. We have distal femur fractures that happen by the knee, but we also have mid-shaft femur fractures. Okay, now with some femur fractures, they may be compound, where the bone will be protruding through the skin. Okay, but usually we see that when there's a break all the way through, like a transverse fracture of the femur. Okay, now with these femur fractures, even if it's a transverse closed femur fracture, okay, the bones will overlap over each other. And when the bones overlap, what happens to the length of that leg? They get shorter. Okay, so we're going to see shortening the leg, and usually we see rotation, either internal or external, just depends on the patient. Okay, but that foot will be twisted to one side, right, with shortening of the leg. Now, if we have a patient who has an isolated mid-shaft femur fracture, again, patients who have an isolated mid-shaft femur fracture, okay, that is the indication for a very special type of splint called a traction splint. There are 2 types of traction splints. I'll go over one of them right now, and we'll see the other one next Friday. Okay, but we're going to use a traction splint for somebody who has an isolated mid-shaft femur fracture. Okay, now as far as what that means, first off, isolated. Isolated means the only injury to that leg. Okay, so isolated means it's the only injury to that leg. And as far as knowing if it's the only injury to that leg, how would I know? Sorry? What do you mean by a body assessment? Looking isn't going to tell me unless I have x-ray powers. Palpate. What do you do?
Palpate.
What do you do?
Palpate.
Right. And when I go over the injury, what are they going to say?
Ow.
Ow. Okay. So if they only say ow here and nowhere else, including the pelvis, okay, then we know it's an isolated injury. Now, as far as mid-shaft, that means right in the middle of the femur. Okay. That's not proximal. That's not distal. It's what?
Mid-shaft.
Mid-shaft. Okay. So an isolated mid-shaft femur fracture means it's the only injury on their leg to the middle of their femur. Okay? Now, if they say ow down here, can I use a tracting splint? Because it's not what?
Mid-shaft.
It's not mid-shaft. What if they say ow here and ow here? Can I use tracting splint?
Yes.
No.
No. Why not?
It's not the only injury.
It's not the only injury, right? It's not isolated. Okay? So we got to palpate to make sure there's no other injuries to that leg, including the pelvis. Now, what if they have bilateral mid-shaft femur fractures? Can I use a tracting splint?
Yes.
Yes. Right? They're really fucked, but yeah, I can use a tracting splint. Okay, if they have bilateral mid-shaft femur fractures, that's fine. Okay, just hope and pray the patient's not going to die, because again, that's 3 liters of blood loss from 2 different femur fractures. Okay, so we have to know the indications for it. Now, as far as what these tracting splints do, okay, kind of barbaric, but they really work. This part is going to get anchored to the patient's thigh, right around here. This part is going to anchor down to the ankle, and as I pull, right, it's going to create tension and essentially take the bone end and start doing this until they line back up. Okay. Now again, with most femur fractures, the muscles in the leg, right, the quads and the hamstrings, okay, they're going to cause the muscles to spasm and the bones to overlap like that. So with traction, I want to try to pull them so they line back up and bring the bone ends together like this. By doing so, we're going to minimize bleeding. There still will be some blood loss, but it's not going to be nearly as much. And it's going to cause some pain relief. Okay, so it actually makes the patient feel a little bit better. But you have to ensure that you're pulling constant traction once you started. Okay, because the muscles are still under spasm. Okay, and if we lose traction for whatever reason, if I'm pulling manual traction, or we put this on incorrectly and it slips, those bone fragments do that. Okay, yeah, makes it a lot worse, and it's going to hurt like hell. And do you think that patient's going to be happy with you? No, because they will call you and your mom names you've never heard before if their bones go back like this. Okay, so you need to make sure that we're pulling constant traction. Now again, there's 2 different types of tracting splints. This one is called the unipolar tracting splint because we have one pole that goes down the length of it. Okay, the brand name for this is a Sager. Okay, so Sager is the brand name. The generic name will be unipolar. Right, we have a bipolar splint because it's crazy, but because there are 2 poles that go down the length of that splint. Okay, and the brand name for that is the Hare, H-A-R-E, like the rabbit. Okay, it's a hair splint. That's the bipolar splint, which has 2 poles. Okay, they both do the same job, just a little bit different. And like I said, we'll train you on how to use these next Sunday. Okay, but do you need to know the indications for these for tracting splint?
Yes.
Yeah, because if I pull traction on an injury that's not an isolated mid-shaft femur fracture, okay, I'm going to make that problem a hell of a lot worse. So let's say we do have that patient who's got an injury here and an injury here, and they're both transverse fractures that go all the way through the bone. As I pull traction, that middle segment is going to flop to the floor. Okay, it's not going to be supported because we're pulling traction on both ends, separating it, and it's going to cause more injury. Okay, so you want to make sure that it is truly an isolated mid-shaft femur fracture. Now, as far as knee injuries, okay, this splint right here, is this proper?
Yeah.
No. Okay, it's not because this person must have x-ray powers because we can't tell where the kneecap is. Okay, and as far as the rule of splinting, again, we do not taper strap over injuries or any uninjured joints. Yeah, sure, they could palpate and maybe find where the kneecap is, but we have to expose the area to know where we're actually placing our straps. Okay, secondly, this guy still has a shoe on. Can you check CMS through a shoe? No. Which means they violated rule number 1 of splinting, not being able to check CMS before or after splinting. Okay, so we have to expose the entire leg, right, as we're splinting. Now, it doesn't have to be taking the pants completely off, right, but we do have to at least assess the injured leg. Okay, now as far as the actual splint itself, the splint itself looks fine. I'm assuming the knee would be right there. Let's say we could get CMS, the splint itself is fine. But they're lazy because they didn't expose the actual leg. Okay, now as far as this guy right here, is this a proper splint? Yes. This is fine. Okay, he's still wearing shorts, but it's a knee injury. Can we see the knee?
Yes.
Yeah, sure, that's fine. Okay, as far as position found, is it splinted in position found?
Yeah.
Okay, because if you think about it, if he has a knee injury, is he putting all of his weight on that injury? No, right? When we walk up to him, he's probably like this. All right, hey, I hurt my knee. Okay, so when we have the patient on the gurney, we have the pillow underneath the knee to keep it in that bent position. We got the splint going through. Now, as far as the modification to that rule, okay, that I said earlier, for dislocated joints, we immobilize the uninjured bones proximal and distal to the injured joint. Okay, so in the case of the knee injury, we got to secure the femur and the tib fib, right? That way they can't bend their knee and move it around. All right. As far as dislocations of the knee, you're going to know if they dislocated their knee because their leg is going to be looking totally different. All right. As far as patella dislocations, same thing. You're going to know if they dislocated their kneecap because it's going to be shifted off to one side, either medial or lateral, depending on where it's going to get pulled. For tib fib injuries, okay, this is a very common source of compound fractures, right? Because the skin over the shin is very thin. Okay, so because of that, right, the bone, right, can go right through that very easily. Now, in the case of this type of injury, what do I do first? Bleeding control or splinting? Bleeding control. Okay, we take care of bleeding control, and then I can go back and do a splint. Now, rule number one of splinting is to check what? CMS. Right, and if I don't have CMS with an angulated fracture, what do I get to do? Bring it back to alignment. Not just pull it. Okay, I get to bring it back into alignment, right, as close as we can. Now, with this, right, this being the medial aspect of the foot where we're going to find a pulse, am I going to find a pulse in this leg?
No.
Probably not. Okay, so I'm checking the pulse. Ah, shit, I can't feel anything. I go over here. Crap, I can't feel anything. No distal CMS. Bring it back to alignment, and then we get to splint. Okay, now tomorrow we are going to show you where to find pedal pulses. Okay, so in addition to your watch that you guys need to bring tomorrow, please wash your feet. Okay, because we are going to be taking off one sock and one shoe to find those pedal pulses. Okay, if you have time, maybe get a pedicure done, right? But you guys will be taking off socks and shoes for tomorrow. Okay, so guys, make sure your nails are nice and painted. So, as far as ankle injuries, okay, it's a very commonly injured joint because it's supporting all of our weight. All right, now as far as treatment of an ankle injury, just follow your basic rules of splinting. All right, nothing terribly special there. Arts and crafts, use whatever you got. Okay, in fact, for some foot and ankle injuries, there's a very nice, comfortable splint we can use, and we'll see that in just a little bit. All right, so we are going to see some bruising to the feet eventually, right? You usually see that, especially with falls. Okay, obviously, sprained ankles, rolled ankles, things like that. So, what we can do for some foot injuries is use a pillow splint. All right, so if you've got relatively firm pillows, okay, and some sheets or something like that, we can go ahead and put two of them together, or fold one really long one around the foot, and create a splint. Okay, yeah, it's got to be firm because it's got to provide some, immobilization, but it's probably the most comfortable kind of splint that there is. All right, so we go ahead and stabilize it, and again, arts and crafts. Right, use whatever you got to make a splint, and firm pillows will make nice feet splints. As far as amputations, now we're getting to the good stuff here. Okay, as far as amputations, right? If we have a patient who has an amputated body part, what's the first thing I do?
Find it.
No, control the bleeding. Thank you. Like, oh, I know you're bleeding out, but let me go find your foot. Okay?
He wants it.
Control the bleeding. All right, because if they don't control the bleeding, they're gonna what? Die. Oh shit! I found his foot. Oh, but he's dead.
He's not going to bleed.
Okay, so we go ahead and control the bleed. Right, so we do so however we can. Okay, depending on how bad it is, we can just go maybe right to tourniquet application. But we want to try our traditional methods first for class. Direct pressure, elevate, wrap. If that doesn't work, then we go for tourniquets. Okay, now that we've taken care of bleeding on the stump, then we go ahead and address the actual amputated body part. Okay, now once you find the amputated body part, if it's dry, we keep it dry. If it's wet, we keep it wet. Okay, so because the foot is supposed to be dry, we keep it dry. So I wrap it in a dry, sterile dressing. Okay, so you wrap the amputated part in a dry, sterile dressing. And then we seal it off in an airtight bag. From there, I want to keep this amputated part cool, but don't let it freeze and do not let it get wet. Okay, so we take the amputated part, wrap it up in a dry, sterile dressing, keeping it cool without letting it freeze, without letting it get wet. If it freezes, that causes frostbite injury, which would be bad. If it gets wet, okay, the cells will start to absorb water. They get bigger, 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 and then they pop. And then we have cell death, which leads to
tissue death.
Tissue death. And that's it, because it's no longer attached to the patient. Okay, and then they can't reattach this body part, and now your patient's friend's going to call them stumpy if they survive this injury. Right? So we want to make sure that we just go ahead and wrap it up in a dry, sterile dressing, keep it cool, don't let it freeze, don't let it get wet, and then we transport it to the hospital. And even though it's foot separate from the body, I always think it has like 5 toes plus the big toe. It looks weird right here. But
I can't count how many.
yeah. All right, so we'll go ahead and take care of that. All right, and we'll talk about amputations again when we cover soft tissue injuries because this is obviously a soft tissue injury. All right, when it comes to compartment syndrome, okay, this is a large hematoma. Large what?
Hematoma.
Hematoma, okay, which is a collection of blood underneath the skin. Okay, so hematoma is just a collection of blood underneath the skin. And this collection of blood is happening underneath the fascia, or underneath the fascia within the fascial compartment. Okay, so again, we have the epidermis, the dermis, the subcutaneous layer, the fascia, and then the muscle, and then bone. So this is happening within the muscle and bone compartment of an extremity. Because there are still blood vessels in there. Right? When we have this rupture occur, we start getting all this blood spilling in that area. And what happens here is it essentially creates a tourniquet effect from the inside out. Okay, so pressure starts building up from the inside, working its way out, as opposed to going outside in. So, past the point of injury, we may have compromised CMS. Okay, so maybe compromised CMS distal to the injury. Now, as far as treatment, okay, treatment for this is going to be RICEs. Rest, ice compression, elevation, and splinting, with the exception of elevation. Okay, I want to keep this extremity level with the heart. Where do we keep it?
Level.
Right, level with the heart. The reason why is if I bring it down below the heart, okay, gravity is going to start taking blood and start moving it down to this hematoma, putting more pressure, making the problem even worse. And if I were to elevate the extremity above the heart to try to alleviate swelling, it actually kind of does the opposite, right? Because the body's going to try to send more blood out to that area, making the problem even worse. Okay, so we keep it level with the heart. Now, as far as splinting and compression, I got to be really careful because if I put too much pressure on this, there's a possibility that it can rupture and then cause bleeding. Okay, so we want it secure enough to at least hold it, but not tight enough to where I could possibly rupture this compartment syndrome, this large hematoma. We do want to apply ice to help reduce swelling. All right, and then we transport. Now, because we have a loss of possible CMS, okay, this is going to be a code 3 transport. Code 3 is used for the possible loss of life or the possible loss of limb. Okay, and if there's no distal CMS on an extremity, that could be possible loss of limb. Maybe life, it's bad. Okay, at the very least limb. Okay, so at that point we go ahead and provide transport. It takes a long time to develop, again, 6 to 12 hours. So are we going to see this in a pre-hospital setting? No. Probably not. Okay, but again, it may be seen later on in the hospital if we're doing a transfer from one area to the next. Okay, or in cases of natural disasters or very, 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 very rural areas, maybe we'll see this. All right, now as far as treatment, okay, most of our musculoskeletal injuries are not life-threatening. Okay, most of the time they're not life-threatening. So if it's just a broken leg, we can transport code 2. Okay, but if we do have some type of MY that does indicate a potential life threat, we now transport code 3. Okay, and as far as my on-scene time, again, for my critical patients, how much time do I have on scene?
10 minutes.
10 minutes or less. But for my stable patient with a broken leg, could I stay there for longer than 10 minutes?
Yes.
Yeah, I could, but should I?
No.
Nah. All right, let's just get him splinted. Let's get him to the hospital. Let's get him fixed. Okay, but I do have the time, but let's not take it. Okay? As far as splinting, we do want to try to prevent the injury from getting any worse. So again, I want to try to minimize bones from rubbing up against each other, cutting up more tissue, causing more bleeding, causing compromised distal CMS. All right, we want to get them out of here. Now, as far as complications, if I were to screw up the splint, could I compromise CMS? Yes. Okay, could I cause more bleeding? Yes. Could I cause more pain? Yes. Okay, so you want to make sure you're doing it very carefully, right, so as to not cause more issues. All right, well, none of you have broken your collarbone. Maybe some of you have broken bones. Okay, and broken bones hurt. Okay, so we want to try to minimize that pain because there's nothing I can really do for that because ALS, maybe, depending on their protocol, they can give them some pain meds. All right, now as far as transporting again, okay, if they have possible loss of limb, then we go code 3. Other than that, it's a simple code 2 call. And we're finally done. All right, so Tomorrow, again, skill day. Make sure you guys bring your patient assessment packets. Make sure you guys have run through an assessment a few times, because again, we will expect you guys to know how to run through an assessment. Bring a watch, clean your feet, and see you tomorrow.
Have a good night, man.